morning, good afternoon, and good evening to everyone joining us from around the world. Welcome to the 5th International Journal of Medical Students World Conference of Medical Student Research, the WCMSR 2026. My name is Francisco Bonilla-Escobar, and as Editor-in-Chief of the International Journal of Medical Students, it is a privilege to welcome you to the 5th edition of our conference. Reaching our 5th edition is an important milestone. The WCMSR was created to give medical students and early career researchers an international platform to present their work, receive feedback, exchange ideas, and become part of a global scientific community. This year, we received more than 200 abstract submissions from researchers around the globe. This growing interest reflects the remarkable research being conducted by medical students and early career researchers across countries, institutions, and fields of medicine. At the IJMS, we believe that medical students are not only the physicians and scientists of the future, they can also contribute meaningfully to science today. The WCMSR is an extension of that mission. And with each edition, we continue to learn, improve, and strengthen the conference. None of this will be possible without the people behind it. I want to thank our abstract managers, Kalev Karani, Sahil Arial, Sayali Kulkarni, Udesh Yoma, and Sohil Arial. Coordinating the review and selection process for more than 200 submissions required tremendous dedication, as you can imagine. Thank you for ensuring a rigorous and fair process. My thanks also go to Moses Estefanes, our director, for managing the many operational and technical components required to make a global virtual conference possible. Together with Moses, we have Dr. Camilo Agames, who will be helping with the streaming platform. I also want to thank our Masters of Ceremonies, who will guide us through the sessions and discussions over these 2 days. I want to recognize also the Executive Committee for its commitment to the success of the conference and its continued support of the organizing team. Mine Alexandru Gaman, our outgoing scientific editor, Abdul Basit Muili, our incoming scientific editor, Sajjad Ahmed Khan, our deputy director, and Pratik and Manali Sarkar, our student editor-in-chiefs. Thank you for your leadership and support. My gratitude also goes to our IJMS student editors and junior student editors who contributed to the scientific review process, and to our judges. We have an outstanding international panel of judges this year, and we deeply appreciate the time and expertise they are contributing to our presenters. I am very proud of what this international team has achieved. The WCMSR is a global, not only because of its presenters and audience, but also because of the people who organize it, review the science, and make it possible. To all our presenters, congratulations. I encourage you to use these 2 days not only to present your work, but also to ask questions, exchange ideas, and connect with other researchers. Some of the most valuable outcomes of a conference are the ideas and collaborations that been through these conversations. On behalf of the International Journal of Medical Students, thank you to the organizing team. Thank you to the Executive Committee. Thank you to reviewers. Thank you to judges, presenters, mentors, and everyone joining us from around the world. 5 editions of the WCMSR represent 5 years of learning, growth, and continue believing the importance of medical student research. Welcome to the 5th IJMS World Conference of Medical Student Research, WCMSR 2026. I hope you enjoy these 2 days of science, discussion, and collaboration. Thank you so much.
Hello, welcome everyone to the conference, and I would want to introduce myself. I am Justin Nathen Federigan, a 5th-year medical student at Huazhong University of Science and Technology, Tongji Medical College in Wuhan, China, and it's an honor to be serving as the Masters of Ceremony of this year's International Journal of Medical Students World Conference of Medical Student Research. And this year, we have actually received nearly 200 submissions from the medical students and young research worldwide. And as mentioned by our chief or editor-in-chief earlier, I would actually want to thank him for his very, very much hard work and for his dedication for this global collaboration and engagement. So following the rigorous peer review of the conference and the scoring process, the scientific committee have selected the highest scoring submissions for the podium and poster presentations. So for these 2 days, we'll be going through nearly 90 presentations and poster oral presentations, and we will be joined by medical students across Africa, Asia, Europe, North America, Latin America, and even the Caribbean, each showing their dedication, creativity, and even the passion for contributing to medical research. So in this conference, as mentioned, we have the podium and poster presentations. All the rewards and recognitions will be presented during the end of the second day. So we encourage everyone to join us until the end of the conference to witness different research strategies and even engage in international collaboration. As medical students, we are all aware that tight schedules and heavy workload are some of the main obstacles for performing research. Therefore, let us all appreciate everyone's work and contribution to medical science. Since its founding in 2009, the International Journal of Medical Students have been dedicated to support the student research from every part of the globe, serving as a platform for collaboration, mentorship, and even academic growth. This medical community encourage international collaboration and cooperation, building a future that can empower the coming generation of medical professionals. Now, before we begin, I would like to introduce the team behind our great event, and with their efforts, today's conference will not be possible. So, as the chief have already thanked, we have the abstract review committee, the conference organizing teams, judges, reviewers, and each and every individual who assisted along the way. Thank you all for your dedication and hard work. Once again, we would like to thank Dr. Bonilla-Escobar for bringing this platform into a drive of medical research and collaboration. His words earlier were quite inspiring for all of us as we continue to bring more research into the global medical science team. And actually, from last year, our submissions have reached to nearly 200 submissions compared to last year, which was around 120. And in this conference, we'll be actually looking into 90 different presentations, both for oral and for the podium. So hopefully these will be great ideas and will also inspire the new generations for that will be coming to become medical doctors in the whole world. So now let's welcome the first presenter, that is actually Dr. Ugo from BAU International University, Batumi, and hopefully we'll be hearing from him on his submission of the early post-marketing safety signals of Anifrolumab in EudraVigilance, a Belilumab comparator disproportionality analysis. So let's welcome him on board here. You have some judges that we would like to introduce. We have the judges on stage, which will be Dr. Avi Singan and Dr. Franklin Kanechukwu Okwenzi. I'm not sure if I pronounced that right. I'm so sorry. Thank you for joining us on this first presentation as well.
Good morning. My name is Urdal. I'm a final year medical student at BAU International University Batumi from Georgia, and today I will present our early post-marketing pharmacovigilance analysis of Anifrolumab using public EudraVigilance data with the title Early Post-Marketing Safety Signals of Anifrolumab in EudraVigilance, a Belimumab Comparator Disproportionality Analysis. Anifrolumab is a type 1 interferon receptor antagonist approved for adults with moderate to severe systemic lupus erythematosus, or SLE. Although clinical trials established its efficacy and expected safety profile, the public post-marketing EudraVigilance analyses remain limited. The aim of this study was to evaluate early signals of disproportionate adverse events reporting for Anifrolumab. Belimumab was used as an active comparator because it's also used in SLE and helps partially address indication-related reporting differences. Our methods: we performed a retrospective disproportionality analysis using public EudraVigilance suspected adverse drug reaction reports. Anifrolumab was the index drug and Belimumab was the comparator drug. The analysis period started on 14th of February 2022, the EU marketing authorization date of Anifrolumab, and continued through 1st of May 2026. All reports included in the analysis were spontaneous reports. Each unique case was counted once per MedDRA preferred term, or PT. This means that if the same PT appeared more than once in one case, it was not double counted. This approach helped reduce inflation of repeated reactions within the same report. Non-clinical and data quality preferred terms were excluded from the primary clinical signal analysis. ET level disproportionality was assessed using 4 methods: reporting odds ratio, proportional reporting ratio with chi-square, Bayesian information component, and MGPS style empirical Bayes geometric mean with EB05 shrinkage. A robust signal was defined as a preferred term with at least 3 Anifrolumab cases and positivity across all 4 methods. Supportive reaction group analyses were also performed using ROR, TRR with chi-square, and IC. Finally, a sensitivity analysis included only cases in which Anifrolumab was the sole suspect drug. Our study included 1,122 Anifrolumab cases and 3,585 Belimumab cases. Anifrolumab reports contained 2,734 reactions across 822 unique preferred terms, while Belimumab reports contained 13,889 reactions across 1,877 unique preferred terms. Anifrolumab cases were predominantly female, with a 931 out of 1,122 cases, or 83%. Most reports were submitted by healthcare professionals with 998 reports, or 89%. The most commonly reported PTs for Anifrolumab included herpes zoster, arthralgia, off-label use, systemic lupus erythematosus, fatigue, rash, headache, COVID-19, lupus nephritis, pyrexia, urticaria, nausea, pneumonia, dyspnea, and drug ineffective. Our primary disproportionality results. So after excluding 13 non-clinical or data quality terms, 2,105 clinical preferred terms were evaluated. Herpes zoster was the only robust signal of disproportionate reporting. It was reported in 84 Anifrolumab cases and 42 Belimumab cases. The disproportionality measures were consistent across all 4 methods. The reporting odds ratio was 6.78 with a 95% confidence interval from 4.66 to 9.87. The proportional reporting ratio was 6.35 with a chi-square value of 130.81. The IC025 was 1.31 and EBGM was 2.56 with an EB05 of 2.14. These results show a stable and concordant herpes zoster signal for Anifrolumab compared with Belimumab. In addition to herpes zoster, 48 candidate signals were positive in at least 2 methods, but they did not meet the full quadruple definition. These included hypersensitivity-related terms, respiratory infection terms, infusion reaction terms, herpes virus-related terms, and SLE activity-related terms. In the supportive reaction group analysis, herpes virus and zoster reactions showed the strongest disproportionality. Other groups, such as hypersensitivity or labeled respiratory infections, showed weaker or less consistent findings. Some SLE activity-related terms may reflect the underlying disease itself rather than a direct drug effect. So these findings require a cautious interpretation. Sensitivity analysis and practical meaning. The sole purpose sensitivity analysis included 1,040 Anifrolumab cases out of the original 1,122 cases. In this analysis, herpes zoster remained the only robust signal. It included 80 cases with an ROR of 6.99, IC025 of 1.36, EBGM of 2.66, and EB05 of 2.21. The practical meaning is that the clinicians should continue paying attention to herpes zoster risk in patients treated with Anifrolumab. This is especially relevant because SLE patients may already have immune dysregulation, comorbidities, or concomitant immunosuppressive therapy. These findings support careful clinical monitoring and awareness, but they should not be interpreted as proof that Anifrolumab directly caused herpes zoster in every reported case. Our interpretations, limitations. The main strength of this study is that it used real-world post-marketing spontaneous reports and compared Anifrolumab with Belimumab, an active SLE comparator. This helps provide early pharmacovigilance information after approval. However, EudraVigilance data have important limitations, and spontaneous reports cannot establish incidence, absolute risk, or causality. Reporting may be influenced by disease severity, comorbidities, concomitant drugs, media attention, regulatory warnings, or reporting bias. Also, SLE itself can cause complications that can resemble adverse effects, making interpretation more difficult. For conclusion, herpes zoster was the only robust signal of disproportionate reporting for Anifrolumab compared with belimumab in public EudraVigilance data. This signal remained stable after restricting the analysis to sole suspect Anifrolumab cases. Other findings were exploratory and should be interpreted cautiously because they may reflect SLE activity, comorbidities, concomitant treatment, or reporting bias. Overall, these results support continued attention to herpes zoster monitoring in patients treated with Anifrolumab, while further controlled studies are needed to assess true risk and causality. Thank you for your attention.
Thank you for sharing this research with us. It's much precious work, Dr. Urgadal. Now let's welcome again our judges, which is Dr. Anvi Sangad and Franklin Kenichu on Agunzi. Please join us on stage here.
Yeah, hi. Okay, yeah, and thank you so much to the presenters for this very important body of research. I just have one or two questions that I want to clarify on. And I know you mentioned that to establish causality, you would need to conduct maybe controlled studies. I'm just wondering what kind of variables would you want to control for to help establish that Anifrolumab causes maybe herpes zoster, or it causes some of the things you found on the signals? Just thinking broadly.
Well, firstly, this is an excellent question. Thank you for asking. Here, what I can say about this is that since our study is based on spontaneous reports, we can't control the confounding factors. In a future controlled observational study, we would adjust for variables that independently influence herpes zoster risk, like age, sex, or a baseline SLE disease activity, or duration of the disease, or concomitant medications, immunosuppressive medications.
Yeah.
We should also account for the treatment duration and follow-up time. Controlling for these factors would help determine the increased risk is attributable to Anifrolumab itself, or rather than the patient characteristics or their underlying disease.
Okay, yeah, and thank you so much for your response. I was just trying to make sure that you're also thinking about the possible confounders of this relationship, and you've already responded to what was going to be my follow-up question, because just thinking about those response relationships are also important for causality. So if you're also considering things like duration of treatment to correlate them to the signals, that would be very important. Okay, yeah, that's all I have for you. Thank you so much.
Thank you so much for your question.
Great job, Ugur. I did have one question on the lines of, establishing causality. There is one concept called biological plausibility. So I would love to hear in your words, how do you think biologically plausible it is that this specific medication, if it's affecting the cell-mediated or humoral-mediated immunity and causing increased risks for herpes zoster infection?
Okay. For cell-mediated and, sorry, couldn't get that.
So do you think there's a bigger component of cell-mediated or humoral-mediated immunity in there, which kind of might explain why there's an increased risk of herpes zoster infection?
Okay, so I can start by saying our drug Anifrolumab, it's a type 1 interferon receptor. It's inhibiting the signaling to type 1 interferons like interferon alpha and beta. These play the important role of the antiviral immune response we get against these diseases, and help support cell-mediated immunity that keeps latent viruses like the varicella zosters. They keep it under control. By inhibiting this pathway, our drug Anifrolumab reduces the host ability to suppress viral reactivation rather, making herpes zoster biologically plausible. We don't really prove causality in our research, but the consistency of the pharmacological mechanism with the observed our proportionality signal, it strengthens the biological plausibility.
Well done. Thank you.
Thank you so much. Sorry again, like I really can't see the camera signal. Camera, I don't think I have it, but if I would have it, I would open my camera as well. I just can't find it. Thank you so much anyways. Thank you for listening, everyone.
All right. Thank you so much, everyone, for Dr. Ugardal and for the judges for joining us. Next, we'll be viewing the QR code. We'll be moving on to the next session of the presentation. Okay. All right. So for all the viewers, please scan the QR code and fill in this form to see which of the presenters are one of those that you would like to set as the best one. So you have to give your own recommendations and suggestions. And as well as the judges, please fill out the score sheet. Yeah. All right. Thank you, everyone, for scanning the code. Your answers will be used to be on the for the awards. And once you have voted for the best awards, that will be what we'll be seeing on the next 2 days or on the last session of the second day. So we hope that you'll be joining us until the end. Next up, we have Fatima Elzra Suliman, the 5th-year student of the Faculty of Medicine from the University of Qatar. Hope you're happy for us that you're joining us. She'll be presenting the Artificial Intelligence Assisted Learning and Critical Thinking, the role of cognitive engagement, a multi-institutional cross-sectional analysis among medical students in Sudan. Thank you. Yeah, and we do have our judges as well, which is Olurfemi Ayuthan and Zainab Lawal. All right, so you could present or you could show your presentation.
Okay. Hi everyone, I'm Fatima Zahra Ahmed Mohammed Suleiman, a 5th-year medical student at the University of Khartoum, Faculty of Medicine. It's my pleasure to present to you our research abstract entitled Artificial Intelligence Assisted Learning and Critical Thinking, the role of cognitive engagement, a multi-institutional cross-sectional study among medical students in Khartoum State, Sudan. Regarding the background, generative artificial intelligence has become increasingly integrated into medical education, offering substantial benefits in academic efficiency and accessibility. However, growing reliance on AI-generated outputs has raised concerns about reduced cognitive engagement, which is the mental effort students invest while learning, and the potential erosion of critical thinking skills. Both of them are essential for sound clinical judgment and patient safety. To the best of our knowledge, this relationship has not been investigated among medical students in Sudan, where gaps in AI literacy and the absence of structured institutional policies may further compound this concern. So our study aimed to investigate 3 main aspects. First, the relationship between AI-assisted learning and critical thinking. Second, the mediating role of cognitive engagement in this relationship. And finally, the student attitudes toward institutional AI policies. Our methodology was a cross-sectional analytical study design conducted among 403 medical students from 4 public universities in Khartoum State, Sudan. Our sampling was a multi-stage stratified random sampling technique. Each university has a separate stratum. Sample sizes were proportionally allocated across academic batches, and participants were selected using simple random sampling with an online randomization tool. The data were collected using a validated self-administered online questionnaire distributed to them via their group coordinators and their colleagues. The questionnaire assessed AI use, critical thinking, and cognitive engagement. Attitudes toward institutional AI policies were analyzed as a descriptive section. Analysis included descriptive statistics, Pearson's correlation, linear regression, and bootstrap mediation analysis with 1,003 samples using SPSS version 13 and Jamovi. And our result was as follows. First, regarding AI use and dependency, moderate artificial intelligence dependency levels predominated among participants, about 55%, while the majority reported daily artificial intelligence use, about 62.3%. AI and critical thinking. The AI usage showed a significant negative correlation with critical thinking, with correlation coefficient minus 0.144, and the p-value, as we see, is significant, 0.004. The variance of the regression model was 2%. Cognitive engagement. Cognitive engagement is considered the main contribution of this study. When cognitive engagement was added to the regression model, the explained variance increased from 2% to 35%. Subsequent mediation analysis demonstrated that cognitive engagement mediated the relationship between AI usage and dependency and critical thinking, accounting for 74.4% of the total effect. The direct effect of AI usage and dependency on critical thinking became non-significant after cognitive engagement was included in the model, indicating full mediation. So this figure demonstrates that AI usage, AI-assisted learning effect on critical thinking estimate is negative, is minus 0.08, but is not significant when the cognitive engagement included in the model. And the indirect pathway, which represented by the AI-assisted learning effect on cognitive engagement, and this by its turn affect the critical thinking, account for about 74.4% of the total effect. Okay, students were also asked about the perceived effect of AI-assisted learning on their cognitive engagement. As shown, the majority, about 57% of them, said that AI positively increased their engagement. 28% reported no noticeable effect, and only 15% perceived negative effect. These three groups was then compared using cross-Calvaris test with the objectively measured cognitive engagement scores from the standardized scale, and no significant difference between all these groups, and cognitive engagement remained low. Okay, also we make GPA association, and we found that students with higher grade point averages demonstrated lower artificial intelligence dependency, and those at the preclinical years scored significantly higher in critical thinking than their clinical year counterparts. Regarding compliance with institutional AI policies, about 65.5% of participants supported institutional artificial intelligence regulation. However, only 29.7% believe that existing policies adequately preserve academic integrity. Furthermore, 37.2% of participants agreed or strongly agreed that they would follow AI policies even if these policies restricted their current AI use. Okay, to conclude, artificial intelligence-assisted learning is deeply embedded in medical student academic practices. Although AI use was not associated with severe dependency, it was linked to a modest but significant reduction in critical thinking skills. The relationship between AI usage and critical thinking was fully mediated by reduced cognitive engagement, highlighting the importance of maintaining active engagement during learning. Students with stronger academic performance demonstrated lower AI dependency, suggesting that self-regulation and responsible AI use may help preserve critical thinking abilities. Medical schools should establish clear AI governance frameworks, promote AI literacy, and design learning environment that foster cognitive engagement so that AI serves as a tool to enhance rather than undermine student intellectual development. Thank you very much for your attention.
Thank you so much for sharing your presentation with us. Welcome two judges who will be joining us, which will be Dr. Hipa and Dr. Adani. Welcome back.
Hello, Fatima. First of all, thank you for the really good presentation. I'm really interested in AI as well and critical thinking. So basically, I had this really slight but important question. It's really short but really important question. I want to know, first of all, what do you how do you define critical thinking as a doctor? And at some point, do you think the AI, regardless what is the tool we're using, do you think AI at some point can replace the critical thinking of a real doctor? at some point, according from what you have from data from the hospital, how do you use AI and so on? Do you think at one point the AI can actually replace the critical human thinking of a doctor? And I would like to know your actual definition for critical thinking.
Okay. Okay, regarding the critical thinking, my aspect that or this study scope of critical thinking is mainly the critical thinking during learning and the active learning process and so on. Okay, we asked the student about if they are setting their goals when studying, if they are trying to link the information together, and if they are think deeply in what they are studying and in what they are learning. Okay, this is our main scope of critical thinking. And regarding the second question about if AI can replace the real doctor, I think no, it wouldn't. Yes, it wouldn't. It will not replace the real doctor. And I hope us as a student, as a future physician, try to use AI for augmentation rather than automation, because this will affect our critical thinking skills, and especially for someone living in Sudan, a third world country. We suffer from the internet infrastructure, and these large language models are not available for us all the time. So I think it will not replace the real doctor and the thinking.
That's very good. Thank you so much.
Welcome.
Okay.
We'll be moving on to the scanning of the codes, and as well for our judges, please do fill in your sheets for our presentation today. Thank you. Again, please scan the code right here to grade who is the best presenter of this event. All of our awards will be presented on the last day and the last session. So hopefully everybody will be joining us. All right, on our next presenter, we do have Dr. Habital El-Maki, fifth-year medical student from the Faculty of Medicine, University of Khartoum, Sudan. He'll be presenting the presentation entitled The Effect of Post-Conflict Educational Disruption on Patient Safety, Competence Among Senior Medical Students in the University of Khartoum, Cross-Sectional Study. Welcome. And we do have the judges as well, which are Dr. Mustafa. So we'll be having him on stage in a bit. So please do present your presentation with us, Dr. Habital.
Yeah, I'm sharing the screen, but
Okay.
doesn't. Good morning, distinguished chairpersons, respected judges, and fellow researchers. My name is Hibatullah Mubarak El-Maki, and I am a fifth-year medical student at the University of Khartoum, Sudan. On behalf of my co-authors, thank you for giving me the opportunity to present our genuine study on medical education today, entitled The Effect of Post-Conflict Educational Disruption on Patient Safety Competence Among Senior Medical Students at the University of Khartoum, a cross-sectional study 2026. Starting with the background, as we know, patient harm remaining as a major health concern globally, with WHO identifying the preventable medical errors as a major cause of morbidity and mortality worldwide, especially in the low and middle income countries. Therefore, developing the patient safety competence of the future healthcare worker during undergraduate medical education is considered essential. But in a conflict-affected setting like Sudan, since April 2023, armed conflict had affected medical education in Sudan, and medical schools, unfortunately, were forced to cancel for face-to-face physical education, and the hospitals reduced the opportunities for clinical training for those students. From these circumstances, our study came to assess the impact of such disruption on patient safety competence among senior medical students at the University of Khartoum. Moving to our methodology, we conducted a cross-sectional analytical study among 298 senior students, and we used systematic stratified sampling technique to reach the final sample size, with calculated k-interval of 3 and proportional allocation to ensure adequate representation of all 3 clinical years. We used, for collection of data, validated self-administered online questionnaire assessing both educational disruption in combined subjective-objective approach and patient safety competence measured using the HPEPS survey, the Health Profession Education on Patient Safety Survey, which assessed patient safety competence in both classroom and clinical settings separately. We analyzed data using SPSS version 26, and because data were not normally distributed, we used non-parametric statistical tests, and we used Wilcoxon sign rank test to measure the competence gap. And also, to identify the independent predictor of patient safety competence, we used the multiple linear regression. Moving to our results, among the 298 senior students, we found that 81.2% of these students experienced post-conflict educational disruption, and for the most common period was 6 to 12 months in the 33.9% of them. And for overall patient safety competence, it was 59.2%. And this indicating both moderate level despite the disruption and a potential room for future improvement. On these two pie charts here on the right side, in which we illustrated the educational disruption severity and the patient safety competence level, we noticed that the majority of students having, here 64% of them having a moderate disruption and 61% having a moderate patient safety competence level. And this after we used the modified Bloom cutoffs. Here below, when we used the related samples Wilcoxon signed rank test to measure the competence gap, we found that 172 negative differences, indicating the number of students having clinical scores much lower than the theoretical scores. Also, 114 negative positive differences, indicating the number of students having the opposite pattern, with only 12 students having equal scores, with a p-value of less than 0.001 is considered significant for this potential clinical competence gap. And further Wilcoxon test, we performed them to assess the clinical competence gap at the level of items. And we found that 15 items out of 16 items had a significant clinical competence gap. To the left here, the bar chart demonstrating the when we asked the student about 4 clinical aspects of patient safety, we found that 3 of them, the hand hygiene and infection prevention and control, patient safety in general, having a higher agreement level more than disagreement level. In contrast to medication safety, in which we found a higher disagreement level. And this in alignment in what we found in literature, that medication safety having the lowest competency level among the all 4 clinical aspects of patient safety. When we use the Spearman correlation coefficient, we found a positive correlation between clinical competence and theoretical competence, with a p-value of less than 0.001. And educational disruption was negatively associated with clinical competence with p-value of 0.02. And this indicating that despite the retained theoretical knowledge, this educational disruption had significantly affected the student hand-on experience aspect of patient safety competence. And moreover, the prior patient safety education was the only significant positive predictor of patient safety competence with p-value of less than 0.001, while the educational disruption having a borderline negative predictivity with a p-value of 0.057. In conclusion, our study demonstrated the substantial negative effect of educational disruption on patient safety competence for those students, especially on the clinical aspects, and for the superior patient safety education being the only positive significant predictor. This informing policies for medical schools on conflict-affected area to implement a longitudinal simulation-based patient safety training and to strengthen clinical training and to adapt a structured academic support for those students in such a fragile, low-resource setting. And thank you for your attention. I would be happy to answer all your questions.
Thank you so much again for this wonderful presentation on this one. Yeah, so we'll be calling on once again the judges to come with us on stage and to discuss this poster with us. Please, Dr. Muhammad Imad and Mustafa Sabir Abakar Awad. Yes.
Okay, Assalamu alaikum.
Wa alaikum assalam.
Okay. Thank you, Dr. Hiba, for this wonderful presentation. Actually, it was very concise and very on point, and it was clear. I have somewhat of one comment and one question. The comment is, this could be a little bit better if you expand the sample size and more even Khartoum, Fannilan, University of Zaim al-Azhari, University of Nduma Islamic University. It could result in more we could be like generalizable results rather than only keeping one university. This is a comment. And regarding the question, in your opinion, as from the collected data and the analysis that has been done, do you think that as you know, the competence of patient competency was measured using subjective assessment, and we know that subjective assessment is not something that can be reliable. So, do you think, or how confident are you that these subjective measures could be like really reflecting the students' actual competencies? And thank you.
Yeah, thank you for your question and your comment. First, for your comment, okay, thank you for your questions and your comment. First, for your comment that the sample size was small. Actually, this is one of our limitation of this study, and I suggest for a further research to conduct a research that would be a longitudinal and comparative, pre-conflict and post-conflict, and it should be a multi-institutional, as you said. And actually, I acknowledge that this is one of our limitation of this study. And for further research, we would conduct a longitudinal, a multi-institutional study. And for your question, as you said, the subjective approach only, it could be weak. So we used a combined subjective-objective approach. Regarding the objective approach, we used a multiple choice question to assess the severity, the duration of this educational disruption. And for the subjective approach, we adapted a 12-item scale assessing the educational disruption on 3 domains. The first domain was about clinical interruption, and the second domain was about theoretical interruption, and the third domain was about the overall impact of such disruption. And for this adapted 12-item scale, we did a pilot study of 30 students, and assessing the validity, and the Cronbach alpha was calculated, and it was 0.82 for overall scale, and it showed adequate validity of this scale. I think the subjective-objective approach would be enough and feasible for such a study, because as we know, educational disruption is a broad term. We couldn't just assess it 100%.
Okay, thank you, Hiba. Well done.
Thank you.
All right, maybe Dr. Muhammad Imad have something to add? Would you have any questions to ask our presenter here?
Yes, thank you so much, Dr. Hiba. That was a thoughtful presentation. And apologies, I can't open my camera now. There is a technical issue. I was about to ask, how did you get these domains regarding the educational disruption and conflict settings? Like, for example, what studies have you used before in order to construct and build your questionnaires? And you said that the study was piloted, the number of students that you piloted your study on. And furthermore, my last question would be, do you think that when we provide structured and for example, programs like visiting students, that would improve clinical maturity and that would improve clinical skills among seniors medical students, which will further lead to improving patient safety? And furthermore, my last question would be, these are self-reported results, and hence we can't generalize them, and we can't generalize them in terms of objectives measures. Do you think of some objective measures that we can use in potential studies in order to know exactly how much the educational disruption affect objective patient safety? Thank you.
Thank you for your questions. Actually, these 4 questions, I would answer to them in order. The first question was regarding the question regarding the subjective objective approach that we used. Actually, okay, can you remind me of the first question, please?
Yeah. In your study, you mentioned the educational disruption and how you measure the educational disruption and how they affect the patient safety as self-reported from a questionnaire that you built and you constructed. My first question was actually about the domains, how you build these domains. Did you refer to some important or significant studies in terms of conflict settings and medical education? And the second, which is about objective and subjective measures, do you think of some objective measure that we can use to predict the actual effect of educational disruption on patient safety? Because these results are reflected on self-reported subjective measures, not objective measures, if that makes sense.
Yeah, thank you. Actually, for the source that we built from the adapted 12 items for the objective approach for educational disruption, actually, on the period of literature review, we didn't find any study assessing the educational disruption using a validated scale. So we adapted one, and we referred to UNICEF book about educational disruption in conflict-affected setting, and many books of these organizations like UNICEF, UNESCO. Yeah, they have a book assess the domains of educational disruption, like on clinical and on the online lectures. Also, in the objective approach, we listed the barriers to the senior students to the clinic, either to the clinical rotations or to the online lectures. So this regarding the source, actually we depend mostly on the pilot study to ensure the adequate validity of this scale. And regarding the second question about
subjective and objective.
Yeah, the subjective and the objective measures. I said that was one of the limitation also, that the result is self-reported, and we could for further research to ensure conducting research, comparative research pre-conflict and post-conflict period to assess
And
and
also,
to compare between the two periods. And this longitudinal approach will ensure objective measure.
thank you, Dr. Hiba. And also, we would think of some
All right, we will
objectives
have
measures,
to
like, for example, OSCE
wrap up
and
our session now.
yeah.
Yeah,
Thank you
the
so much.
simulation. Yeah, simulation-based training would be also an experimental part of these objective measures.
Exactly. Thank you.
All right, thank you. Thank you so much for these. We'll be going on to the next presenter, but before that, we would want to have all our viewers to scan the QR code right now and vote for our presenter. As well as our judges, please do fill in the forms if you are given. Thank you. All right, welcome back. We'll be going on to the next presenter. This presentation will be an oral presentation from Fatima Nazir, and she'll be discussing on the sleep disorders and restless leg syndrome among patients on maintenance hemodialysis in Pakistan, a multi-center cross-sectional study. Thank you for being with us today. And right now we'll have our judge, Anna Karina. Please welcome and join us on stage as well. All right. So, Dr. Fatima, once you're ready, please present your presentation.
Good morning, everyone. Fatima Nazir here, and I'm a final year medical student from Rawalpindi Medical University, Pakistan. And today I will be presenting sleep disorders and restless leg syndrome among patients on maintenance hemodialysis in Pakistan, which is a multi-center cross-sectional study. This was a collaborative effort conducted across multiple provinces in Pakistan to assess the true burden and predictors of sleep disturbances in hemodialysis patients. Okay. Sleep disorders are extremely common, but often overlooked in patients on hemodialysis, especially in low-resource settings like Pakistan. The most frequent conditions include insomnia, obstructive sleep apnea, and restless leg syndrome. These disorders significantly affect quality of life, mood, cardiovascular risk, hospitalization rates, and overall survival. However, Pakistan lacks comprehensive multi-center data on their prevalence and predictors. So our objective was to determine the prevalence of these factors in maintenance hemodialysis patients and identify key predictors for each conditions. Talking about methodology, we conducted a multi-center cross-sectional study from 15th May to 30th August 2025 across 12 dialysis centers and the 4 provinces of Pakistan. We recruited 361 patients on maintenance hemodialysis for at least 3 months, and patients with active psychiatric illness, cognitive impairments, or acute medical conditions were excluded from the study. Data collection was done through structured face-to-face interviews using validated tools, which are Nathen Insomnia Scale for insomnia, Berlin Questionnaire for obstructive sleep apnea risk. International Restless Leg Syndrome diagnostic criteria was used to diagnose, and those who were diagnosed with RLS had an additional questionnaire screening test for the severity. Statistical analysis included Wilcoxon test, chi-square test, and multivariate logistic regression models. Wilcoxon rank sum test was used for continuous variables, and chi-square test was used for categorical variables, and then binary logistic regressions were used for the outcomes insomnia, obstructive sleep apnea, and restless leg syndrome. Now talking about the participants' characteristics, we enrolled 361 patients with a median age of 47 years. 59.6% were females and 40.4% were females. Nearly half had normal BMI, while about a quarter were overweight. Education levels differed significantly between genders. Hypertension 68%, diabetes 29% were the most common comorbidities. Around 64% were using antihypertensive medications and 17% were on insulin. These characteristics reflect a relatively young but clinically burdened dialysis population. Now, talking about the prevalence of sleep disorders, we observed a very high burden of sleep problems. 63.16% had insomnia, 45.98% had high risk obstructive sleep apnea, and 67.87% had RLS. And talking about this severity distribution of RLS, 12.7% had mild, 33.8% had moderate, and 21.3% had severe or very severe disease. And these numbers indicate an alarming level of sleep pathology compared to international data. Okay. So predictors of RLS, the regression analysis identified the strongest predictor hypnotic use with p-value 0.015, while education level was found to be a protective factor. Model strength was modest. Now, talking about predictors of insomnia, insomnia had a strong association with severe RLS, with p-value less than 0.01, higher BMI, insulin use, and older age. After adjustment, obstructive sleep apnea risk and education were not significant, and the model performance just moderate explanatory power. So the key message here is the restless leg syndrome is the dominant driver of insomnia in hemodialysis patients. Now, predictors of obstructive sleep apnea. For obstructive sleep apnea risk, significant predictors included age, and the model explained was satisfactory. Now, I'll talk about the overall model performance across these factors across all three models: insomnia, obstructive sleep apnea, and restless leg syndrome. The calibrations were excellent for all models. Area under curve values were acceptable to go, and EP values indicated stable and reliable regression outputs. So overall, the models were statistically robust and clinically meaningful. Our study demonstrated a high burden of sleep disorders among Pakistani hemodialysis patients, substantially higher than many international reports. So we found 68% RLS prevalence, 63% insomnia prevalence, 46% high risk obstructive sleep apnea prevalence. Severe restless leg syndrome emerged as the strongest driver of insomnia, emphasizing the need for early identification and targeted management. Predictors such as age, BMI, insulin use, hypnotic highlight metabolic and treatment-related influences. So to conclude, sleep disorders are highly prevalent yet under-recognized in dialysis units. Routine screening using Nathen Insomnia Scale, Berlin Questionnaire, and International Restless Leg Syndrome diagnostic tools should be integrated into practice. And so addressing the modifiable risk factors may improve sleep quality, cardiovascular health, and overall quality of life. Thank you very much. I'll be happy to take any question now.
Thank you so much for this presentation. And now let's have Dr. To join us on the platform to ask the questions.
Hi, Fatima. Very nice presentation. Congratulations. I just have a very quick question. I think you put that you report hypnotic use as one of the strongest predictors of restless leg syndrome. But since this is a cross-sectional study, how do you rule out reverse causation so that the patients are using hypnotics because they already have restless leg syndrome and disrupted sleep?
Yeah, this is actually the limitation or study because this is a cross-sectional study, and the hypnotic use, especially, it shows the reverse causation with restless leg syndrome. Actually, I believe those who are diagnosed with restless leg syndrome may already have severe sleep disorders for which they are taking hypnotic use. So it actually is not a causation, but it's a co-founder that is found significant here.
Okay, awesome. Thank you so much. Those are all my questions.
Thank you for your question.
Thank you again, Dr. Fatima and Dr. Anna Karina, for joining us for this presentation. Now we'll be moving on to our code and our screening. So another reminder for all our viewers, please scan the QR code to vote for the presentation, the one that you are preferring to. And then, as well as the judges, please fill in the sheets that is given to you. All right, we'll be moving on to our next presenter, which is Noor Alia Yasmin Zakaria, who will be presenting the perceived social support on opioids relapse among patients receiving methadone maintenance therapy, MMT, at a public hospital in Malaysia cross-sectional study. And let's welcome as well our judges, Dr. Aditya Saran and Hiba Hamdar, to join us on the platform. All right. Ms. Noor, please present your presentation.
Right. So good evening, everyone. My name is Alia, a final year medical student from IMU University, Malaysia. Today, I am honored to present our study titled Perceived Social Support and Opioid Relapse among patients receiving methadone maintenance therapy at a public hospital in Malaysia. These are my colleagues involved in this study, and we were supervised by my lecturer, Professor Zainab. So before I begin, what is perceived social support? Perceived social support refers to a person's subjective belief that support is available whenever it is needed. Two individuals may receive the same amount of support, yet one may feel well supported while the other may not. And research has shown that perceived social support is often a stronger predictor of mental health and recovery outcomes than the actual support received. Opioid use disorder is a chronic relapsing condition and remains a major public health challenge worldwide, including in Malaysia. Despite the implementation of methadone maintenance therapy in Malaysia in 2005, relapse remains common. While demographic and clinical predictors of relapse have been extensively studied, the role of perceived social support has received relatively little attention in Malaysian population. Therefore, we aim to determine whether perceived social support is associated with opioid relapse among patients receiving methadone maintenance therapy. So this slide shows the increasing burden of substance use in Malaysia. Despite being on methadone maintenance therapy, opioid relapse remains high. A study was done locally in 2022 showing that the relapse frequency of 11.9%. It suggests that there are additional factors influencing recovery. So this leads to our research question. Is there any association between opioid relapse rate and perceived social support? We conducted a cross-sectional study over a 3-month period among patients attending the methadone clinic. Individuals aged 18 years and above who had initiated methadone maintenance therapy were included, while those with significant psychological or medical conditions were excluded to minimize potential confounding. Participants completed an interview-administered questionnaire consisting of socio-demographic information and the validated 24-item social provision skills, which measures perceived social support. Data were analyzed using SPSS version 29 with chi-square test, independent t-test, and Mann-Whitney U-test. Moving on to the results. The participants ranged in age from 30 to 70 years old, with the largest proportion belonging to the 50 to 59-year age group. The study population was predominantly male, accounting for 95% of the participants. And out of all, Malays constituted the largest ethnic group in the cohort. This histogram illustrates the relationship between each demographic factor and the relapse rate. Among all demographic variables, only age and educational level demonstrated a statistically significant association with relapse. Next is a table presenting the percentage of participants according to their level of perceived social support. A majority of the participants were classified as having good perceived social support, comprising of 60% of the total study population. This is a scatter plot illustrating the relationship between social score and relapse rate, suggesting that the level of social support may not be strongly associated with the frequency of relapse in the sample. Therefore, further analysis was done via Mann-Whitney U-test to confirm whether the number of relapses differed between social support categories. This test demonstrated no statistically significant difference in relapse frequency between both support groups. Although perceived social support was not independently associated with relapse, our finding reinforced that opioid relapse is multifactorial. In clinical perspective, MMT program should continue adopting a multidisciplinary approach by combining pharmacological treatment with psychosocial support. In addition, our findings suggest that age-specific intervention and counseling tailored to educational level may help improve long-term recovery outcomes. In conclusion, perceived social support was not significantly associated with opioid relapse in our cohort. However, relapse remains a multifactorial process influenced by demographic, behavioral, and clinical factors. Our study has several limitations. The relatively small sample size may have reduced the statistical power and limit the generalizability of our findings. In addition, excluding patients who defaulted from treatment may have introduced selection bias, as these individuals are often at higher risk of relapse and have lower perceived social support. Furthermore, this was a single-centered study, and social-cultural difference across Malaysia may influence both perceived social support and relapse patterns. Further studies should involve larger multicenter cohorts and evaluate additional factors such as psychiatric comorbidities, treatment adherence, and peer influence using the multivariable analysis. This will provide a more comprehensive understanding of relapse and help optimize MMT programs in Malaysia. This marks the end of the presentation. Thank you so much.
Thank you once again, Noor, for that wonderful presentation. Now I would want to call on our judges to join us as well. Dr. Hiba Hamar and Aditya Saran. Yeah, hi.
Hi, hello.
Hello.
Hello, Dr. Noor. Your presentation was wonderful. But I do have a funny question that stopped me. So basically, when you were talking about the frequency of relapse, so you mentioned several times frequency of relapse. How were you able to measure this frequency of relapse? It was according to 6 months, as much as I can remember, 6 months, not 3 months, yeah? How were you able to measure this frequency of relapse over this period of time? And how could that have contributed to the null finding that you had as a result in your presentation?
So we analyzed the relapse frequency by checking the data, the patient data. We had received the basically the hospital allowed us to check on the data. So we checked the number of the positive urine tests every time they come for follow-up. That's when we counted that the patient had relapses.
Okay. Thank you. Clear. Thank you.
All right.
Okay, so nice presentation. My question would be that your study found no statistically significant association between the perceived social support and the relapse. As you said that the p-value was around 0.427, if I'm right. So does this mean that the social support has no role in the opioid relapse? Why or why not?
Although our study shows that there is no significance between both items, we still think that there is some significance. However, because our study sample is quite small and the duration is very short as well, and this is also a cross-sectional study because social support is indefinite, so it might change over time. So a longitudinal study might be better to have a better understanding regarding this relapse. Yeah.
Okay, thank you so much.
Thank you.
Thank you once again, all of our doctors here, and Noor for that wonderful presentation. We'll be moving on to the QR code. Once again, we would like to remind everyone to scan this QR code and vote for your most preferred presentation. All of the awards will be presented on the last session of the second day. And as for the judges, please fill in the forms that you were given. All right, we'll be moving on to the next presentation with Dr. Kartik Laddha, final year medical student from Jalawar Medical College, India. He'll be presenting Curbing the Crippling Challenges of Osteo-dental Fluorosis, Role of Domestic Defluoridation Method. And we will also want to welcome our judges, Dr. Franklin Kinechukyu Openazi, and Isabel Chukong, right there. All right. Thank you, judges. All right, presenter, please feel free to have your presentation on and start when you're ready.
Thank you, Justin. Yeah, I'm ready. Greetings, everyone. My name is Kartik Laddha. I'm a final year medical student from Jalawar Medical College, India. The title of my study is Curbing the Crippling Challenge of Osteo-dental Fluorosis, Role of Domestic Defluoridation Method. This was conducted under the guidance of my mentor, Dr. Shakila Mullah, Head of Department of Community Medicine. Okay, so for the background, what is fluorosis? Fluorosis is a chronic irreversible condition caused by drinking water high in fluoride, specifically groundwater because it is high in fluoride due to geogenic causes. This manifests as dental and skeletal problems, leading to crippling in its later stages. Globally, more than 100 countries are affected by high fluoride levels in groundwater, and it is estimated that around 200 million people are affected by fluoride-related groundwater issues and health problems. In India alone, the population at risk is 11.7 million. The acceptable upper limit for fluoride concentration in drinking water is 1.5 mg per liter as per WHO. Moreover, groundwater dependence is increasing year by year, which is a cause for further concern. You can see this map is given by a global review. This shows the estimated population potentially exposed to fluoride more than 1.5 mg per liter. There are parts of Central Africa, parts of India, and parts of China most affected. There exist several techniques for defluoridation of drinking water, including RO and ion exchange, but these are very expensive. There exist absorption methods also, bone char and activated alumna, as well as the Nalgonda technique, but these are community defluoridation methods using thousands of liters of water, and these are not very sustainable. The Nalgonda technique was developed in India, but it had large community defluoridation units. All of them are non-functional as of today. So there remained a need for simple, affordable methods for domestic defluoridation, which the families could use in their homes using small amounts of water. Thus, our study was conducted with the following objectives: to develop a low-cost domestic method for defluoridation and evaluate its effectiveness, to estimate the prevalence of dental fluorosis in an endemic area, to test levels of TDS and fluoride in drinking water samples before and after defluoridation, and to analyze the correlation between TDS and fluoride levels. Our study is a community-based quasi-experimental study. The study area is a fluoride endemic village. The study period was 3 months. We included all the consenting families residing in the study area. We calculated the sample size using a previously conducted study in the area. The sample size came out to be 350. Our sampling method is systematic random sampling. It reduced selection bias, and we used a sampling interval of 2 because you see the population had 770 houses. Dividing that by 350 would give you around 2. So for data collection, we visited each family. A performer was filled. We obtained informed consent as well. The fluoride levels initially was checked by an international organization of standardization certified titer-metric kit known as the Aquasol fluoride kit. And TDS was checked using a digital generic TDS meter. Nalgonda technique, it uses alum, quicklime, and bleaching powder for defluoridation of water. You can see that a method for 40 liters of water was also proposed. It has the solutions of alum and lime as shown, but this was not very feasible, and owing to the scarcity of water also, this method was reduced to 8 liters of water when fluoride levels were found to be high. And so we came to a common consensus. We changed the solutions to powdered forms. We came to a common consensus that 10 grams of alum, 1 gram of quicklime, and a pinch of bleaching powder were to be added to 8 liters of water as shown in the figure. You can see then we performed stirring, and a settling period of 1 hour was required. After that, the supernatant was collected, the sediment was discarded, and supernatant was reassessed for fluoride and TDS levels. TDS using the same TDS meter, and fluoride using an ion selective electrode because our kit was found non-functional in post-defluoridated samples. For dental fluorosis, they were assessed using Dean's fluorosis index. I was the only researcher conducting it, so there was no observer bias. Age of participants exhibiting dental fluorosis was noted. We did statistical analysis using JASP. A total of 1,002 individuals from 350 families were recorded in our study. Out of them, 354 showed varying degrees of fluorosis. The prevalence comes out to be 35.3%. You can see the pie chart. It shows the number of members affected by dental fluorosis in each family. Among those affected by dental fluorosis, adolescents were the major group. 59.04% of them were adolescents, and the mean age is given as 12.99 plus minus 6.57 years. You can see a histogram with KD overlay showing the age distribution. You can see that the peak occurs after 10 years of age. For 88% of samples, the source of water was underground, and this is a very concerning point. We also recorded that only 12 families used RO out of the 350 families. You can see in the table the awareness regarding fluoride levels and fluorosis was also very less. The The 12 families using RO had fluoride within safe limits, so they were not defluoridated. The initial fluoride levels for the 338 families is recorded as a mean of 4.124 mg per liter. After defluoridation, it reduced to 0.110 mg per liter, a reduction of 97.3%. It is to be noted that TDS increased after defluoridation, but although it increased, the TDS levels remained within the acceptable WHO limits. More importantly, only 2 cents were required for each defluoridation, each 8-liter defluoridation. You can see a rain cloud plot showing concentrations before and after defluoridation of fluoride. The green dots depict the concentrations before defluoridation. The orange dots depict concentrations after defluoridation. So there is a substantial reduction. An analysis of the water samples was done using the paired samples t-test to calculate the difference in mean fluoride levels before and after defluoridation. We observed a p-value of less than 0.001, which was a significant p-value. So we recorded that this was a significant reduction in fluoride concentration. We also did Pearson's correlation to check correlation between fluoride and TDS levels. You can see before defluoridation, the p-value is not significant. After defluoridation, it is significant, but still Pearson's R is 0.193, which is a very weak correlation. So we inferred that TDS alone cannot be used as a surrogate marker for fluoride levels. That is, high TDS values do not necessarily show high fluoride values in water samples. So for the conclusion, it highlights the burden of fluorosis in the fluoride endemic region. Our method, our domestic defluoridation method, can serve as a low-cost solution for reducing high fluoride in drinking water, reducing levels from hazardous to permissible ranges. And these are the references I used. These are some snippets from my work in the field. Thank you.
Thank you so much for that wonderful presentation. We will have again our judges back on the platform to discuss on this presentation.
Kartik, good job. I really liked your presentation. The only question I wanted to ask you, so could you tell me a little bit why you chose a quasi-experimental design? And how can you confirm that the reduction in fluorosis resulted from the intervention alone?
Yeah, we did not have a control group, and it was found non-ethical to have a randomized control trial instead, because we did not want to have a control group and not provide them with the defluoridation method that we were providing the rest of the population. So quasi-experimental design, it was the most logical thing to do, so that everyone in the field could be provided with the defluoridation method and without any problem.
Awesome. Thank you for that.
Thank you.
We would like to remind everyone to look into the code and scan it to choose your most preferred presentation. All awards will be presented on the last session of our second day. And as for our judges, please fill in the forms that were given to you. All right, moving on to our next presenter, we have Dr. Kavya Ammineni from BES Institute of Medical Science and Research, Kupam, India. He'll be presenting on the diagnostic challenges in early CAR T-cell therapy toxicities, recognizing mimics of cytokine release syndrome and immune effector cell-associated neurotoxicity syndrome. And we'll also have, or let's welcome the judges, Dr. Muhammad Imad, to join us. Thank you. All right. Dr. Kavya, once you're ready, please begin.
Okay. Good morning, everyone. I'm Kavya Ammineni. I'm a medical graduate. I'm from PES Institute of Medical Sciences and Research Foundation. Today, I will be presenting our work with the title Diagnostic Challenges in Early CAR Cell Therapy, Recognizing Mimics of Cytokine Release Syndrome and Immune Effector Cell-Associated Neurotoxicity Syndrome. So what is CAR cell therapy? CAR cell therapy stands for Chimeric Antigen Receptor T-cell therapy. It is an advanced form of immunotherapy where patients' own T cells are genetically modified to recognize and destroy cancer cells. Despite its success, CAR therapy has unique toxicities. The two most common toxicities are cytokine release syndrome and immune effector cell-associated neurotoxicity syndrome. However, several conditions mimic CRS and eye cancer, leading to inappropriate treatment and worsening outcomes. The aim of our study was to evaluate the major diagnostic mimics of CRS and ICANS and highlight the challenges clinicians face in distinguishing these true CAR toxicities from other conditions that can present with similar overlapping symptoms in the early post-CART period. For this study, we conducted a systematic review and meta-analysis following the PRISMA guidelines. We searched four major databases, PubMed, Scopus, Embase, and Cochrane Library, for studies published between January 2016 and March 2026. We included randomized trials and observational studies involving adult or pediatric patients treated with CD19, BCMA, or CD22 directed CART therapy, and studies involving more than 5 patients, and full text articles published in English. We excluded case reports, conference abstracts without complete data, non-English publications, animal studies, and studies with fewer than 5 patients. From each study, we extracted data on the incidence of CRS, ICANS, and their mimics. Finally, we pooled the data using a random effects model reporting proportions with 95% confidence intervals and assessed heterogeneity using the I-squared statistic. Our analysis included 42 studies with a total of 8,764 patients who received CART therapy. Overall, cytokine release syndrome was the most common complication, occurring in about 72.4% of patients, while severe CRS occurred in approximately 14.8%. Among conditions that can mimic CRS, bacterial infections were the most common mimics, affecting around 42.7% of patients after CD19 CART therapy and up to 58.4% after BCMA CART therapy. Another CRS mimic is hemophagocytic lymphohistiocytosis, which demonstrated a pooled incidence of 34.1% in anti-CD22 CART studies. The next common toxicity is ICANS. ICANS occurred in nearly 38.6% of patients, with severe ICANS in about 11%. Common manifestations of ICANS include encephalopathy, aphasia, tremors, seizures, and memory impairment. Cerebral edema was rare, occurring in only 1.6% of patients. So the conclusion is many early toxicities observed after CART therapy are not always true CRS and ICANS. Several medical conditions like bacterial sepsis, HLH can mimic CRS. Metabolic abnormalities, infection, and structural neurological disorders, they all can present as encephalopathy and closely resemble ICANS, and this creates the diagnostic challenge. Misdiagnosis may lead to inappropriate treatment. For example, if we give immunosuppressants like corticosteroids, assuming it has CRS, it worsens infections due to inappropriate immunosuppression. So, a systematic diagnostic approach is necessary, including infectious workup with blood cultures, inflammatory markers, microbiological testing to exclude bacterial sepsis from CRS, and metabolic evaluation like electrolyte assessment, glucose levels, renal and hepatic function tests, neuro radiographic assessment with CT or MRI to differentiate structural abnormalities, stroke and cerebral edema causes. And we by cytokine analysis and ferritin levels helps distinguish HLH from CRS because they elevate in HLH more than CRS. So early detection by integrating clinical findings with this systematic diagnostic approach avoids mismanagement, supports targeted therapy, and improves outcomes. Thank you for your attention. I'd be happy to answer any questions from the judges.
Thank you so much again for that wonderful presentation. We'll be welcoming again our judge, Dr. Muhammad Imad, to join us on this. Thank you so much again for that wonderful presentation.
Hi, thank you so much, Dr. Kavia, for your presentation. This is a very interesting systematic review and meta-analysis. However, I would just like having one question or two questions regarding the heterogeneity of your study. Would you be able to elaborate more on how to reduce this heterogeneity, or for example, how would the clinician interrupt this heterogeneity in terms of their clinical practice? And my second question would be, you have done good exclusion criteria of the studies, but I would like to also elaborate on the mixing of RCTs with observational studies in your study. Thank you so much.
Okay, thank you for the question. The heterogeneity in this study is mainly due to. Thank you. Hello. Thank you for the question. The heterogeneity in this study is mainly due to differences in CAR products, malignancies, and patient populations or the study designs. This can be reduced by stratifying patients based on CAR product type, on disease type, and patient's age and severity of inflammatory toxicity. This would help determine whether specific patient groups have higher risk of CRS mimics, ICANS mimics, such as infection, HLH, and coming to the second question, we included both RCTs and observational studies because RCTs provide controlled evidence while observational studies provide larger real-world safety data, particularly for this type of uncommon CAR toxicities.
Yes, thank you so much. That was fruitful. I would like to add one suggestion for to improve this study furthermore, which is instead of sorry, I just have a bit of technical issues here. But instead of doing pure systematic review and meta-analysis, you can, as you have done, the systematic review, but in terms of meta-analysis, you can do a subsequent stratified meta-analysis. Like, for example, you gather the applicable data from the RCTs and do the pooling analysis for them, as well as you gather from observational, like separately, and trying just to make the outcomes feasible and could be like analyzed. That's it, and thank you so much.
Thank you.
Thank you once again for Dr. Kavra for sharing her presentation and Dr. Imad for sharing his thoughts on the research. Now we'll be having the code. We would like to remind everyone to scan the code and to choose your most preferred presentation. All awards will be presented on the last session of our second day. And as for our judges, please fill in the forms that were given to you. Welcome back, everyone. We'll be moving on to the next presentation of this conference. We have Dr. Hajar Saad Hali Bashir, an MBS student from the Faculty of Medicine of the University of Khartoum, Sudan. And they will be presenting on the exploration, the prevalence, and the patterns of traditional medicine use among the general population of conflict-affected areas in Sudan 2025. It's a cross-sectional study. And we also have our judge, which is Dr. Ashish Gupta. Welcome for joining.
Good day, everyone. My name is Hajar Saad Saleh, fifth year medical student from University of Khartoum. Today, I'm honored to present our research entitled Prevalence of Traditional Medicine Use Among General Population of Conflict-Affected Areas in Sudan 2025 for a sectional study. Next, please. The work was conducted by 15 authors, myself, Hajar Saad, and 14 colleagues, most of whom are medical and dental students. So, as you all know, since the conflict began in Sudan in April 2023, the formal healthcare system has faced a catastrophic collapse. Around 68% of health facilities in conflict-affected areas completely closed, leaving only 28 out of 88 partially open. In this dark reality, a massive knowledge gap emerged. How do people survive when there are no hospitals? Traditional medicine shifted from being a cultural preference to a vital survival strategy. Next. Existing Sudanese research only cover peacetime usage. Our study aims to look into this silence and understand these patterns of an studied usage of traditional medicine during the conflict time. Next. So to clear this gap, we conducted a community-based cross-sectional study between February and July 2025. We targeted 3 conflict states: Khartoum, Al Jazeera, and Kordofan. Our calculated sample size using the Cochrane formula was 633, which included a 1.5 oversampling adjustment for field realities, targeting age 18 and older. Because of the active war and serious safety restrictions, we couldn't use random sampling. Instead, we used a convenient sampling technique and conducted 633 face-to-face interviews using a validated Arabic questionnaire. Data was analyzed using SPSS version 21. Chi-square and visual exact tests were used. So let us move to our result. Our findings are eye-opening. First of all, we found a remarkable high prevalence of traditional medicine use, with 75% of participants reporting the use of traditional medicine during the conflict. Second, the main users were females, young adults, and many were university graduates. Third, we observed concerning behavioral patterns, including exclusive reliance on traditional medicine, widespread self-medications, and poor communication with healthcare providers. Fourth, family and friends were the primary source of information about traditional medicine. Many participants reported symptom relief after use of traditional medicine. Herbal remedies were the predominant modality used, and mainly used for respiratory and gastrointestinal conditions or problems. So, fifth, the drivers of traditional medicine use. Next slide, please. So, the drivers for traditional medicine, not only the cultural, but also the availability and affordability, and the cost also. The driver of traditional medicine use extend beyond cultural beliefs. Participants frequently cited affordability and easy accessibility, while major barriers to conventional healthcare include high cost and unsafe travel routes. And finally, the conflict appears to have reinforced reliance on traditional medicine. About 1/3 of participants increased their use after the April War 2023. Half of participants perceived traditional medicine as more reliable than before the war. Over half believe that its importance within the community had increased also during the conflict. These patterns vary significantly between ages, sex, educational level, income, and displacement status. So, what do our results mean? They prove that armed conflict permanently reshaped the healthcare behavior. People are turning to traditional medicine out of necessity, not ignorance, because it is available and affordable. However, the fact that 77.5% of users did not disclose traditional medicine use to physician, this result in dangerous silence. It increased the risk of herb-drug interaction and delays proper medical treatment. Another interesting finding, we also notice mental health paradox. There was very low reporting use of traditional medicine for psychological problems or issues. We believe it is due to cultural stigma and invisibility rather than low actual use. So next slide. So coming to our strengths and limitation, our strengths of this study is in 3-stage geographic coverage and capturing data mid-crisis, which provide actionable insight for policymakers. We want to acknowledge some limitations is cross-sectional design. Cross-sectional design not give us the causality. Using of convenient sampling due to insecurity and conflict circumstances makes the generalizability of our finding less. And final limitation is potential recall bias. So, in conclusion, adaptation over culture. 75% usage across all demographic prove reliance is driven by affordability and access, not educational level. The safety risk, 77.5% non-disclosure, create a dangerous gap for herb-drug interaction and delayed care. The post-war shift conflict permanently increase the perceived reliability of traditional medicine. And we urge policymakers to design conflict-sensitive health policies, focus on public education, and also support clinical research to ensure the safe integration of these practices during crisis. Next. Next. Okay, finally, I want to thank the Student Association of Medical Research and of Medical Education and Research, SAMIR, and Khartoum Medical Student Association, KMSA, for making this work possible under exceptional circumstances. Thank you all for listening, and I'm ready for your questions, if any.
Thank you once again, Doctor, for that wonderful presentation. Now we'll be going to the discussion part. Let's welcome Dr. Ashish Gupta. Yes.
Yes. Greetings of the day. Dr. Hazar, it was a very decent presentation. It's a good study, basically. You have very well covered all the aspects of the study. You have very well explained the limitations of the study also. So, how did you manage to minimize the selection bias in the study? So there may be some areas or some populations where more people are used to use or follow traditional medicine rather than the regular medicine. So how did you overcome that selection bias?
Okay, thanks for your question. We add 1.5 effect size. Our calculated sample size increased. It becomes 133 to decrease the potential risk.
Okay, great. That was a nice presentation. If any other judge has any other question, we can proceed with the next presentation.
All right, if we don't have any other questions, we may proceed to the code. All right, we'll be presenting the code. We would like to remind everyone to scan the QR code presented on the screen right now, and please choose your preferred presentation. All rewards will be presented on the last session for second day. And as for our judges, please do fill in the form that has been given to you. All right, moving on to the next presentation, we would have Dr. Yamini Saraswathi Guram from the Ammineni Sadari Institute of Medical Science and Research Foundation, and they will be presenting on the diagnostic value of pleural fluid and terminal pro-brain natriuretic peptide levels in patients with cardiovascular diseases. So please do share the presentation. And then we would also have our judge, which is Dr. Gupta, joining us on this as well.
I would like to welcome my respective judges and fellow colleagues for the presentation. I am presenting my research on the topic of pleural pro-BNP and how it is useful in the diagnosis of the etiology of pleural effusion. So why actually this matters? So for me, I have seen a lot of cases of pleural effusion, especially in the critical care, and any disease as such would end in pleural effusion at last in most of the cases. So the incidence is almost 3,000 cases per million annually. And as we can observe, it is the major mortality driver in the course of the treatment. So this unmet need of not having a biomarker which would help us in differentiating between the other causes of pleural effusion and the cardiac cause of pleural effusion led me to conduct this research. So I would like to explain basically about my study. So this is a systematic review and a meta-analysis. So in my study, I have gone through the literature, literature of 10 years, and I have compiled the data according to the PRISMA guidelines and having inclusion and exclusion criteria in mind. And while including, I have included all the cases, all the papers which have patients with cardiac as well as non-cardiac causes of pleural effusion, whether it can be malignancy or whether it can be infectious cause or any other liver-related cause of pleural effusion. So once I have included the patients, I have ensured that the methodology of all the studies are similar. So I have ensured that all the patients have undergone some kind of pleural tap and pleural fluid collection. After the pleural fluid collection is done, the pro-BNP level was measured. And then after the measurement of pro-BNP, I have compared the levels of pro-BNP between both the groups after random in the RCTs, and I tried to find out if at all pro-BNP is helping us diagnose the etiology of pleural effusion in a better way. So what I came across is the cardiac causes of pleural effusion. The patients who ever have cardiac cause as the major driver had higher level of pleural BNP, and the marker was around 1,714 picogram per ml. And I have observed that in the other causes of pleural effusion, such as hepatic hydrothorax, tuberculosis, parapneumonia, and malignancy, the pro-BNP level was 84% lower. So this was significant. And I felt like that would really help clinicians make a sound decision and help make a proper treatment plan for our patients. So how is that going to make any impact? So my research is important because we can differentiate the actual etiology of the pleural effusion. Once you know that, we'll be able to guide the patient for treatment according to his personal preference and his basic etiology instead of giving a generalized treatment. So that would reduce the mortality in patients to a larger extent. And this biomarker is not an invasive procedure. So this gives us a option for early diagnosis of pleural effusion. And when we diagnose the pleural effusion in an early stage, it is easy for us to cure. And last but not the least, when we know that there are a lot of patients, especially in critical care and accidental ER settings, then we will also know which is more important, which case is more dangerous than the other. So it helps in classifying the patients and helps us in triage. So this initiates the etiology targeted therapy is my main focus. And that is why I think that pleural proBNP is a diagnostic marker in differentiating between the cardiac and the non-cardiac causes of pleural effusion. So once I have made this analogy, I have made a few forest funnel plots and I have tried to analyze the statistics of it. And then I have concluded my study and found that proBNP was significantly more in cardiac causes, and that is the main reason it is the next bigger thing in cardiac pleural effusion. Thank you, and I would like to answer any questions you guys have.
Thanks again for that wonderful presentation. You could share more on the inspiration on why you have chosen this topic.
Okay, yeah, sure. I would love to. So I'm from India and I had my major rotations in ER and critical care. So in that setting, I found that a lot of patients somehow land up in pleural effusion and complications related to that. And that made me think, like, if there is a way we can identify this early in the course, and if we could give an appropriate treatment, then probably we could just reduce the mortality and hospital stay. So that was my main motto in conducting this study. So it was like a SRMA. So I just went through the literature, I compiled all the statistics, and after proper analysis, I came to the analogy that I have presented today.
Understood. Thank you so much for that sharing. And I think that is actually very good, where we try to have an early early detection, early diagnosis for an early treatment that will be good for our prevention. Thank you once again for presenting and sharing your wonderful
Thank you for
study.
giving me this opportunity to share my research and collaborate with all of you. Thank you very much.
Thank you. All right, we'll be having the code, and please, we would want to inform everyone to scan the code and choose your preferred presenter. And as for the judges, please do fill in the form that were given to you. All the awards will be done on the last session of our second day, so we do hope everybody will be joining us to see more of other research and other strategies that could be done. All right, we'll be going on to the next presenter. That will be Hanisha Shivaprakash. It will be a presentation, a poster presentation, and they will be doing on the risk profile clinical presentation and immediate outcomes of neonates and Fluconazole-Resistant candidal sepsis and their response to Voriconazole, a retrospective case study. Please do present, and we do also have our judges, which is Dr. Isabel Chungong and Maxine Gonzalo Williams. Please do join us on our platform. Thank you. Dr. Hanisha?
Hi, Justin. Thank you. Can you see my screen?
Yes, please do start. And a reminder, we just have 7 minutes, all right?
Yeah, sure. Hello, everybody. Good morning. I'm Dr. Hanisha Shivaprakash, an intern at JJM Medical College. And today I will be presenting our research paper titled Risk Profile Clinical Presentation and Immediate Outcomes in Neonates with Fluconazole-Resistant Candidal Sepsis and Their Response to Voriconazole, a retrospective case series. Starting off with the background, neonatal sepsis, particularly candidal sepsis, is a major cause of morbidity and mortality in NICUs worldwide. Over the last few decades, we've seen an increasing number of reports of non-albicans candida isolates in neonatal candidemia, as well as rising rates of fluconazole resistance. However, we have very limited studies on alternative antifungal agents, particularly voriconazole. The aim of our study was to describe the clinical profile, microbiological spectrum, and to assess the outcomes of neonates with fluconazole-resistant candidemia when treated with voriconazole. This was a retroprospective case series conducted over 3 years, starting from March of 2023 till the March of 2026. It was conducted in a tertiary care NICU where culture-confirmed candidemia cases were included. Cultures were processed using BACT alert system, identified, and antifungal susceptibility testing was done using the Vitek-2 compact system. Voriconazole was administered for neonates who showed either clinical or in vitro resistance to fluconazole. Repeat cultures were sent 5 to 7 days after the administration of voriconazole. Voriconazole was continued for 14 days after microbiological clearance, and routine end organ screening was performed for all. Primary and secondary outcomes were noted. Primary outcomes included survival and time for microbiological clearance. Secondary outcomes included duration of antifungal therapy, length of NICU stay, end organ dissemination, species distribution, antifungal susceptibility profile, and associated risk factors. The key results of our study, we enrolled 26 cases. Most of these were preterm, low birth weight with male predominance. The striking feature was that 83.6% of the cases had some sort of NICU intervention. This fits and supports the established neonatal risk factors for candidemia, like prematurity, low birth weight, and NICU intervention. Thrombocytopenia was the most common clinical manifestation. 50% of the cases had thrombocytopenia. End organ dissemination was seen in 9% of the cases. Species, the most common isolated species was Candida tropicalis. This is in par with studies conducted in India as well as worldwide, where non-albicans Candida is being isolated as the predominant species. Outcomes, culture clearance took 10.17 days, therapy duration was 24.5 days, survival of 69.2%, and hepatotoxicity was seen in 15.3%. Discussion, as we previously talked about, non-albicans Candida species are emerging as the dominant neonatal pathogens. Voriconazole achieved timely microbiological clearance with acceptable safety. Species-directed therapy and antifungal stewardship are increasingly important. The take-home message, voriconazole is a promising option for fluconazole-resistant neonatal candidemia, but larger multi-center studies are required before routine adoption. With this, I would like to conclude my presentation. Thank you for your time and thank you for this opportunity.
Thank you so much for this wonderful presentation. And we would want to have our judges back on the platform, the Dr. Isabel Tunkang and Maxine Gossel-Williams.
Okay, thank you very much, Anishka. Very interesting presentation and one that is really important. We all know fungal infections are very hard to manage. I just had one question related to the hepatotoxicity. It was 15%, I think that's what I saw. And I wondered what were the profiles and how you felt about that, seeing the fact is that you're dealing with a population that is likely to have a liver function that's not fully developed.
Thank you for your question, Dr. Williams. So yes, we did weekly LFTs on these neonates that were enrolled in our study, and this was because voriconazole is known to cause hepatotoxicity, and their transaminase levels were increased. In some cases, bilirubin was deranged, which is why we concluded with hepatotoxicity. So this comes as a risk benefit when you compare this toxicity against other antifungals such as amphotericin. It's quite acceptable. So, and especially when there is established fluconazole resistance, voriconazole is definitely an alternative antifungal with acceptable safety profile.
Hi, are you guys able to hear me? Okay, I guess
Yes,
I
Dr.
cannot
Yes,
hear
loud and
Sriram.
anyone.
clear.
Thank
Okay, because I couldn't hear when Dr. Maxine and Hanisha were speaking. Thank you, Anisha, for your presentation. I only have one question. I wished you told us a little bit how you were able to define fluconazole resistance. Are you able to tell us a bit more on that?
Yes, of course. Thank you for your question, Dr. Chukang. So we had two types. One was in vitro resistance, where
Yeah,
when we
I
ran the
can't hear her. Okay, I don't know if it's my microphone.
is
We can hear
everyone
Hanika.
Okay.
would you like me to type
Please
the
proceed,
answer?
Hanisha.
All right. So we had two types of resistance. One is in vitro resistance, where we did when we did the antifungal susceptibility testing, the species would be resistant to fluconazole. So that was in vitro resistance. And coming to clinical resistance, we saw that the neonates were not improving despite giving voriconazole for an accepted period of time. They showed no improvement or, in fact, deteriorated. So when there was no response to fluconazole, we took that as clinical resistance. So this is how we concluded on fluconazole resistance.
Okay, thank you so much, Hanisha. Dr. Isabel, do we still have any other question you would want to supplement?
Oh, no, I have no other questions. Thank you.
Thank you so much. All right, so we'll be moving on to the code. We would like to remind everyone to look into the code and scan it. Choose your most preferred presenter. All rewards will be presented on the last session of the second day. And as for the judges, please do fill in the form that were given to you. All right, moving on to our next presenter would be Dr. Danielle Ninan, a medical student from the California University of Science and Medicine. Welcome. And he'll be presenting on evaluating the efficacy of on-device AI in radiological image classification using core ML for brain tumor detection. We would also want to request again Dr. Maxine to join us as our judge for this session.
Hello. I unfortunately
Please.
can't hear you at this moment. Should I go ahead and present? Can you give me a thumbs up if you can hear me? Okay. Thank you for this opportunity to present. If you can go ahead and go on to the next slide. Let's see. There we go. Okay, my name is Daniel Ninan, and I'm presenting on behalf of our team at California University of Science and Medicine in California in the US. Our team's interests are at the intersection of machine learning, healthcare accessibility, consumer level hardware, and modern software development. We developed an AI model that detects brain tumors from MRI images, and it runs entirely on device. No server or cloud infrastructure is required. We believe this approach has meaningful applications for how AI diagnostic tools can be built, deployed, and scaled, both cost efficiently and while protecting patient privacy. One way brain tumors are diagnosed is by having a radiologist interpret MRI scans. This is a process that is accurate, but it is also resource intensive and expensive. This brings the question, can AI help in this process? What we know is that AI radiology tools have shown promise in aiding diagnostic accuracy and in reducing physician workload, but their implementation costs have been a significant barrier, especially for under-resourced health systems. Most commercial AI radiology products require expensive server infrastructure, cloud subscriptions, or dedicated hardware, putting them out of reach for many clinics and hospitals. Our team asked, can we build a model that is both accurate and accessible? And that's where on-device AI frameworks come in. In our specific research, we used Xcode as our development environment and Core ML, which is Apple's on-device machine learning framework, to build and train the model. The model runs entirely on consumer hardware. not the cloud, and does not require any expensive server infrastructure or expensive GPUs. Our specific aim was to evaluate the accuracy of a core ML model in detecting brain tumors from MRI images, with the broader goal of enabling affordable, large-scale deployment in healthcare settings. For our dataset, we used a publicly available de-identified Kaggle dataset that contained over 7,000 MRI images spanning 4 categories: glioma, meningioma, pituitary tumor, and healthy. We split the images 85% for training and 15% for testing, giving nearly 6,000 images for training and just over 1,000 for testing or evaluation by our model. Images were standardized using CreateML's image feature print v2. Images were automatically scaled to 360 by 360 pixels and no manual augmentation done. This allowed us to assess baseline model performance. The model was then trained using a supervised image classifier set to go through 50 iterations. However, training stopped early at iteration 21 because the model converged, which indicated that the model was sufficiently trained. We then exported the model as a core ML package ready for on-device inference use. To evaluate performance, we use standard classification metrics of accuracy, precision, recall, F1 score, and a confusion matrix to visualize per class errors. We'll show you the results in just one moment, but this here is the architecture of the model. On the left is the full pipeline from image input to image classification. There are 2 stages. The first stage is Apple's image analysis framework, and it extracts a numerical representation of the image. The second stage takes that numerical representation and feeds it into a logistics regression classifier, which outputs both a predicted class and a confidence score. On the right is an example of 4 different predictions. We used 1 different class or 1 different category of tumor and the resulting model output. And in this particular case, in this particular sample, each tumor or healthy was classified correctly. Now, moving on to the results, let's take a look at what the model achieved over testing 1,053 images. The overall accuracy was 93%. Performance was strongest on healthy and pituitary cases, and those tend to have visually more distinct features. The most challenging cases were glioma and meningioma, and that's not surprising. These 2 tumors can look radiologically similar, and misclassification between them has been documented even among physicians. Next, looking at the confusion matrix, correct classifications fall across the diagonal. Anything that is not on the diagonal represents a misclassification. Here, the vast majority of errors involved meningioma misclassification, with every other category classifying as with very high accuracy. The bar chart on the right also confirms this pattern and shows precision, recall, and F1 scores are consistently high across all 4 categories. Now, we want to be transparent about what the study does and does not show. The model was trained on a single public data set, which may not capture the full variability seen in real-world clinical MRI data. We didn't apply image augmentation, which typically improves accuracy, and we haven't validated performance in an actual clinical workflow alongside radiologists. So some important next steps include obtaining multi-center data, applying targeted augmentation to try to improve accuracy, and also doing a proper clinical validation study. That said, the practical case for this approach remains. The model runs entirely on consumer hardware and is much more cost-effective as we are not reliant on cloud infrastructure. And this can also serve to increase accessibility as a preliminary screening tool or to assist physicians in large areas where there's fewer resources. So to summarize, we analyzed over 1,000 MRI images, each taken in one of 3 planes, axial, coronal, or sagittal, spanning 3 tumor types and a no tumor category. An overall accuracy of 93% was achieved using an entirely on-device model built with freely available developer tools. Performance was strongest on healthy and pituitary images. The main area of confusion was between glioma and meningioma, which is consistent with findings in the literature. And most importantly, this model runs entirely on consumer hardware. We see this as a potential tool for preliminary AI-assisted assessments, not as a replacement for radiologist judgment, but a meaningful first step that could reduce diagnostic delays and improve access in resource-limited settings. Thank you. We're happy to take questions. And if you would like to interact with our model directly with the test data set that we did use, we do have that available on Apple's App Store. Thank you. And if there's any questions, I'm happy to take them.
Thank you very much for that wonderful presentation, Dr. Danielle. We would also want to call in Dr. Maxine to join us for this session.
Okay. Okay, thank you very much, Dr. Naren. Very interesting presentation. AI is the way we are being told, and some.
So I don't
Not
know if
hearing
it's
me?
possible to put a question in the
Justin, are you hearing me?
comments or something if there was one.
All right. I think Dr. Danielle may not be hearing both of us, Dr.
Are you
Maxine.
hearing
So
me?
if you do
No?
have a question, I would relay it to Dr. Danielle on the chat if that's possible. Yeah, please do fill in to put on your question, Dr. Maxine.
Are you hearing me now?
Yes, we can hear you.
Okay.
Could you
I
hear
just
us?
opened up a YouTube window. Yes.
Okay, I just have my question. I was just wondering, how do you see this being of value to low and middle income countries? I imagine the cost of having this in place is phenomenal.
All right, Danielle, the question is also on the chat box if you couldn't hear us.
So the consumer level hardware we're talking about is iPads and iPhones. I'm sorry, there was a delay, but by consumer level hardware, we're looking at like cellular phones and iPads and tablets, which I do admit are expensive in lower countries, in some countries. However, it is also much less expensive than a traditional server things. And so what we can now do on like a cell phone, this is technology starting to allow us to do things on cell phones that used to require expensive computer servers. So I think that this is opening up a new opportunity if there's a clinic. Now, unfortunately, the MRI machines are still expensive, but this is opening up potentially some to allow us to extend technology.
Okay, thank you.
All right, thank you so much. I do have a question personally, if that is all right. So from what I understand in our university hospitals, we do have integrated AI to assist our radiologists. On your research, is there any confirmation, for example, when they're used in the hospital, we also have the man radiologist or the human to confirm the diagnostic that the AI has given?
I am strongly biased that we need a human in the picture. And so is what I would like to do is provide the radiologist a tool that if they chose to use, they could use it. And the intention is to try and make the radiologist's job easier. And when a radiologist isn't available, perhaps the computer can kind of screen through things and prioritize reading of images to try to help people who need it the most.
Understood. Thank you so much, Danielle, for sharing your presentation. From here, I think we don't have additional questions. We would move on to the code. We would like to remind everyone to scan the QR code and to choose your most preferred presenter. All awards will be presented on the last session of the second day. And as for our judges, please do fill in the forms that have been given to you. Moving on, we'll be having Dr. Sofia Sandalova that will be discussing on the early post-marketing safety profile of fezolinetant in FAERS, a disproportionary analysis with the emphasis of hepatotoxicity. And we will also have the judges, again, Dr. Maxine Gossel-Williams, to join us on this session. Sophia?
Hello, everyone. 1 second, I'm uploading the presentation. Okay, can you see this?
Yes, we could.
Okay, unfortunately, I don't see the camera option to be open. If it's fine, I will proceed. Hello, my name is Sofia Sandalova. I'm a final year medical student from Bao International University, Batumi from Georgia. And today I will present our early pharmacovigilance analysis of fezolinetant in 5 years with the title of Early Post-Marketing Safety of Fezolinetant in 5 years Disproportionality Analysis with emphasis on hepatotoxicity. So our background and aim. Fezolinetant is a non-hormonal neutrogenic 3 receptor antagonist approved for moderate to severe vasomotor symptoms of menopause, especially for hot flushes. After approval, safety communications raised concern about possible liver injury, making early FIR's evaluation clinically relevant. The aim of the study was to characterize hepatic adverse event signals for fezolinetant and to distinguish broad liver test abnormalities such as increased ALT or AST from narrow clinical liver injury events such as jaundice, liver injury, hepatic failure, hepatitis, or drug-induced liver injury. This distinction is important because abnormal liver enzymes don't necessarily mean confirmed clinical liver injury. So we analyzed raw 5 years quarterly ASC2 files from 2023 quarter 1 through 2026 quarter 1. Reports were deduplicated by case ID, retaining the most recent FDA data and the case versions. So the duplicate versions and the same case didn't inflate the signals. The primary exposure cohort included reports which fezolinetant was coded as a primary suspect drug using code equals PS. And the sensitivity analysis, we also included reports where fezolinetant was either primary or secondary suspect. And we also described reports mentioning fezolinetant in any role. Hepatic preform terms we specified and grouped into 2 categories. The narrow group represented the clinical liver injury terms. The broad group represented hepatic enzymes or laboratory abnormalities. We performed case and non-case disproportionality analysis using several complementary methods: reporting odds ratio, proportional reporting ratio, IC 0.25, from Bayesian confidence propagation neural network approach, and the NGPS style EBGM with EB05 shrinkage. We also performed additional analysis using menopause-related active comparator drug, excluded hepatic laboratory terms, 2 reported adverse events, quarterly reporting trends, and based time to onset among reports with complete therapy start and event dates. In total, there were 4,566,098 deduplicated 5 years cases. Among these, 1,761 were fezolinetant primary suspect reports, and 1,776 were primary or secondary suspect reports, and 1,939 mentioned fezolinetant in any role. Primary suspect cohort was predominantly female, with 1,659 female reports, or 94.2%. Most reports came from United States, accounting for 76%, and serious outcomes occurred in 75 reports, or 4.3%. Hospitalization occurred in 49 reports, or 2.8%, and deaths were reported in 2 cases, or 0.1%. So overall, 274 primary suspect reports, or 15.6%, contained any pre-specified hepatic term. Most of these were broad hepatic enzyme or laboratory abnormalities. 249 reports, or 14.1%. Narrow clinical liver injury terms were less frequent, appearing in 32 reports, or 1.8%. The most commonly reported events included drug ineffective, with 219 reports. Alanine aminotransferase increased with 182, hepatic enzyme increased with 171, aspartate aminotransferase increased with 138, and off-label use with 105. Headache with 98, hot flush with 86, and liver function test increased with 84. So the strongest and most consistent finding was a broad hepatic laboratory signal. All 5 pre-specified broad hepatic laboratory terms showed a strong multi-method concordance. Their reporting odds ratio ranged from 11.3 to 49.1. IC 025 values ranged from 2.6 to 5.2, and EP05 values ranged from 5.8 to 38.3. In contrast, codon clinical liver injury was much less frequent. And among narrow clinical injury terms, jaundice showed a signal across all 4 methods, but there were only 8 reports. Liver injury with 11 reports and hepatic failure with 5 reports showed weaker signals that were consistently confirmed by EB05. And drug-induced liver injury, hepatitis, hepatocellular injury, and hepatobilirubinemia were spared to none. The broad hepatic signals persisted in the primary or secondary suspect sensitivity analysis, and when fezolinetant was compared with menopause-related comparator drugs. Expanded hepatic laboratory sensitivity analysis also identified strong signals for hepatic enzymes, increased the liver function test increased, and gamma glutamine transferase increased, and broad alkaline phosphatase increased. Among reports with complete therapy and event dates, the median time to onset for any hepatic term was 59.5 days, and practically this supports careful liver test monitoring and attention to the symptoms such as jaundice, but it shouldn't be interpreted as incidence, absolute risk, or proof of causality. So in conclusion, also raw 5-year data show that fezolinetant was a dominant hepatic laboratory reporting signal, while coded clinical liver injury appears infrequent. The most important message is that biochemical abnormalities and clinical liver injury should be interpreted separately, and these findings are hepatitis generating and useful for pharmacovigilance, clinical awareness, and future research, but 5 years cannot establish the causality, true risk, or incidence, and further studies using controlled observational data would be needed to quantify actual liver injury risk. And thank you for your attention.
Thank you so much again for that presentation. So we'll be calling on again Dr. Maxine Gossel-Williams to join us for this session.
Okay. Thank you, Dr. Sandalova. It was a really very interesting presentation, well put together, and conclusions were right on point in terms of hypothesis generating. You are clearly aware of the limitations of using the database of FDA. My question to you, and I know you did speak at the end about But I just wanted on that, seeing that this is a drug that is going to be useful for a large percentage of the population. Some menopausal women are out there and they're going through these problems, and certainly want to ensure that the drug remains safe, so benefits, outweighing risk. Any recommendations in terms of, the actual assessment of this risk? I mean, hepatotoxicity can be serious. You did record 2 deaths, and we do know that there's kind of underreporting when it does come to adverse events. Any recommendations in terms of actually using this, or, keeping the drug safe in the real world?
I'm sorry, there was some connection problem. I couldn't hear the question correctly. Could you please repeat shortly your question?
Right. So in terms of making sure this drug remains safe on the market, how do you envision actually evaluating this safety issue? Hepatotoxicity is a serious adverse event. Any recommendations other than doing controlled clinical trials?
Okay, thank you for your question.
Dr. Sophie, did you hear me?
Yes. Thank you for your question. And I think the next step should be the active pharmacovigilance rather than relying only on spontaneous reporting system like FHIRs. But for example, large electronic health record databases and insurance claims databases or patient registered could be used to conduct cohort or nest the case control studies. And these designs, they allow estimation of the actual evidence incidence of the liver injury and the adjustment of confounding factors such as age and comorbidities or alcohol use and concomitant medications. And in addition, the continued routine pharmacovigilance is important, but including monitoring new uploaded FHIRs reports and the data from other international databases like EudraVigilance, for example.
Yeah, but all of those are kind of with the same limitations and, the errors, etc. I was looking more at, the fact is that you are going to have patients on this. Are any risk minimization strategies possible? Some more prospective monitoring on your side? What do you think about that?
So I think the most important risk minimization strategy is appropriate patient selection. And before starting Fezolinetant, for example, liver function tests should be performed to identify patients with the pre-existing liver disease or the significantly elevated liver enzymes. And the drug should be avoided in patients with severe hepatic impairment or according to the approved prescribing information.
Okay, thank you.
Thank you for your question.
Thank you once again. If you have no other question, we may proceed to the code. We would like to remind everyone to scan the QR code on the screen and to choose your preferred presenter. All awards will be presented on the last session of our second day. And as for our judges, we do remind you to fill in the forms that were given to you. Moving on to our next presenter, that will be Dr. Chitwanpreet Kaur, an intern of Sri Guru Ramdas University of Health Sciences in India. They'll be presenting When a Fall Turns Black, Acute Esophagus Necrosis in a Frail Elderly Patient, a Rare Case Report. And we'll also want to welcome our judges, which will be Dr. Avi Singhat, to join us for this session. Okay, so please do present the screen and start when you're ready.
I guess there has been a mix-up, but okay, I will also present my slides. Greeting everyone. This is distinguished judges, respected organizing committee, and dear colleagues. This is Dr. Ayan from Osmanian Medical College, India, and I'm presenting my poster titled Burnout Affecting Postgraduate Resident Doctors in India, a Systematic Review and a Meta-Analysis. I like to begin not with a stat, but with a question that led to this research. A few months ago, I was watching an interview with a health policy maker discussing the challenges faced by doctors in India. During the discussion, a thought struck me. We frequently hear that resident doctors are overworked, exhausted, and stressed. But whenever the solutions are discussed, one fundamental question remains unanswered. How many doctors are actually experiencing the burnout? Without a number, it is difficult to measure the scale of the problem, compare it over time, or evaluate whether the policies are making a difference. This curiosity led me to looking for an answer. When I searched the literature, I found that many individual studies from different parts of India reporting different estimates. However, there was no single pooled estimate telling us the national picture among the resident doctors. So we conducted a meta-analysis to answer a simple but important question. What is the prevalence of burnout among postgraduate resident doctors in India? To find that number, we first needed to find every study that has attempted to measure burnout among doctors in India. Following PRISMA guidelines, we systematically searched multiple databases including PubMed, Google Scholar, and Scopus against preferred eligibility criteria and included those reporting burnout prevalence among Indian resident doctors. The meteorological quality of the included study was assessed using the JPI score, and a random effects meta-analysis was performed to account for expected heterogeneity across studies. We also conducted sensitivity analysis and publication bias to ensure the robustness of our finding. This process yielded 10 eligible studies representing 3,062 resident doctors. The question we set out to answer was simple. How common is burnout amongst postgraduate resident doctors in India? Our analysis revealed approximately 1 in every 2 postgraduate resident doctors in India experiences burnout. The forest plot illustrates prevalence was about 50.9% with a 95% confidence interval of 39.5 and 62.2. Although substantial heterogeneity was observed across studies, our sensitivity analysis yielded a comparable estimate, and publication bias was not statistically significant, supporting the robustness of the overall finding. While our study was designed to quantify the burden rather than identify causal factors, long duty hours, heavy clinical workload, sleep deprivation, academic pressure, and limited work-life balance emerged repeatedly as a top contributing factors to burnout. Our study provides to our knowledge the first pooled national estimate of burnout amongst postgraduates and doctors in India. Approximately 1 in every 2 residents experiences burnout, a finding that deserves our attention. Although considerable heterogeneity existed across studies, it likely reflects the diversity of the specialties, institutions, and measurement tools rather than diminishing the significance of the overall finding. In conclusion, while individual studies have highlighted the burnout in different settings, a pooled national estimate provides a clearer picture of its overall burden. This baseline may support future surveillance, guide institutional interventions, and contribute to evidence-informed policy decisions. Yet, as important as this number is for research and policy, it is equally important to remember what it represents. Because statistics don't feel burnouts, doctors do. And that's precisely why measuring this burden is the first step to reducing it. I hope this study serves as a foundation for future research and evidence-informed policies that support resident well-being, strengthen the healthcare workforce, and ultimately improve patient care. Thank you for your time. I'll be happy to take any questions.
Thank you once again, Dr. C. I have a question personally, if that would be all right. So in my country, we do have a lot of burnout in especially on public hospitals. And based on your study, it's actually quite impressive. So if we are to move this to a different country, would you have any other take-home messages that they could maybe learn from?
Yeah, definitely. See, India is a country where the burnout prevalence is like much more than at least compared to other countries. So we can, main take-home message is basically once you measure it, you can try to manage it from the study. So first, if we have to establish the baselines, Then the policy will be informed, and then the reduction in the burnouts can happen. That is the main motto of the study.
All right, thank you so much. So now we'll be going on to the code. We would like to remind everyone to scan the QR code and to choose your most preferred presenter. All awards will be presented on the last session of our second day, so we do hope everybody will join us up to then. As for our judges, please do fill in the forms that have been given to you previously. Moving on to our next presenter, that will be Shivaprakash Kaur, an intern of Sri Guru Ramdas University of Health Science, India. They'll be presenting on when a fall turns black, acute esophagus necrosis in a frail elderly patient, rare case report. And in this session, we'll be having Dr. Avi Sangad as our judge.
Acute esophageal necrosis is, a circumferential diffuse necrosis of the esophageal mucosa, which is basically seen on endoscopy, and the necrosis can be through the mucosal, submucosal, and even the muscularis layer. And the overall mortality is 32 to 36%. And importantly, the demographics mostly is an elderly male, and the pathogenesis is a two-hit model. So first there's going to be usually there's going to be a mucosal ischemia from your usual low flow states like hypertension, dehydration, and hemodynamic stresses, and the second one is going to be a back diffusion of the corrosive gastric acid onto the already compromised mucosa. So most cases you see are going to be elderly male who has these two hits on the mucosa, and you'll see that there's going to be a necrosis of your distal esophagus. Now, why our case is different is because, as you'll see, is that we had an 87-year-old woman who developed a whole esophageal necrosis after a mechanical fall, which is a very atypical trigger, which is also outside your classic demographic. So this patient, she had lots of comorbidities. She was a diagnosed patient of COPD. She had GERD. She had Zenker's diverticulum, recurrent diverticulitis, chronic constipation. She had been treated for spinal trauma. And her only medication was aspirin. So she presented to ER after a mechanical fall. And her hemoglobin was normal at this time, and mild leukocytosis was seen. And throughout her scalp, there were some contractures which were sutured. So on investigations, there was a lot of findings. On CT, we had some chronic ischemic changes. CT cervical spine showed T1 and three compression deformities, and there was a 1 centimeter non-calcified right upper lung nodule. There were some T3 vertebral fractures, and there was a possible acute restricted diffusion near right thalamus. We had diffuse bilateral opacities on chest X-ray, and abdominal X-ray showed a large fecal burden. So the spinal surgery was consulted, and they said that we just need to do some conservative management and give some pain medications and then we just had to follow up for the pulmonary nodule and trauma. Interestingly, that evening, the patient came back to the ER with acute coffee ground emesis and a sensation of something caught in her throat and difficulty swallowing her own secretions. She also reported 2 days of constipation and denied any abdominal pain. IV pantoprazole was started, and a Foley's catheter was placed for urinary retention. Now, during her stay in the hospital, her hemoglobin, which was previously normal, it dropped down, and there was a worsening of WBCs, and urine analysis showed findings which were consistent with UTI. Other findings were normal, and there was another large pulmonary lesion which was seen, and which raised concern for some metastatic disease. So because on chest X-ray there was some free air under the diaphragm this time, so we consulted the GI. Now, given her Zenker's history and foreign body sensation, the GI, they performed an EGD, and what we saw was a black friable mucosa throughout the entire esophagus. Now, this is different because it was just not the distal segment, but like throughout the whole esophagus, and hemospray was applied. And what we saw was that stomach, the cardia and fundus, it was normal on retroflexion. So, on histopathology, residual squamous elements with marked reactive atypia was seen, ulcerations were there, and granulation tissue was there. And we excluded any melanoma, medication-induced injury, and acanthosis nigricans and charcoal ingestion. Now, so what we did was that we put the patient on Nilpar oral for 48 hours, and we gave high-dose IV pantoprazole, IV fluids, and antibiotics. And we avoided nasogastric tube because there was high risk of perforation given how friable and necrotic the mucosa was. Since there were no randomized trials to guide the management of this patient, the approach above reflects our expert consensus, prioritizing mucosal rest, acid suppression, and treatment of the underlying trigger. So on day one, again, we gave NPOs, IV pantoprazole, and the vitals, they started to stabilize. The diet was we just gave her clear fluids, liquids, and she tolerated it well. Purine diet and antibiotics, we stopped it early due to diarrhea. The patient was improving clinically, and so we did not wanted to put her at the risk of endoscopy given her comorbidities and the risk of anesthesia. After extensive discussion with the family, regardless of overall prognosis, the diagnosis of AEN, of frailty, newly identified pulmonary nodules, concerning for metastatic disease, and several functional decline, the patient and her family, they opted for hospice. Okay, the distal, so usually, as I mentioned at the starting of the presentation, that usually the distal esophagus is most vulnerable to EN because number one, it has a limited vascular supply, and then and it is like more susceptible to the acid, the injury due to the acid. But in our patient, because there were multiple factors which converged, given there was acute mechanical trauma with vertebral fracture, physiological stress, pre-existing GERD and Zenker's diverticulum, systemic inflammation, and chronic aspirin use, all of them, they created an ischemic inflammatory environment severe enough to involve the entire esophagus and not just the distal mucosa. This reinforces the need for early recognition of AEN in a frail elderly patient after acute physiological stress, and for integrating the goals of care discussion into management, particularly with advanced age, functional decline, and life-threatening comorbidities. So again, usually we have an elderly man. She was an elderly woman. Usually you have low flow states, and here we have mechanical trauma plus some physiological stresses. The whole esophagus was involved, and multiple triggers were there. So this all came down to the fact that this was an atypical demographic, and the trigger did not change the diagnostic or management approach, but the whole esophageal involvement suggests this presentation was unusually severe. So the key takeaways would be that we need to think beyond the classic profile when considering AEN. The diagnosis and treatment, they stay simple, and goals of care belongs in the algorithm. In frail patients, recognizing the diagnosis is half the job. Recognizing what it means for their overall trajectory is the other. Thank you. I would be happy to take any questions now.
All right, thank you once again for sharing that wonderful presentation. We do have some technical difficulties, and we would also want to have Dr. Avi on the platform with us as our judge for this session.
Hi, am I audible?
Yes, we hear you loud and clear.
Perfect. Thank you. Sorry, I think I'm having some video difficulties, but good job, Chitwan. So I wanted to
Thank
ask.
You so much, sir.
So, in these patients, how is the prognosis beyond just making sure that they're fine outside of the acute interventional state? Are they at risk of having such incidents again? And was the fall possibly causing in part the presentation, or was that likely presentation because she already had esophageal necrosis?
So given that she had a lot of comorbidities, maybe this fall possibly was like a trigger, which kind of maybe she was like, as I said, there's usually a two-hit model, right? So maybe this was like the second hit, which kind of triggered the glucosa to involve the whole esophagus. And regarding your first question, that what is the prognosis? So I think uh, beyond managing the other comorbidities, we need to have like a proper follow-up scheduled for such patients, because we never know when something else can trigger such thing, and we need to make sure that she is diligent with her medications.
Got it. Good job. All the best.
Thank you, sir.
All right, we all have our questions done, so we'll be moving on to the code. Thank you so much, both presenter and judge. We would like to remind everyone to please scan the code and to choose your most preferred presenter. All awards will be done on the last session of our second day, so we do hope everybody would be joining us up to then. For our judges, please do fill in the forms that were given to you previously. Next up, we will be having Muhammad Ons, a medical student second year from Allama Iqbal Medical College, Pakistan. And in this session, we would have Dr. Fernandez as our judge. So Muhammad Ons, please do present your screen and start when you're ready.
Hello, good morning. Am I audible?
Yes, loud and clear.
Okay, so I am Mohammed Faisal, and I am a second year MBBS student at El-Maki Medical College, Lahore, Pakistan. And today I am going to present a case series titled Anti-Odontoid Screw Fixation in Congenital Osteo-dental. It's a 2-case series with post-traumatic or trauma-related symptoms. So this is our research team, and I want to thank the whole team. I'm glad to be a part of it. So let's start. So before we know what actually osteo-dental is, let's talk about the embryology of the odontoid process. So the odontoid process, also known as the dents, basically originate from the C1 vertebra, and later it fuses with the C2 vertebra. So in osteo-dental, so basically what happens is odontoid process becomes as separated from the C2 vertebra, and it becomes as an independent bone and creates an ossicle. There's an ossicle formation here, and this is what we know called this osteo-dental, and it's a congenital abnormality. It's often asymptomatic until it leads to any major trauma triggers it. So it leads to atlantoaxial instability that compresses the spinal cord. Also, myelopathy occurs. The main objective of this case series is basically the standard treatment for this osteo-dental is the posterior C1 to C2 vertebra fusion. But the major disadvantage of this standard treatment is that 50% of the neck mobility is lost. So here it comes with the AOSF, anti-odontoid screw fixation. Basically what happens in this is it preserves the neck motion, while it preserves the neck motion, also stabilizes the fixation, but only in carefully selected patients. So in AOSF, as the name shows, we we move towards the anterior approach towards the patient, and we use biplanar fluoroscopy. We inserted approximately 4.5 millimeter cannulated cortical screw into the vertebra, and then the fibrocartilaginous interface is compressed, and the C1 vertebra normally then would be able to rotate on the C2 as normally it would. So here's the patient selection criteria. We must have a suitable anatomy for the patient, in that we will able to perform AOSF. First, the atlantoaxial distribution must be reducible. Also, the ossicle size must be adequate so that the screw can be inserted into it. The ligaments must be intact. Also, the C2 there's a C2 sufficient body. There's sufficient C2 body dimensions. So here comes with our first case. It's a 28-year-old male case with he came to OPD with acute neck. They complain of acute neck pain since the 5 days. The major thing is here is a minor trauma. Basically, triggers it. Triggers the pain. So his neurological examination was intact, and when we perform the X-rays, the X-ray shows that there's a cortical ossicle which is separated from the body of C2. So here comes with the diagnostic part. So as the minor trauma triggers it, so it confirms that this is a congenital condition. This is a congenital osteo-dental. On dynamic imaging, confirms that the atlantoaxial instability is reducible. Here pre-op films, and it clearly visible in that their well-corticated ossicle is got separated from the C2 body. On lateral view, the atlantoaxial instability is reducible. It was confirmed, and there's a hypoplastic C2 odontoid fragment present. So when we ask the patient, he confirms that there is no significant trauma in the history. So this thing also confirms that this is congenital. And now after surgery, 4.5 millimeter screw is inserted into the vertebra, C1 to C2 for fusion, and the atlantoaxial alignment is maintained. Now, the patient, his clinical outcomes was his clinical was perfect, and after the treatment, the patient pain was reduced, and his there are no neurological deficits present in it, and also there are no other complications occurring in the patient. So he well tolerated the post-operative physiotherapy, as well as the fusion process was ongoing as expected. Now here comes with the second case. It was a case of a 54-year-old female who has achieved complaint of chronic neck pain for 6 months, but the major thing is there is no any trauma that triggers it. Also, her unlike the first patient, so on neurological examination that was intact, and on exam finding it was clear that there's a restricted bilateral cervical rotation. Also, there's a pain on axial loading. So on diagnosing the part, this was the congenital os odontoideum orthotopic type. Dynamic imaging confirms that this was the atlantoaxial instability was reducible. So here comes with the pre-op films, and it confirmed that there's an orthotopic os odontoideum. So also there's a hypoplastic C2 odontoid remnant present. But the interesting part here is that the patient do not have any neck trauma history, unlike the first patient. After the surgery, the screw was inserted, the central positioning was confirmed, also the cervical alignment was preserved in it. So compared to the pre-operative baseline, the patient has uncomplicated recovery. There are no neurological deficits present. There's a meaningful reduction in the neck pain of the patient, and the motion of the neck was preserved. The most important part of that of this AOSF. So here comes the difference between AOSF versus posterior fusion. So the main thing, the most important thing is AOSF has about 81 to 100% fusion rate, while posterior fusion is about more than 95%. There's a very high fusion rate of posterior fusion. But the major disadvantage of it is that 50% of the cervical rotation is lost. But so do not go for that disadvantage. We prefer AOSF, but AOSF offers superior functional preservation only in carefully selected patients with appropriate anatomy. So the conclusion of, in short, os odontoideum can remain silently for years until a major or minor trauma triggers that symptoms into a patient. And AOSF is technically reducible in patients, but only those patients that fits that criteria. All the cross boxes must be ticked in. So after that, we can perform the ASF in those patients. Plus, AOSF provides motion, basically maintains the motion of the neck rather than, and it's the best alternate to the posterior fusion, but only in selected patients, definitely. And in our case, we performed this on 2 patients, and both shows achieved stable fixation with intact neurology and improved function. So basically, it's we need larger studies on this AOSF and a longer follow up before someone calls this settled up. But the results here are encouraging. Thank you so much. I would be happy to take any questions.
Thank you so much for the both of the case studies that you have presented here. Now I would want to welcome again Dr. Fernandez for her questions and evaluation.
Hi, am I audible?
Yes, loud and clear.
Okay, so my first question would be, in Osteo-dental, the transverse atlantal ligament is what actually holds C1 to the dens. So the screw only restores odontid continuity. So how did you confirm that the ligament was intact, and what would you have done if it were incompetent?
Basically, that was a limitation of our case report, that we don't have CT scan and MRI, but we just due to limited resources, and we only have the X-rays. So through that way, we have confirmed this.
Okay. Another question, Osteo-dental is usually a chronic sclerotic non-union, so anterior fixation depends on achieving bony union across an old gap. So what is your evidence that fusion, not just fixation, was achieved, and how are you following it up?
Sorry, could you please repeat the last line?
What is your evidence that fusion, not just fixation, was achieved in your specific case, and how do you plan to follow it up?
Yes, that's we need a longer follow-up for this. But basically, in our case, we have a short follow-up for these two case series on the patient. So future studies should focus on that, so that we can get that answer.
Okay, my final question would be, with only 2 patients and a limited short follow-up, what late complications would worry you, and how long would you need to follow them up before recommending AOSF over posterior fusion more broadly?
20 to 30 years.
Okay, all right. Yeah, that's all the questions I have. Thank you so much for your presentation.
Thank you so much, Dr. Fernandez. Now we'll be going into the code. Thank you again, Dr. Mahmoud. We would like to remind everyone to please scan your code and choose your most preferred presenter. All awards will be presented on the last session of the second day. And we do hope everybody will be joining us up to then. As for our judges, please do fill in the forms that I have given to you previously. All right, welcome back once again to our IJMS World Conference of Medical Student Research, Day 1. And we will be continuing with our next presenter, which is from the University College School of Medicine. It will be Vivian Wong, who will be presenting to us her titled Clinical Outcomes Following Uterine Artery Embolization for Uterine Fibroids, a Retrospective Cohort Study. And we'll be joined by the judge, Dr. Fernandez, once again. Please do present your screen. Wong, Vivian.
Hi,
All right.
yes. Can you hear me?
Yes, we hear you loud and clear, and you may start once you're ready.
Okay, perfect. Hi, everyone. My name is Vivian Wang, and I'm a medical student from University College Cork in Ireland. And today I'll be presenting a retrospective cohort study on clinical outcomes following uterine artery embolization, also known as UAE, for uterine fibroids. So uterine fibroids are the most common benign tumor of the female reproductive tract, detected in up to 70% of women. And while many women are asymptomatic, between 20 to 50% can develop clinically significant symptoms that seriously impair quality of life, including heavy menstrual bleeding, or also known as menorrhagia, pelvic pain, urinary symptoms, and infertility. Traditional surgical management options include hysterectomy and myomectomy, but these carry significant risks, and in the case of hysterectomy, loss of fertility. UAE is an established, minimally invasive, uterus-preserving procedure involving the catheterization of the uterine arteries and injection of embolic particles to cut off the fibroid blood supply, with the goal of fibroid shrinkage. UAE has been shown to have similar quality of life outcomes and lower peri-procedural morbidity compared to the surgical options of hysterectomy and myomectomy, but higher rates of reintervention long-term. Therefore, continued real-world evaluation is needed, and our study aimed to evaluate complications, reintervention rates, symptom improvement, and fertility outcomes following UAE in an Irish tertiary center. This was a retrospective single-center cohort study, and the study was conducted at Cork University Maternity Hospital, a high-volume tertiary referral center. We screened all UAE procedures performed by a single interventional radiologist from November 2021 to December 2024. And after exclusions for things like non-fibroid indications or insufficient records, 114 patients were included. The flowchart to the left here shows that 123 patients were screened and 9 were excluded, leaving us a total of 114 patients in the final cohort. And our primary outcomes were the occurrence of periprocedural complications and reintervention rates. And then our secondary outcomes were menstrual symptom improvement and observed pregnancy outcomes. The analysis was descriptive with Wilson coefficient intervals and a complete case approach for missing data. Patients had a mean age of 45.5 years old and a mean BMI of 29.5. The majority were premenopausal at 88%, and a median follow-up post-UAE procedure was 119 days. Menorrhagia was by far the most common presenting symptom in about 80% of patients, followed by pelvic pain, pelvic pressure, urinary symptoms, and dysmenorrhea. The mean largest fibroid was 9.2 centimeters, and most patients had multiple fibroids. Complications occurred in 18 of 112 patients with a rate of 16%. The majority were moderate complications such as post-procedural pain, post-embolization syndrome, fibroid expulsion, and infection. 12 of the 20 total complication events occurred in the periprocedural period, so within 30 days of the UAE. And we did observe 2 severe complications, 1 case of small bowel obstruction requiring laparoscopic adhesiolysis, and 1 delayed fistula formation in a complex patient with pre-existing pelvic pathology. Reintervention occurred in only 6 patients with a rate of 5%. Over the available follow-up, which was a relatively short period in this study. Looking at our secondary outcomes, menstrual symptom improvement was documented in about 75% of patients, though this is lower than the 90% reported in previous prospective studies. Those studies used validated questionnaires while we were relying on clinical documentation. Regarding fertility, only 7 patients expressed intent to conceive, and 2 of these conceived spontaneously post-UAE, but both resulted in first trimester miscarriage and no live births. Importantly, fertility intent was not routinely documented for about 87 patients, limiting these conclusions. And these results are directly consistent with the literature that conception is possible, but outcomes are variable. So what does this mean in practice? First, this real-world population validates the safety profile previously reported in landmark RCTs, confirming that UAE is appropriate for a carefully selected population. Second, although reintervention rates are low in our study, patients should be counseled about potentially higher long-term reintervention risk with UAE compared to surgery, as evidenced by previous long-term RCTs. Third, our fertility data reinforce that UAE can be considered in women wishing to preserve their uterus, but careful counseling about age and reproductive goals is paramount, particularly in women over 40. In summary, UAE demonstrated a favorable early safety profile in this cohort with a complication rate of 16%, a low reintervention rate of about 5%, and meaningful symptom improvement in about 75% of patients. Fertility desire was low in this predominantly older cohort, while spontaneous conception was observed, there were no live births recorded post-UAE. And so our data add to the evidence base supporting UAE as a safe, effective, and uterus-preserving option for symptomatic fibroids. I'd like to thank my colleagues, Dr. Zibi Markovsky and Yusuf Garaz, for their guidance and contribution to this research, and the IJMS conference for this opportunity. Thank you, and I'll take any questions.
Thank you so much for that presentation. Now we'll be calling on Dr. Fernandez to join us for this session.
Thank you so much for your presentation. So the first question I'm going to have is a median follow-up was only 119 days and symptom data existed for barely half the cohort. Yet fibroid regrowth and reintervention after UAE typically surfaced at 2 to 5 years. So how much can this data set really say about efficacy?
Yeah, so for those data points in particular, we can't really make any definitive conclusions. I think that further studies with prospective studies with a longer follow-up period are definitely needed in order to make better conclusions about that. But our study definitely adds to the existing literature to show that there are risks for reintervention post-UAE, which is important to consider when thinking about your options for fibroids.
Okay, thank you. My next question is, you report no association between complications and fibroid size or number, but with only around 18 complications, are you actually powered to detect one? Did you analyze this? Did you check it?
Yeah, no, so we're not powered to make any definitive conclusions for that. Unfortunately, we only had 20 complications and we weren't able to do any multivariable analysis or anything like that. So that is something that future research should definitely address. And that is a limitation of our study for sure.
Okay, and my final question is, how do you handle the missing symptom data? Was it a complete case analysis on the 59, and how could that bias the 74.6% figure?
Yeah, for sure. So it was, we did use a complete case analysis. So we only looked at the cases that were documented. And so this approach is more of a conservative approach, and this underrepresents certain outcomes in this group. And that's a genuine limitation. And so further research should address this as well.
Okay, that's all from me. Thank you for your presentation. Thank you so much.
Thank you.
Thank you so much, both. Now we'll be proceeding to the code. We would like to remind everyone to please scan the code and choose your most preferred presenter. All awards will be presented on the last session of our second day. So we do hope everybody would be joining us up to the end of our conference. And as for our judges, please, we do remind you to fill in the forms that have been given to you previously. We're back up and we'll be going on to the presentation of Marafi Ahmed Abdelrahim, a third-year medical student from the Faculty of Medicine, Alziam Al-Harazi University of Sudan. And his video is actually a poster presentation on enhancing science communication skills among medical trainees through an interactive online workshop in Sudan. And for this session, we would have Dr. Torres and Dr. Ali Singan as our judges on the session.
Good afternoon, everyone. My name is Marafi Ahmed, and I'm a third-year medical student at the IJMS University. And on behalf of my co-authors from the University of Khartoum, I'm going to present our abstract entitled Enhancing Science Communication Skills Among Medical Trainees Through an Interactive Online Workshop in Sudan. So as an introduction, effective science communication is essential for improving public understanding, supporting evidence-based decision-making, and combating medical misinformation. Yet beside that scientific knowledge, many medical students and early career researchers lack the practical skills needed to communicate complex scientific information in a way that is clear, accessible, and engaging for the public. Therefore, our aim was to equip medical students and early career researchers with the skills needed to communicate science effectively. And to address this gap, we designed a practical interactive training program. So let me briefly walk you through our methodology. We conducted a 4-day interactive online workshop involving 20 medical trainees with varying levels of research backgrounds. The workshop consisting of 3 interactive sessions covering the foundations of science communication, simplifying complex scientific concepts, storytelling techniques, target audience analysis, and message tailoring. On the 4th day, participants work in small groups to apply these skills by designing educational posters and delivering simulated presentations tailored to specific public audiences. And to evaluate the effectiveness of this workshop, participants completed pre- and post-workshop assessments using a 5-point Likert scale. We analyzed our data using JMovie software, and due to the normal distribution of our data, we applied the Wilcoxon signed rank test with a statistical significance set at p-value less than 0.05. After implementing this training program, we evaluated whether it produced measurable improvements. So here are our findings. 15 participants completed both the pre- and post-workshop assessments. We observed a statistically significant improvements across all evaluated domains with a p-value less than 0.05. For example, participants' confidence in simplifying scientific information increased from a Ammineni score of 2.13 before the workshop to 3.73 afterward. Similar significant improvements were observed in defining science communication, identifying target audiences, applying storytelling techniques, and selecting appropriate communication platforms for messaging. Participants also reported a high level of satisfaction with an average rating of 8.7 out of 10, and most indicated that they would recommend the workshop to their peers. These findings highlight the value of structured science communication training and lead us to our main conclusions. In conclusion, our study demonstrates that structured interactive science communication training can effectively improve both knowledge and confidence among medical trainees. These initiatives help equip future healthcare professionals with the skills needed to communicate scientific evidence clearly, engage diverse audiences, and maximize the societal impact of research. Therefore, we recommend integrating evidence-based science communication training into medical education curriculum and expanding similar programs to reach a broader groups of healthcare professionals. Effective science communication is no longer an optional skill for healthcare professionals. It is an essential component for improving public health and strengthening trust in science. Finally, I want to thank the Student Association for Medical Education and Research, or SAMER, for their valuable support. Thank you so much for your time, and I'm happy to address any questions you may have.
Thank you once again for this presentation. Now I would want to welcome once again Dr. Tanya Plet-Torres and Dr. Avi Singan to join us in this session. Hello both.
Hi.
You may start with questions.
Hi, Marafi. I love your research work because it is a very important field for medical students that should develop during their training and after the training when you are professionally working as a medical doctor. No, but I have just one question, and as I read your abstract, I wonder if you made any comparison between the outcomes when you analyzed postgraduate students and undergraduate students. Did you see something different between them?
Actually, we didn't separate the participants if they're undergraduate or postgraduate really. This is a very good question. We can consider this in our future workshops or future activities. Thank you so much.
Yeah, because mostly, as a postgraduate, maybe you have like more, chances to become, I don't know, a lecturer or a professor or something. And somehow you have like more opportunities, no, to develop these skills. And another question that I have is if you, I know that you have already done this analysis, but if you have the information of other programs that these institutions where these medical and postgraduate students come from, in terms of if they have the opportunity to become, I don't know, like support teachers to their teachers when they are in the undergraduate studies or something. Do you have that information? Just like to analyze it, like to compare if also those programs may help them together with obviously all the tools that you gave them in this like workshop. Maybe this can enhance the communication skills that they had. I don't know if you have that information.
Do you mean that they have previously attended same workshops as these workshops?
Or
Yeah.
they serve like the support teachers for, you have your professor in your class, and then you have like the young teacher that is currently studying medicine. I don't know if you have that information.
Currently, I do not have this data, but I can working with my peers to searching for this information.
Maybe it could be possible that some differences may be, important, and this information also helps these programs to know if they are working or not in these communication skills. No?
Yeah.
These are my questions. Sorry, Abby, I speak too much.
Thank you.
Thank you very much.
It's a pleasure. It's a pleasure to listen. Thank you, Marafi. I think that was great. This is something also very close to me, that you are able to intervene and then make it into a research. So it kind of stays there for people to follow up as well. One thing that I personally am always interested is this like a one-time thing, or do you plan to follow it up? Is there a bigger plan for it? And sometimes that just means, like Dr. Torres said, making sure like other programs can kind of take away something from it, or like people who've learned in this intervention become the teachers for another intervention, things like that. Are there plans like that? Because I know like the sample size as of now in these med-ed interventions is impactful, and the outcomes are supposed to be interpreted a little differently because it's hard. But it's 15 people in that intervention, right? So I would love to see a greater number of people from across the spectrum.
Yeah, our main goal, our main objective was to measure the impact directly after the workshop. But we, as our concluding, our conclusion, we recommend to expand this training to our, to a broader network of healthcare professionals, and to integrate this evidence-based communication skills training in the medical curriculum. So we can participate, or we can make collaborations with other institutions to make this training in a broader sample size, and to enhance this training by addressing the limitations that happen in our activity right now.
All the best. Thank you.
Thank you.
All right, thank you both judges and as well as our presenter for this wonderful discussion. Now we would be presenting the code for everyone to scan. Please do scan the code and choose your most preferred presenter. All of our awards will be presented on the last session of our second day. So we do hope everyone will be joining us up to then. Judges, please do fill in the form that were given to you previously. So moving on, we will be having the pre-recorded video of Shiraz Kazim of Admir Undin Medical College Postgraduate Medical Institute of Lahore, which will be talking about the social media-induced guilt loop of FOMO, a cross-sectional study in the implicit cycle of social media consumption in medical students. And in this session, we would also want to invite Dr. Sagid Mukhida as our judge, and as well as Muhammad Imad to join us in this session. We will be sharing the pre-recorded video in a bit. Research on social media-induced guilt loop and fear of missing out. Medical students heavily depend upon social media for lectures, notes, group chats, and communication exam prep. However, increased social media is linked to fear of missing out. So what connects the two? This is our question. And the answer is one word: guilt. In our study of more than 1,000 medical students across Pakistan, we found that guilt is the underlying psychological mechanism that turns heavy social media usage into fear of missing out. And these three processes perpetuate each other in a cycle we call the guilt loop. Social media has nearly 5 billion users. For medical students, it's not just about fun, it's about lectures, it's about communication, it's about notes, exam prep. So heavy usage doesn't automatically translate into a bad thing. At the same time, medical students have suboptimal mental health as compared to general population, primarily because of academic stress, as explained by Bergman and colleagues in their research. So the real question is not how many hours they spend on the social media, it's what that time they spend does to them. Medical students sit with these three problems. First, the problematic social media usage. The second is fear of missing out. And the third is academic guilt of wasting time. These are common. Saad and colleagues in Egyptian medical students found that more than half, 58%, report real FOMO, fear of missing out. However, the catch is most studies just look at one of these aspects at a time. And there is paucity of literature on how these three aspects lock together. When other studies try to explain how heavy usage leads to harm, they put FOMO in the middle as the mediator. Chen and colleagues in Chinese medical students found FOMO explained the whole link between use and the negative emotions. Yang described the same FOMO and addiction cycle in 2025 paper, actually titled Caught in the Loop. So the idea is of loop is there, but the real question, but every version that exists out there puts FOMO in the middle. What's missing is guilt as the mediator. When guilt shows up at all, it's shown as a side effect of overuse rather than a link that carries the problematic social media usage into fear of missing out. So, put simply, no one has modeled heavy use, guilt, and FOMO as a self-feeding cycle in medical students with the guilt as the link, as the mediator. Three things are missing. There is no named cycle of such kind. Guilt is often left out of the model or simply treated as outcome of overuse, and academic FOMO of wasting time. The fear of falling behind in your studies from your peers is rarely looked on at its own. Our goal was to measure how heavy use, FOMO, and guilt in a big national sample and see how they connect, how these three aspects connect. 5 objectives take us from how common these are to how they link and to what predicts each one. It was an online survey ran across medical students from Pakistan in August 2025, medical students from public and private medical colleges, male and female, who gave consent. And we collected 1,033 responses after inclusion and exclusion criteria. We analyzed a sample of 1,023. One number to remember here, though, is that we only require 385 a sample size of 385. However, we collected 3 times more the sample size to increase the reliability of our results. three tools. We used three scales: Burgeon social media addiction scale, FOMO, and we customized it into two parts: academic FOMO and social FOMO, and a custom built guilt scale. Although the internal consistency of guilt scale was compromised, but it's still an initial version, and to build a better scale is next step moving forward. However, the scale does what it was intended to do, and that would be explained in these slides. We worked step by step. First, we ran like the basic numbers analysis, descriptive analysis, then group comparisons, correlations, then the mediation and moderation analysis to test whether guilt is the link, and finally the three prediction models using linear regression. Over 1,000 medical students and over half male, mostly from public colleges and heavy users. 3 in 4 spend 3 or more hours a day on social media, and every year is studied. The thing is, 45% use social media more than 3 hours per day, and another 35% use social media more than 5 hours a day. So the question to ask is, isn't that just normal given the circumstances nowadays? Yes, and that's the point. Whole point is this: when almost everyone is a heavy user, the spending hours per day stops telling you who's actually in trouble. And what matters is losing control and feeling bad about it. So guilt is a better clue than hours spent on social media. Our scales, they all these three aspects move together strongly and significantly. Use and FOMO, use and guilt and FOMO. When one goes up, the other also goes up. That's the first sign that loop is real. And here is the guilt loop visualized. Heavy use eats into your study time. Students notice the lost study time and feel guilty. That guilt makes them extra aware of what others are doing and how they are falling behind. And that leads to FOMO, both academic and social FOMO, and which makes the guilt worse. And round and round and round it goes. This is the main result. On its own, heavy use has a strong effect on fear of missing out. But when we add guilt as the mediator, that effect drops by more than a third and stays significant. In plain terms, what this means is guilt carries a big part of how heavy usage turns into fear of missing out. And it works the same way for men and women. So while other students put fear of missing out in the middle, our data put guilt there. And that's the heart of the talk. Women scored higher on both guilt and FOMO, and the guilt gap was the biggest difference we found. And the interesting part is heavy use itself was same among men and women. So women aren't using social media more, they are just feeling it differently, carrying more guilt from the same amount of use. And that fits wider research showing women tend to report more guilt. Three prediction models, and notice the pattern. Each one is predicted by the other two. Guilt is predicted by use and FOMO. Use is predicted by guilt and FOMO is predicted by guilt and use. Everything feeds everything. That's why a loop looks like. And the sharpest finding is FOMO is predicted by guilt and by heavy use, but not by the screen time or things like age or gender. The feeling drives it, not the hours spent on the social media. And that's the whole point of the study in one line, actually. Three well-known ideas explain how the loop turns. The Higgins self-discrepancy theory, what you want to be and what you are, and the guilt because of this gap. Then Festinger's social comparison theory, seeing classmates wins online makes you feel left behind. You are overly sensitized. That's FOMO. And Carfeld's Winter's idea of compensatory internet use, when you use social media to escape the stress, and it digs you deeper into this loop again. Strengths of our study include a big national sample, tested scales, and analysis that goes past correlation to test a real link, mediation and moderation analysis. And the limits are the cross-sectional design and the limitations associated with that design. One message to take away is deal with guilt, not just the screen time. Our study shows heavy use is part of an emotional cycle with guilt at the center. Academic FOMO turns out to be real, separate thing teachers should watch for. And it means simply telling students to cut
screen time won't work. We have to deal with guilt, perfectionism, and comparing themselves to others. And these are psychological aspects of medical students' mental health that need to be dealt with rather than just asking them to cut your screen time. Because if guilt is the link, then guilt is where we step in. And guilt is where, and this at this link, we provide the intervention. Thank you.
All right, we have just witnessed the pre-recorded video. Now we'll be having Dr. Sajid, Mukhida, and Imad to share their suggestions and concerns regarding the video. Hello? Hello?
Yeah. Am I audible?
Yes, you are audible.
Okay. The study was good, and they are almost focused on the topic which is currently actually required. Means guilt in the using the social media in the medical students. It is now the way of everywhere. Now we have a means it was a pre-recorded video. So can we ask the question to the participant because he is not here.
You may leave the question here for him to ponder on. Yes, that is possible.
Okay, because we want to know that they are discussing about the more than 3 hours and more than 5 hours of using the social media in the day. But which is part they are detecting as like they say that this is a social media use because now the currently many of time for the medical students the using the social media it's a now screen time is more because like they have a teaching on the screen now pre-recorded videos all the sessions and also there is a online classes also ongoing. So if they are counting this thing in like social media using or they are just using this counting the only social media like Facebook or any other social media websites. So this is the thing I have to ask first thing. And second thing that guilt is like what is the outcome like after the guilt if person is feeling the guilt what is the they are thinking what they are planning to do the removing this guilt what is their output like after the getting the guilt is like understand that person is getting the guilt but what they are want to do the removing this guilt. So I'm writing my question on the chat box, so you can that transfer that question to the participant.
Thank you, Dr. Mukhida. Dr. Imad, would you have something to add as well?
Yeah, this is a very interesting study regarding social medias. We're all like in this loop. However, I have a question for the author of the study. If they like thought about in terms of comparison between others and discrepancy and so on, have they thought about the image, the self-image perceived after social media use? This is my question of for the authors. Like, for example, they have validated and they have included some questionnaires and some items, but will they be considering the effect of social media on body image, the effect of social media on performance, especially as students in the universities?
Thank you. Thank you for adding that. And as personally, since I am a Chinese medical student, I would want to comment on a certain thing that he have noted. Maybe he would want to consider the social aspect as well of the pressure between the peer pressure, since there's a lot of, maybe it also is related to the confidence of the student itself when it comes to learning. So I'm not sure if he have actually looked into that in his study. So hopefully this is something he could look into as well. If we do not have any other questions, we can proceed to the code. Thank you, both doctors. We would like to remind everyone that the code on your screen is to get or to choose the most preferred presentation in this conference. All the awards will be presented on the last session of our second day. And on our judges, please do fill in the form that was given to you previously. Moving forward, we will be having Marina Lobo Carvalho, a medical student on Santo Amaro University, and she will be presenting on the impact of AI-based educational intervention on academic performance and learning in medical students. For this session, we would want to invite our judges. Dr. Fatima, would you be with us today? It seems that she is not here. We would want to request both judges in the previous sessions to stay and to listen to our presenter right now. Thank you. Marina, if you're ready, you may start.
All right, I'm ready. Thank you for having me. Everyone, I am a medical student at Santa Amaro University, UNISA, and today I'm going to present impact of AI-based educational interventions on the performance and learning of medical students, a meta-analysis. So to begin introducing what we are talking about, today is very difficult to the medical student to understand all the content and everything he needs to learn in the traditional way. So medical education demands customizable approaches, which are still poorly met by the traditional models. AI-based interventions such as intelligent tutors, adaptive platforms, virtual patients, and language models offer personalized learning, enhanced formative feedback, and reduction in the extrusion's cognitive load. What does that mean? It means that we have a student with needs and we have model personalized learning tutor that can meet its needs, so he can study more with less cognitive load. Our objective was to evaluate and quantify the impact of AI-mediated educational interventions on the academic performance of medical students compared to traditional non-AI-based methods. So, the method search and selection. The study type, systematic review with meta-analysis conducted according to the guidelines. We used the databases PubMed, LILAC, Cielo, and the period was January 1st, 2015 to December 31, 2025. We decided to use the languages Portuguese, English, Spanish. What was the eligibility of the studies? So first, experimental or quasi-experimental studies, undergraduate medical students, the intervention AI-based educational strategies, the comparison traditional or non-AI-based methods, and the outcomes, objective learning outcomes or academic performance. Did they get better? Did they get worse? What was it? So the quality assessment, our methodological, we decided ROB2 for randomized clinical trials and Robbins I to non-randomized ones. Performed by 2 independent reviewers, and if they had any disagreements, a third one reviewer decided which one. And the quantitative synthesis random effects model and the effect size hedges G. I'm going to say that furthermore. And we didn't need an ethical review because we didn't use the human one exempt from the ethical review. And it was registered in the Prospero, International Prospective Register of Systematic Reviews. So, our key results. 231 records identified in the initial database research, but only 81 studies included in the final qualitative analysis. But because this is a meta-analysis, only 10 clinical trials were included in the meta final one. In here, you can see the Prisma flow diagram 2020. And also, we did not find the risk of bias assessment in the patterns that would compromise something of the validity and robustness of the quantitative synthesis. So I'm going to say of these 10 included clinical trials of the AI-based intervention, we have an overall effect of 1.07, which is very high. And the heterogeneity was 48%, which is considered moderate and expected for this study. So the overall impact, the AI-based interventions were consistently superior to the traditional methods. And the greatest benefit was the strongest gain in preclinical settings with adaptive feedback and on platforms featuring guided decision making. Yeah, you can see the forest plot on the global effect of AI-based interventions here. So the meta-regression, what does that mean? It means that the student that had the most difficulty could gain a lot in his performance, and also the students who were already good also gained a lot in his performance. So 39% of variability explained, a lower baseline performance, greater gain, which I said, adaptive feedback increased the effect. So overall, the findings indicated that AI-based educational interventions yield robust and consistent improvements, which greater benefit over it when there is adaptation on the student's level, complex feedback, and application in preclinical context. The best one was the adaptive platforms, chatbots, intelligent simulations. So the narrative synthesis, types of interventions and mechanisms of effect. 1. Adaptive platforms, greater overall impact with dynamic difficulty adjustment based on student performance. Clinical chatbots, gains in clinical reasoning, communication, OS performance. OS means that it's a practical test. You need to respond quick. 3. Virtual patients, improvements in clinical decision-making, knowledge application. And 4. The equalizing effects, greater benefits of students with lower initial performance, promoting equity. Very important in today's world. In conclusion, curricular implications. We want to consolidate evidence. Educational AI fosters consistent and significant improvements in academic performance, particularly when integrated into structured pedagogical models. Key contributions: personalizing of learning, reduction of cognitive load, enhancements of self-efficacy, promotion of educational equity. Complementary role: we want to say the AI is not going to replace the human teacher. Acts as a complementary tool rather than a substitute of the teacher on clinical practice. Requires instruction, supervision, and curricular alignment. We have an ethical responsibility, necessity of critical digital literacy, and ethical responsible use of AI technologies within the educational context. Thank you so much. Here are the references, and you can see the full abstract in the QR code. Thank you so much.
Thank you once again for that presentation. Now I would call on to the judges, Dr. Imad and Sajid Mukhida, to join us once again.
Yeah, thanks for this great presentation. Have you checked, like in your narrative review, whether there are differences or superiorities between the paid AI models and the differentiation between the AI models in terms of the clinical practice and in terms of the assisting learning?
Sorry, can you repeat that? I think my Wi-Fi connection is kind of slow. Can you repeat the question, please?
Yeah, sure. In your narrative review, have you checked for differences in regarding to the AI models in terms of students' perception of the learning, and how, like for example, ChatGPT or Gemini or any AI model, is there any superiority in terms of assisting the students in their learning and the questions and so on?
So the different AI ones, they are kind of similar because in these studies, we wanted to see how the student would use the AI who would adapt to the study in real time. So they all are doing kind of the same. They are using the content to study, and then they go do the test, and then you get the grades. And I analyzed, I am the co-author, I'm not the main author, but we analyzed the grades. So it's not specific like did ChatGPT did better than the Gemini. Is mostly like the student that used the AI had a great improvement in the grade than the student that used only the library book and only went to the library and did the grade. So the AI can have infinite patience with the study, the student. And the book, you need to go back and forth, back and forth, back and forth with a great load of cognitive. It gets tiring very fast. And the AI can explain again and again and again and again and adapt to your answer. So it's not really a matter which AI is better, but using it gets you to study more and be more prepared to your test and to become a better doctor in the future.
More questions, Dr. Sajid?
Yeah, it was a good systematic review, but I have a question about your duration, which study you are selecting, because like you selecting from January 2015, you selecting from January 2015 to December 2005, but when we know that AI is coming in the market around like after 2020, so before the 2020, there were not that much AI models are there. So there was study duration, which you selected. Actually, it's not required. Like you have to select after 2020 or maybe after COVID pandemic when we are actual understanding about AI tools and then when. So your narrative review, you are taking, I mean, systematic review took the time is around like 11 years, but actual the study, whatever found is between the like 2021 to 2025, around like 4 to 5 years, not that much bigger. Second thing, that previous you receive get actually only 10 RCT. You get only 10 RCT. You are not getting like, means if you are selecting the 11 years period, so you will get, you should have to get around like more than 100 study which have actually RCT, but you get only 10 RCT. Your duration was actually not right. So if you get the only 10 RCT in the last 5 years or so, you have to write your duration around like 2020 to 2025, like that. That was my observation from you.
Okay,
Second
so
thing,
can I see if I understood what you said? You're talking a little fast. So you're talking about the time period from 2015 to 2025, and you're also talking about only 10 of the ones that made it to the final one, right?
Yeah. So in your 10 RCT, my question is that on your 10 RCT, which is the oldest one? Just give me which RCT means you have a 10 study. So like which is old one, like around like it's a 2015 study or it is a 2017 study or 2020 study or whatever. Which is the oldest study? Means here I just want to ask you about.
Okay, so why did we choose from 2015 to 2025? And yes, there are 10 studies that are from around it. It's because even though the AI only got more popular after the pandemic, it doesn't mean it started happening in the pandemic. So we got more popular at using it in 2020, just like you said. But we started using it, and it started having things to observe in the articles before the pandemic, actually. But it wasn't so popular. And do you understand me? So
I understand. I'm saying means if you got the like 300 or more than 5,000 study or like that, so you will not remember, but you remember, you get only 10 RCT. So I am asking you, the out of 10, which is the earlier study or which is the older study, means which year. I want to ask the year in your 10 RCT, which is the oldest?
The oldest one is 2017.
17. Okay. And what is the actual the result of the 2017? What they are like? It is match with your conclusion, that your conclusion is that AI cannot be replaced the human teachers. Oh, it's a 2017 studies, I think, conclusion. But now when you reach to the 2024 or 25 study, what is their conclusion? That all the have a same conclusion?
The conclusion is that the AI is helping the students and it's learning very fast and becoming a very important tool for us. But the teacher is not going to be replaced. It's only to help everything.
Definitely. Okay. Yeah.
Marina, Dr. Sajid,
Yeah.
if I
Okay.
would
Okay. Yeah. Understand.
wrap it up.
Yeah.
What
Yeah.
Dr. Sajid is
Yeah.
trying
Yeah.
to say is that an AI produced in the 2017 is inferior to AI produced in 2024, and hence the validity of information given to students studying in AI in that period, like in the older years, is not like the validity and update of the information that we study using the AI in the last recent years, if that makes sense. So we can't like possibly compare and do systematic review between studies doing on older and like naive AI in 2017 with those doing research on AI that is more advanced in 2024 or 2026.
Okay. Now wrap up these things. Okay. We have another presentation also there.
All right. Thank you both doctors for providing your suggestions. So I think Marina, you could get on the suggestions from both doctors to include it on the limitation and as well as reconsider the the guidelines of your study or the points of your study. Okay. So we'll be moving on to the code. Thank you so much.
Thank you so much, everyone.
We would like to remind everyone to please scan the code in front of you right now and to vote for your most preferred presenter. All our rewards will be presented on the last session of our second day. And as for our judges, please do fill in the form that was provided to you previously. Moving on, we will be having Julia Moore, a fourth-year medical student from Edward Via College, Osteopathic Medicine, Louisiana campus, USA. And she'll be presenting on the National Pediatric Ophthalmology Survey Workforce Shortage, Telemedicine, and Advocacy Priorities. Yeah. And on this session, we'll be joined by our judges as well. Dr. Adani for this session. Yeah. All right. So please do present.
And
Yeah.
can you see my screen? Okay, perfect.
Yes.
All right, well, hi everyone. Like Justin said, my name's Julia. I'm a medical student and I'm excited to talk to you all about a survey-based project I had the opportunity to be a part of, looking at American pediatric ophthalmologists' perspectives on a wide variety of topics, including the current workforce shortage in America, the use of telemedicine, and some advocacy priorities amongst the providers. So first, let's just talk about the current landscape of pediatric eye care in America. So for every 3 pediatric ophthalmologists, there's about 1 million Americans. So let that sit in for a moment. About 90% of US counties lack a single pediatric ophthalmologist. And for your non-urgent, just standard referral for a pediatric eye exam, families can expect to wait up to 6 months to see a provider. And this really matters because pediatric eye diseases are very time sensitive often. So it's been well studied and established that diseases like amblyopia, strabismus, retinopathy of prematurity all have improved long-term visual prognoses when they're diagnosed and treated earlier rather than later. And this isn't just an impact for kids visually also develop mentally. So it was studied and documented that 80% of classroom learning is visually mediated. And then also just from a psychosocial standpoint, when studied, it was seen that patients with visual impairment or children with visual impairment, when compared to their non-visually impaired peers, had a higher rate of both anxiety and depression. But I think the most shocking statistic is that in the US, 50% of childhood blindness was due to a preventable and treatable cause. So don't just take my word for it, though. We have Dr. Glockenflecken and several other researchers and providers emphasizing the gravity of this issue. So back to our study, we created a cross-sectional anonymous national survey, and we distributed it through the American Academy of Pediatric Ophthalmology and Adult Strabismus' online discussion board through April to May of 2026. And in order to complete the survey, you had to either be a currently practicing pediatric ophthalmologist or a pediatric ophthalmologist that retired within the last 10 years, or a current pediatric ophthalmology fellow. And you also had to be an APOS member or eligible for membership to APOS. And that was just to ensure that the respondents could practice in America, because we were looking at US data for this project. We mostly just looked at the data descriptively rather than subcategorically, or we didn't really break the cohort up and sub-analyze in that way. This is our survey here. It was 38 questions, and we administered it through REDCap just to ensure secure data collection and storage. And we looked at 5 domains of questions, and we'll kind of break them up one by one when we talk about the results of our survey. But first, let's just talk about who answered our survey. So 67 respondents completed our survey, and admittedly that's a very modest response rate. I'm happy during the question portion of this presentation to kind of go into why we feel it was that way. But nonetheless, we had 67 experts in this field provide their insights, so we feel that this is still very meaningful data to present to you all today. The majority of respondents were female, practicing in an academic center and more established in their career, so more than 15% 15 years removed from their fellowship training in pediatric ophthalmology. So now looking at the results. The first domain of questions looked at the workforce and training topics, and we thought that this outcome was really interesting for this question. So as you'll see when we go on, there was usually a majority consensus with the questions that we asked, but for this one it was about a 50-50 split. And so currently there's many solutions being proposed to help decrease the current workforce shortage of pediatric eye providers in America. And one being that there be a fellowship in pediatric ophthalmology that's non-surgical, outbranched from your general pediatrics residency. Right now you go into pediatric ophthalmology fellowship in America after completing an ophthalmology fellowship that is surgical. And you can see here that about 50.7% of respondents felt that this could be a solution that could help mitigate the workforce shortage, but 49.3% of respondents thought that this was not a proper solution to consider. Then looking at the use of telemedicine, we see here that the majority, 71%, agreed that telemedicine can improve access to care for kiddos that can't be seen by a pediatric ophthalmologist easily, and that 76% even think that retinopathy of prematurity can be adequately screened with telemedicine approaches. But the majority, so about 69% of respondents, or 2/3, stated that the over-reliance of telemedicine could cause some issues, and that really the overall solution won't be through telemedicine, but rather having more physical manpower and more hands on deck, more providers, but that this is a helpful kind of tool in the toolbox. And then for our advocacy domain, we saw that lack of time, by no surprise, was the largest barrier for pediatric ophthalmologists to hindering them in engaging in advocacy efforts, and that the number one advocacy priority amongst the pediatric ophthalmologists that completed the survey was just expanding insurance coverage. And then for the financial, medical, legal concerns domain, we saw that almost 100% of respondents thought that reimbursement failed to reflect the workload required for this subspecialty, the work demands of the subspecialty, and that 98% felt that medical legal risks hindered providers from partaking in ROP care, or retinopathy of prematurity care. And if you are in the ophthalmology community, you'll often hear it said that if you go into pediatrics, you're taking a pay cut, or there's not you quote unquote won't be paid very much as a pediatric ophthalmologist. So I thought the fact that 63.2% of pediatric ophthalmologists themselves stated that they were satisfied with their compensation kind of argued that maybe it's not a numbers issue, but more of an unjust reimbursement issue for the care that they're providing. And then finally, looking at the social determinants of health category, we saw that there was an overall concern for health equity for kids in America to receive eye care, and that the reduction in research, so medical research in America, including in the field of pediatric eye care, was an issue felt amongst all the respondents. And then also, just like we saw before, limited insurance coverage being a reason for the disparities in receiving pediatric eye care. So that was our main takeaways from this study. I just want to say thank you so much for the International Journal of Medical Students for having us partake and share this research with you all. And it's been amazing to listen into the other presentations. So if you have any questions, that's my email, and I'm happy to take any questions. Here are our references.
Thank you so much for that presentation. Now we will be having Dr. Adeni as our judge for this session. Julia, I think you may turn off your camera to have a more smoother audio. You're kind of
can you hear me?
Yes,
can you hear me?
Hear you, Dr. Adeni.
Oh, yeah. Thank you very much for the presentation. I have very few questions for you. The first one is that there are more females in your studies than males. Don't you think that could have altered the direction of your the findings, having a large number of females than males? And why is it like that? Why do you have more females respondents than males? Then again, you did not conclude. You only showed us the results. There was no conclusion to your studies. Thank you very much.
Yeah, thank you so much, Doctor. I do also think that it is interesting there were more females. I think that would, to really be able to answer that question, I would want to look at just the distribution of females to males in the pediatric subspecialty as a whole, because I think it might be reflective of the fact that there are, and I'm just assuming here, but just by my anecdotal observations, there might be more females in the subspecialty overall in America. But I would need to look into that to confirm. We didn't see that it was a great outnumbering, so about 14% more females to males, but still that's definitely something to take into consideration when looking at the conclusions. And then for the conclusions themselves, just due to the fact that we had a low response rate of 3%, and we didn't feel that we could competently make any grand conclusions based on this data, but we more so wanted to present this as just to show that it is confirming other data sets that also highlight that pediatric ophthalmologists fear that the workforce shortage is becoming a larger issue, and just kind of add to the literature in that way, so that whenever the community goes to maybe advocate for policy change or other avenues that could really help mitigate this issue, they would have just more study, more information to use to advocate to the movers and changers that could maybe help provide solutions to this issue.
All right, thank you.
Thank you so much.
All right, I think we don't have any other questions here. We may proceed to the code. Thank you both, and thank you, Julia, for the presentation. We would like to remind everyone to please scan the code and please vote for your most preferred presentation. All awards will be presented on the last session of our second day. So we do hope that everybody would be joining us for this international engagement. For the judges, please do fill in the form that has been given to you previously. All right, we're back on, and we'll be having Ayman Dean Omer Ali from Sudan, Red Sea University third-year medical student. And he would be presenting on the post-traumatic stress disorder among epileptic patients in conflict-affected regions of Sudan, a cross-sectional study. And for this session, we would also have our judges with us, Dr. Imad. Yes.
Hello, everyone.
All right, we see your screen. Please begin.
Hello, everyone. My name is Ayman Al-Addin. I'm third-year medical student at Red's University. Thank you for giving me this opportunity to share our cross-sectional study, post-traumatic stress disorder among epileptic patients in conflict-affected regions of Sudan. So here is our author, and let's start with the introduction. Firstly, we need to know that epilepsy is one of the neurological disorders that affect approximately 50 million individuals worldwide and presenting an established risk of severe psychiatric comorbidities like depression, anxiety, and PTSD, which is triggered by trauma. Secondly, we need to know there is something called the bidirectional cycle, that extreme stress and violence and forced displacement participate or exacerbate seizures activity, while uncontrolled seizures conversely a heightened psychological distress. Also, in conflict realities, that we know that in humanitarian crisis, patients face treatment interruption and medication stuck out, like what happened in Sudan last 2 years and until now in the conflict and the war. And also for the literature gap, while the general conflict zone PTSD level reach 30 to 50% globally, dedicated study examining PTSD among epilepsy patients in active African zone remain extremely scarce. And for the study we aim to determine the exact prevalence of PTSD and evaluate its precise statistical associations with socio-demographic and clinical seizures factor among adult epileptic patients living in conflict-affected areas of Sudan. Methodology, we use descriptive multicenter cross-sectional conducted across 5 conflict-affected states in Sudan: Red Sea, Qatarif, Omdurman, River Nile, and Blue Nile. The data were collected between January and June 2025. Population sampling architecture inclusion criteria, we include 18 years old or more, the adult patients with confirmed diagnosed epilepsy made by qualified neurologists and residing in active conflict areas. For the exclusion criteria, we exclude the severe cognitive impairment or confounding major psychiatric condition that impede accurate reporting. For sampling strategy in neurology outpatient clinics, we use systematic sampling for clinical profile, and we use purposive sampling for in the displacement camps. The sample size, the final sample size was 395 after cleaning of the analyze, but the minimum was 385. Data processing and ethical standards, we use standardized interview administered questionnaire with 3-part validated questionnaire covering demographic, clinics, epilepsy, histology, and standardized PTSD screening checklist. And also in the analysis, we used SPSS version 25, and in the ethics, we used approved from the Research Ethics Committee, Faculty of Medicine, Red's University, and written informed consent obtained from all participants. So let's start with the results. In the results, we find that the severity of PTSD was like the following. The high severity was 54.7%, and the low severity was 43.5%, but the moderate severity was 1.8%. And also, in figure 2, we find that 54.2% was internally displaced persons, and there is 33% of this internally displaced person suffer from worsened seizure frequency post-conflict, and 30% of the total population 30.9% of the total population suffer from exacerbated seizure severity post-conflict. Also, we has chi-square test association and correlation that's statistically significant, that there is categorical testing proof that high PTSD diagnosis tracks directly and significantly with educational level, employment status, clinical seizure severity, and seizure frequency. And also there is a strong correlation in the total PTSD scores demonstrate exceptionally powerful positive linear relationship with key variables like occupation, patient age, seizure duration, and patient sex. Okay, for the discussion, we need to know that the main we had a contrast between the main findings and global baseline, while global meta-analysis show baseline PTSD prevalence of only 7.7% to 18% in stable regions, but our study revealed strikingly higher rate of 54.7% and high severity PSD among Sudanese patients driven by acute war trauma and high displacement, which is 54.2%. And also our study confirmed the bidirectional cycle that mentioned before, or our result confirmed it by the highly significant association between PTSD and seizure severity duration proved the severe war zone seizure act as traumatic triggers for PTSD. Also, there is a strong correlation with age and occupation, highlight the social instability directly amplify psychological trauma. And also we had limitations on methodological limitations that cross-sectional design restrict the determination of true temporal causal links, and also relies primarily on interview-administered self-report screening checklist rather than longitudinal research. For conclusion and recommendation, we conclude that there is an alarmingly dense, under-recognized burden, high severity PTSD tracking directly with displacement markers and severe clinical seizure variation in Sudan. We recommend that we should have mandatory integration of routine in mental health screening and trauma-informed psychological support directly into neurology and humanitarian care program. And thank you.
Thank you so much for the wonderful presentation. And for this session, we would want to invite Dr. Imad and Dr. Sajid Mukhita, if you are there, to join us, and as well as Dr. Nawaj. Yes. Welcome both. You may start with your questions for this presenter.
Professor Nawaz, you start first.
All right, maybe both professors may have some difficulties or technical difficulties here. I would want to ask regarding on the Sudan. Maybe you could explain more on the certain categories of the epileptic patients that you have already included on the study. Maybe you could explain more of that to give us a background again.
Excuse me, I didn't hear you because there's some noise in the background, maybe.
Oh, okay. Sorry.
Okay. May I ask?
Yes.
Go ahead.
Okay. So, Ayman, what is your actual prevalence of the epileptic present in the Sudan? Prevalence. I am asking about prevalence of the epilepsy.
The prevalence of epilepsy in Sudan, generally, you mean that's not the PTSD?
Okay.
Or what?
And
Because I couldn't hear you.
okay. If you are not getting the prevalence, then how you decide the sample size for that one?
The sample size of
Yeah.
the study.
Yeah.
It was 385. This is the minimum sample size, but we adjust 10% the non for the non for the non-response buffer target. It was 424, but the final valid sample after cleaning the analysis data and after cleaning the analyzed data was 395.
Okay. Yeah.
Yes.
Just if you have a question, you can ask them.
Dr. Nawaj, are you there? I think we may have some technical difficulties on Dr. Nawaj end. It's not a problem. If you do have any questions, feel free to have it on the chat box. Yeah, but as of now, I think we may not have any other questions for your session, Amen. And thank you so much for the presentation. It was a wonderful study.
Thanks.
So we'll be having the code right now. We would like to remind everyone, please scan the code in front of your screens right now and to vote for your most preferred presenter. All the awards will be presented on the last session of the second day, and we do hope everybody will be joining us up to then. For our judges, please do fill in the form that was given to you previously. All right, moving on, we would have the study of Laura Pinheiro Roy, a third-year medical student from the Faculty of Medical Medicine and Health Sciences, Universidad de Barcelona from Spain. And that will be discussing on the dietary creatine intake and depression in US adults in multi-cycle NHANES replication and sensitivity analysis of Bakian 2020. And for this session, we would want to invite Dr. Adarsh Keshari as our judge. So you will be presenting the video in a bit.
Hello everyone, I'm Laura Pinheiro, a third-year medical student at the University of Barcelona and the single author of this work. Today, I'll show you a replication of a well-known finding that people who eat more creatine seem less depressed, and a twist. Whether it holds depends on one methodological choice that earlier work never made explicit. So it's really a story about reproducibility, about how one hidden analytic choice can change what a study concludes. Creatine is central to brain energy metabolism, and low brain creatine has been reported in depression. So there is a plausible mechanism. In 2020, Bakian and colleagues took that to population scale in over 22,000 named adults. Those in the top quartile of dietary creatine intake had 32% lower odds of depression, with an odds ratio of 0.68, stronger in women and younger adults. A striking low-cost signal, but it had not been replicated in newer cycles, and no one had asked whether it survives a different definition of where dietary creatine comes from. Because creatine isn't measured directly, it's estimated from the foods people report. Two aims. First, repeat Bakian's analysis in a more recent pre-pandemic cohort. Second, the new part. Test whether the association is robust to four alternative definitions of the creatine source, because that estimation step is where a lot of hidden judgment lives. I pulled 3 9 cycles, 2013 through March 2020, stopping before the pandemic. Adults 20 and older with a valid PHQ-9 and at least one 24-hour recall, 14,664 met our criteria, and the adjusted models fit on 13,170 complete cases. Depression was a PHQ-9 of 10 or more. Creatine was estimated from animal protein equivalents in the USDA food database using Bakian's coefficient. We combined survey weights per national guidance and adjusted for 11 covariates. Animal protein isn't one thing. Different foods carry different creatine, so how you define the source changes the exposure. A is the strictest, meat, poultry, and eggs only. B, C, and D progressively bring seafood in. B is closest to Bakian. The fractions are deliberate scenario choices. And here's the contrast. Most studies make this choice once, quietly, and never report it. We made it 4 ways, in the open. The question underneath, does seafood count? The pattern is clean. Whenever seafood is in the source, B, C, and D, higher creatine intake is associated with significantly lower odds of depression, 0.72, 0.65, and 0.67, all below 1. The continuous models agree, but definition A, meat and eggs, only weakens to 0.81 and crosses 1. So the same data give a significant or a null result, depending on that one choice. Closest to Bakian, our estimate was 0.72 against her 0.68. Same direction, slightly weaker. 3 things. First, it replicates in newer independent data. Second, its size hinges on an analytic choice usually made silently and left out of the methods. That has to be stated upfront every time. And third, in honesty, the definition that shows the effect includes seafood, which is also the main source of omega-3 itself, linked to depression, so I can claim this is specifically a creatine effect. It's cross-sectional, so it's an association, not a cause. The younger subgroup pointed the same way, but was underpowered. To conclude, higher dietary creatine intake was tied to lower odds of depression, but only when seafood entered the source definition. The real lesson is bigger than creatine. The same data can give a significant or a null result depending on the one choice we usually hide. If we want science that replicates, we have to make those choices visible. And everything I've shown is reproducible. Public names data and my code is open on GitHub. The cleaner test of creatine itself is a larger trial, building on the small ones that already exist. But the message I leave you with is about reproducibility. Thank you very much, and I'm happy to take your questions.
All right, so that was the pre-recorded video of Laura. Now we will be having Dr. Adarsh Kashari to present his suggestions.
So my question for Laura will be that beyond replicating the Bakian et al. Study that she presented today, what is the novelty that is contributing towards from the study? What is the novel element of the study?
Thank you for that. We'll have that noted. Maybe you would have other suggestions as well for the study or something to add?
Regarding the study is relevant in the point that it is very much relevant in the current sense because high creatinine intake is a matter of fact these days, but the novel contribution towards the existing literature is the question from my end. Thank you.
Understood. Thank you so much, Dr. Adarsh. We'll be proceeding to the code. So we would like to remind everyone again to please scan the code and to vote for your most preferred presenter. All awards will be there on this last session of our second day. So we do hope everybody will be joining us up to then. So as for our judges, please do fill in the forms that has been provided to you previously. Moving forward, we would have Lino Abdul Rahim, Justina medical student of the, and then she will be presenting on the conventional suture ligation versus sutureless technique in total thyroidectomy, a systematic review and meta-analysis of randomized controlled trials. And for this session, we'll have Dr. Imad and Dr. Fernandez as well on our judge section.
Hello everyone, my name is Mina Justiniya and I'm a senior medical student in King Saud bin Abdulaziz University for Health Sciences in Jeddah, Saudi Arabia. Today, on behalf of my group, I'm going to present our research entitled Conventional Suture Ligation versus Sutureless Technique in Total Thyroidectomy, a systematic review and meta-analysis of randomized controlled trials under the supervision of Dr. Bara Awad. To begin with a brief, the thyroid gland, high vascularity, and because it's near to critical muscular and neural structures, it requires prompt hemostasis during surgery to reduce complications. Traditionally, surgeons have relied on conventional methods for hemostasis, like hand-tied sutures or surgical clips, but newer high-energy devices, including harmonic scalpel and ligature, offer sutureless alternatives with potential efficiency gains. Therefore, our study aimed to compare the efficacy and safety of these devices. Following the PRISMA approach and Prospero registration, we have searched up to 5 major databases for RCTs published up to July 2025. We included adult patients undergoing total thyroidectomy for benign or malignant thyroid disease. The interventions analyzed were HS and LS compared to conventional suture ligation methods, and the outcomes were operative time, intraoperative blood loss, recurrent laryngeal nerve palsy, hypocalcemia, postoperative hematoma, postoperative drainage, and length of hospital stay, with a minimum follow-up duration of 4 weeks. So as you can see in the figure, following the PRISMA approach, we identified up to 1,180 records, and we screened up to 890 records approximately, ending up with 22 RCTs. We performed a network meta-analysis using the random effect model with 95% credible intervals. Risk of bias assessment was done using the Cochrane RB2 tool, and intervention rankings were calculated using the surface under the cumulative ranking curve. As I said earlier, we ended up with 22 RCTs, enrolling a total of 3,824 patients with mean ages ranging from 44 to 55 years and female predominance, which is consistent with the thyroid disease epidemiology. Regarding risk of bias, overall it was 14% having low risk, while 86% was having some concerns, mainly related to unclear randomization and lack of blinding during outcome measurements. As per our key findings, both HS and LS have reduced the operative time significantly by 22 minutes compared to conventional suture ligation, as they lie entirely in the site favoring the device. Also, for HS solely, it have reduced the length of hospital stay by 0.37 days and post-operative drainage by 24 mL compared to conventional suture ligation significantly. As well, in addition, in the table, you can see that efficacy outcomes, the first 3, were supported by moderate certainty of evidence according to the grade, while safety outcomes were supported by low certainty of evidence. As for the remaining outcomes, which are highlighted in this slide, they cross a line of no effect, indicating no significance. And these include intraoperative blood loss, strain duration, hypocalcemia, transient recurrent laryngeal nerve palsy, and hematoma. So, according to the CIRCA rankings, these represent ranking probabilities ranging 0 to 1, rather than direct clinical or statistical superiority, reflecting that the likelihood that a treatment is the best among options. So following the blue bar, which represent the harmonic scalpel, you can see that it ranked highest for intraoperative blood loss, hospital stay, post-operative drain output, and hematoma. While significantly in the operative time, you can see that both HS and LS have ranked much higher than conventional sutural ligation methods, further emphasizing outperformance over the conventional sutural ligation methods in terms of efficiency. Taken together, these findings support that these devices, particularly the harmonic scalpel, improve surgical efficiency in total thyroidectomy without an increase in complication rates, supporting their safety in clinical practice. And future studies should focus on standardizing outcome definitions, evaluating cost effectiveness, and examining long-term functional outcomes. And thank you for your attention. You can scan this QR code for references, affiliations, figures, and tables. And I would be happy to answer any questions.
We would like to thank the presenter. Now we'll be having Dr. Imad and Dr. Fernandez on the judging.
Hi.
Thank you so much for this presentation. This is a very interesting systematic review and meta-analysis. I'd like to ask a few questions. First one is that you recommended the use of harmonic scalpel. However, there was no differences in terms of right recurrent laryngeal nerves injury or hypocalcemia. So does that mean that both interventions are safe and equally? And does that justify the expensive approach using this HS?
Thank you for that question, Dr. Imad. Dr. Fernandez, would you have something to add?
My question was, your overall risk of bias bar is almost entirely some concerns. So only a small fraction of trials had low risk overall. So given that, how much confidence can we actually place in the pooled effect estimates? So did you downgrade for this in grade?
Thank you both. So we will have this noted as well for our presenter. If there is nothing else to add, we would proceed to the code. We would like to remind everyone to scan our code in front of you. So please vote for the preferred presentation. All awards will be presented on the last session of our second day. And as for our judges, please do fill in the forms that have been provided previously. Up next, we will have Nida Bakri El-Haj from the University of Medical Sciences and Technology. They will be presenting on the cross-sectional study on ADHD symptoms among medical students in Rwanda, academic and psychiatric correlates. So in this session, we would also have Dr. Sajid Mukida and Dr. Franklin as our judges.
Hello, everybody. Can you hear me?
Yes, we could hear you. Please do present.
Now you can see my short screen.
Okay, yes.
Okay. Hello, everybody. My name is Nida Bakri Haj. Graduated from University of Medical Sciences and Technology with a prize for the best graduation thesis. It's my honor today to share here in IJMS. Thank you for this opportunity. Today I'm presenting a cross-sectional study on attention deficit hyperactivity disorder symptoms among medical students in Rwanda, academic and psychiatric correlates, presented by me, Nida Bakir Haj, others, Dr. Dani Ibrahim and Dr. Ruth Tisera. Introduction. Attention deficit hyperactivity disorder is a neurodevelopmental disorder characterized by inattention, hyperactivity, and impulsivity. It often persists into adulthood, remains underdiagnosed and undertreated, and is associated with a poor academic performance and psychiatric comorbidities, particularly anxiety and depression. However, evidence on ADHD among university students in Rwanda remains limited. This study aimed to assess the prevalence of ADHD symptoms and its association with subjective academic performance and psychiatric comorbidities among medical students in Rwanda. Method, study design, analytical cross-sectional study, duration, September-October 2025. Study settings, University of Medical Sciences and Technology and the University of Rwanda. Both of universities were in Rwanda. Study population, 584 medical students aged above or equal to 18 years who speaks English or Kinyarwanda, and for those who excluded, students who have been severely ill and experience severe psychiatric or physical health conditions. Sampling technique, we did multi-stage sampling. We purposefully selected the two largest medical universities in Rwanda, then stratified students by academic year to achieve balanced representation. Within each academic year, participants were recruited through convenient sampling in proportion to the number of students enrolled. Data collection and measures, self-administered questionnaires in both English and Kinyarwanda were used, online and face-to-face. ADHD measured by validated questionnaire, adult ADHD self-reported scale, version 1.1, and maladaptive daydreaming was measured by maladaptive daydreaming scale 16. Statistical analysis, we use chi-square, Fisher-exact, logistic regression through IBM SPSS version 23, and we control the confounder user logistic regression. Ethical approval. Ethical approval was obtained from University of Medical Sciences and Technology and access to data from University of Rwanda. Results. A total of 584 medical students participated in the study. Response rate was 61.5%. Nearly half were male and 47.1% were female, and the mean age was 21.6 plus or minus 1.7 years. The prevalence of positive ADHD symptoms was 21.4%. ADHD symptoms were more common among students aged less or equal to 20 years, and it was significant, and it were also significantly associated with poor academic performance and anxiety disorder, 6.4%. Actually, it was not significantly associated with depression, 3.2%, and behavior addiction, 0%. In addition, ADHD symptoms were associated with maladaptive daydreaming, nearly half. We did logistic regression for 5 independent predictors as shown in the figure: university, age, mental disorders, physical illness, and family history of psychiatric illness. The model show good fitness with variance of 16.8% and confidence interval 95%. So after we adjusted these variables, all the physical illness and family history of psychiatric illness remained significant predictor of ADHD symptoms. Students with physical illness had 72% higher odds of reporting ADHD symptoms, while those with family history of psychiatric illness had 86% higher odds. Discussion. ADHD was more prevalent among University of Medical Sciences and Technology students than University of Rwanda students, possibly reflecting greater academic demands, competition, and heavier course load in the first one. Younger students had a higher prevalence of ADHD, consistent with Rosra et al., who reported a decline in ADHD prevalence with increasing age. ADHD was significantly associated with poor academic performance, consistent with previous studies. It was significantly associated with anxiety disorders, but not significantly associated with depression, which may reflect differences in assessment tools or study populations. A positive family history of mental illness was significantly associated with ADHD, supporting the substantial genetic contribution to the disorders. ADHD was also associated with maladaptive daydreaming, consistent with previous studies suggesting short deficit in attention regulation. In conclusion, ADHD symptoms were prevalent among younger medical students in Rwanda, and they were associated with a poor academic performance and psychiatric comorbidities, particularly anxiety spectrum disorders. These findings highlight the importance of early screening and accessible mental health support for medical students. Future longitudinal and multicentric studies are needed to explore the relationship between ADHD and physical diseases, genetic and environmental factors. Thank you.
Thank you for that presentation. Now we would have Dr. Franklin on the platform as our judge, and as well as Dr. Shaji Mukhita.
Nida, I have a question that how you decide the sample size, because you have selected 584 samples from the two different institutes. So how distribute the sample, like both institute you have took the similar samples or you have to take a different sample size?
Sorry, can you repeat the question, the last question? How did I do what?
How you did decide the sample size for the study?
Okay, actually, I select the sample size by a known population equation, and it was 306. But I multiplied by 2, the double design effect, because I use convenience sampling. So I try to minimum the bias of selection bias and improve the generalizability a little bit. Yeah.
So you choose two institutes. One is the University of Rwanda and one is the University of Medical, that is Science and Technology. So you distribute both sample size, like 584 is in equal in the both institute. You choose like different variation.
So it's not like 100% equal, but like similarly, yeah. The number is similarly.
Okay. Okay. Second thing, you have mentioned that younger students, like less than 20 years students, have a more this type of attention deficit, this ADHD. So you just mentioned the more less than 20 age of this one, but you not mentioned the numbers. I want to ask about numbers.
So
That
for
how
numbers
many
of
students is how many students which is below the age of 20 have this type of ADHD symptoms?
So for number of students who have been below 20 years, so it was like for those who have been, for number of students who have been less than 20 years and who have been diagnosed with ADHD was like 27%, and for those more than 20 years was 19.10%.
What is your higher age of the students? Like it is 25 above or 30 above? What is your higher age?
Sorry, can you repeat the question? How what?
In your study, out of 584 students, what is the higher range? Means what is the elder students of this year in your study? Like it's 30 years student.
So the higher rate was those more than 20 years. Like they constitute in total 73% point 9, and for those less than 20 years, like 26.1%.
Okay.
Thank you very much, Nida, for your fantastic presentation. It was very interesting to hear about like ADHD among students in Rwanda, or rather ADHD symptoms. So just to be clear, the tools you used to identify the symptoms, the ASRS and the that's the daydreaming tool. How well are they able to detect ADHD symptoms in adults? Because I know like it's typically diagnosed in children 4 to 12 years old, thereabouts. So like, were you concerned about the sensitivity of these tools in an adult population?
Okay, thank you, Dr. Franklin, for the question. So I used the adult ADHD self-reported scale to screen for ADHD symptoms. It's well-established, validated, standardized questionnaire, and it's mostly used than like other questionnaires. It's a kind of screening tool, so I cannot be like 100% that like I can diagnose them with ADHD. It's a positive screen for ADHD symptoms, but it show like high sensitivity and specificity, and even it's reliable with Cronbach alpha 0.88. Yeah.
Okay. Yeah. Then just to follow up, because I know that like most of your results talked about the findings were in terms of ADHD symptoms, but in your discussion, you were just talking about ADHD. So I was wondering if like you went from a place of just like identifying symptoms to actually making diagnosis. So that was just one discrepancy I wanted to like highlight. Then and this is just me trying to like think broadly and frame the research question. What was like the overarching research question? Like what was the general hypothesis that was being tested here? Because I know a lot of things went on, but tell me more about the background to this research.
So the null hypothesis is that there is no association between attention deficit hyperactivity disorders and academic performance and psychiatric comorbidities. So the question is there any association between ADHD and subjective academic performance and psychiatric comorbidities? Yeah.
Okay. All right. Yeah. Thank you. Yeah, that's all the questions I have for you. Yeah. Good
Thank
luck.
you.
Yeah.
Thank you very much.
Nice wrap up. Thank you, everyone. Thank you, Nida, for that presentation. We'll be moving on to the code. So we would want to remind everyone once again to scan the QR code to vote for your most preferred presentation. All awards will be presented up to the last session of the second day. And as for our judges, please do fill in the form that was given to you previously. Moving on, we would be having Fikir Balate Kabede, 6-year medical student, School of Medicine, College of Health Sciences, Addis Ababa University of Ethiopia. And she'll be discussing on the barriers to medical research participation among undergraduate medical students in Ethiopia, a cross-sectional study. And for this session, we would have Dr. Tanya Pilet-Torres and Sajid Mukita as our judge. Yeah, so you may begin once you're ready.
Thank you. I just wanted to make sure that my slides are visible
Yes.
and moving.
Yes.
All right, thank you. Good morning, good afternoon, and good evening, everyone. I'm Fikir from the Addis Ababa University College of Health Sciences, and I'm going to present to you the topic of our research, that is barriers to medical research participation among undergraduate medical students in Ethiopia. And after reading this topic, some of you may be thinking, we are here, aren't we? Is this even a problem? Is there even a barrier that we need to discuss? So I want to lead you to this saying by Paul Glasziou, who is a pioneer and also an advocate for evidence-based medicine. He said that the skills needed to find potentially relevant studies quickly and reliably, and to separate that wheat from the chaff and to apply sound research findings to patient care have today become as essential as skills with a stethoscope. And while research, as we know, is a systematic inquiry into materials and sources to establish facts, innovate information, and research new conclusion, undergraduate research specifically involves mentored investigation conducted by undergraduate students seeking to make scholarly contribution to knowledge. And in general, globally, we've had a surge of research conducted by medical students. However, that surge and increase in number is disproportionate across geography and socioeconomic status. So students in developing countries seem to face more numerous barriers that prevent them from taking advantage of research opportunities. And this is not a problem of low interest. In fact, they do have high interest, but the engagement is alarmingly low. And after a literature review, these are the factors that we identified to contribute to this: existence of a research club, familiarity with IRB procedure or proposal approval, research course or biostatistic and epidemiology course taken, attendance of research conferences and reception of research grants seem to be factors that affect their participation. And the following barriers were also identified: limited time due to heavy coursework, clinical rotations, difficulty in finding research mentors, and also the faculty having limited time for student research, leading to difficulty in finding research mentors, lack of research training and sufficient feedback, limited access in general to computers, software, up-to-date journals, and clinical laboratories, and lack of adequate integration of research into the curriculum. That, coupled with low peer interest and difficult IRB process, was identified to be major barriers. So what we set out to do in this research is we wanted to find and assess the barriers that are hindering undergraduate medical students in Ethiopia from engaging in medical research. So what we designed is a study that is institution-based and multi-centric cross-sectional study. And we conducted it across 10 medical schools in Ethiopia, and this included both government and private institutions. The study period ranged from August 2025 to December 2025, and the study population were undergraduate medical students that were currently enrolled in Ethiopian medical schools. So our sample size came up to 381, and we used convenience sampling. Basically, we had the questionnaire, and we used a structured self-administered online questionnaire to assess the socio-demographic research knowledge and perceived barriers by students. Now, the barrier items we measured during a 5-point Likert scale, and then we summarized that into a standardized overall barrier score. So to come to the results, these were the sample demographics that we had. So to start off, we had the academic year distribution. As you can see, we had 54% of them were from clinical years, and about 29% were in their preclinical years, and 17% were in their internship years. Institution-wise, 78%, that is the vast majority, was in government schools, which does reflect the current realities on the ground. And research participation was actually surprising when we had about 54% of the students actually involved in research at any level, from data collection to being able to submit their own manuscripts and also present at research conferences. Now, after categorizing and aggregating the barrier scales and adding the Likert scales, what we found was that about 2% of the students had high barriers, 59% had moderate barriers, and 39% had these low barriers. But what were these barriers? So the statistics is actually distributed between these main 6 barriers. So lack of research training and funding limitation take the largest part of the cake by about 74%. Heavy coursework, limited collaboration across peers, and low peer research interest were also in the high 60s, and also academic writing difficulty were largely perceived as barriers by students. Now we decided to take a closer look, and on barrier analysis, what we found was the factors that were associated with actually decreased participation were the first one, and the biggest one is lack of mentorship. Students who faced lack of mentorship from faculty and senior faculty faced about 77% decreased chance of participating in a research project. The ones with poor academic writing skills were attributed to an odds ratio of about 0.21. That is about 79% of less research participation, and the curriculum gap that contributed to about 71% of decreased research participation. What we found were a bit hope enticing were the ones that increased the participation, which was clinical years. Now, the students in clinical years had a 15 times odds of participating in research. This is largely attributed to the fact that they had access to faculty and mentorship in general, and access to research in general. And then conference attendance also took a big part of the cake by 14 times increased research participation, and taking a research course by 3 times. So these are all things that can be affected by the institutions. So what we're trying to take from this, and I'm glad to be presenting these implications in such kind of a platform, because this is where we'll find actionable points to strengthen the future of physician scientists. What we need to do is integrate research training early in the curriculum. That means we don't need students to just know how to do research. We need to learn how to become researchers. And to be able to establish structured faculty mentorship programs will fill that gap of students not being able to find mentors. And also providing scientific writing and publication training will fill in that gap of lack of training, poor academic writing. And we have actually implemented this in our schools, and it has yielded results. Expanding student research conferences and collaborative opportunities like this conference would also go a long way in encouraging students to participate in research. So what I want everybody to take home is that undergraduate medical students in Ethiopia, along with other low-income countries, face significant structural, educational, and mentorship-related barriers, and that does limit research participation, but research interest is still high. Now, the research engagement was strongly associated with clinical training exposure, formal research, and research conference participation, and the major barriers we identified were limited faculty mentorship opportunities, academic or writing difficulties and skill gaps, and also poor curriculum integration. These are my references, and thank you. I will be accepting questions now.
Thank you for that really wonderful presentation. We'll be having the judges join us in a bit. We have Dr. Tania Torres and yes. Dr. Tania,
it is a good study. Okay.
Go ahead.
Okay.
Go ahead.
It was a good study, and you cover the like 10 medical schools. So it is like you can get a more response from the variation and the variability of the responses. Okay. The question is like you are saying that there is a biggest barrier is the like lacking of mentorship. So is there any possibility or any invention or any methods which you try to remove this barrier in Ethiopia after your study? It will be anything are there? Okay. Did you get my point?
All right. Can you please repeat the last part of the question? Can you please repeat the last part of the question?
in your study, is your like one conclusion that means lack of mentorship is the biggest barrier or largest barrier. So, is there any improvement in your Ethiopia after your study or previous anything is doing on your institutes or study area?
Yes, thank you. That's a very good question. And it's something that we are trying to implement. So, within our Medical Students Association, one of the branches that we're working on is research exchange. And in order to do that, what we do is we contact the senior faculty members and we see what researches the residents are actively working on. And what we do is we try to connect them with students who are actually interested in research so they could help with data collection. And we ask them to mentor them in the research in return. So, they show them what the research is, how they came up with the proposal, the things they need to notice in the data collection and data analysis as well. So the biggest challenge that we're now facing is how to make that sustainable. And that is what we're working on currently. Thank you.
Good.
Hi, Vicky. I'm really glad that you tried to analyze this very difficult part for med students in order to understand why they are not involved in research, because research is a very important part of the medical education in general. And you have to understand research every day of your life, even your professional life, because you have to be updated. So you have to understand articles, and then you have to understand things are changing and all the technologies that are new. So this is something that also I have studied somehow in where I work, and this part of trying to involve the med students into research has been one of the main issues all around the world. And I was surprised that most or almost half of the participants in your study, they were already involved or they like research. So that's good. That's really good. I was surprised. But I have a question. Do you know if in those institutions, they already have something like you have already described, like if they have these like special programs that in some places we have that, for example, they can have these research days in the afternoon, and then they have like a sanction list of mentors. Do you know if you have in these places where you obtain the subjects these type of programs?
Yeah, so that's a very good question as well. So, in most of these medical schools that we assessed, as I said, in the Medical School Association, they do have active SCORI programs where they have dedicated research capacity building programs as well. So, we were really surprised at the prevalence of actual research participation, and that is one of the things we're attributing it to. Research clubs are very common, and the faculty is starting to really invest in medical student research, which was a surprising, pleasant surprise.
Because, for example, MD PhD students, do you have any MD PhD students that are in part of your sample size?
No, we do not have any MD PhD students. All are medical students and their undergraduate degrees.
Okay. So because MD PhD students, usually they start the research part when they finish med school? Okay. So because I know some programs that start in the undergraduate part of the med school, and that's how you can involve them very hard in research work, no? So that would be like a very good option, like to try, to restructure these type of programs like MD PhD programs and start when they are really early students in the medicine area, no? And then you can start from that part of their or stage of their med studies, and then you can involve them like really hard, and they start even publishing papers since like the second or third year of med school. So if you restructure that MD PhD program, you can also take those students and train them really hard. So that was something that I wanted to ask. And I don't know if you have thought about focus groups, like a qualitative analysis for this.
Can you please elaborate?
Sorry.
Due to the lack of time,
sorry. Okay, thank you.
So thank you both for
just
your
an idea.
concerns and questions.
See you.
Thank you.
Bye-bye.
Thank you, Fikir. All right, so we'll be moving on to the code. We would like to remind everyone to please scan the QR code right now and to vote for your most preferred presentation. We will have all the awards on the last session of our second day. And for the judges, please do fill in the form that has been given to you previously. All right, so moving on, we would have Dr. Rina from the Abdulaziz University of Health Sciences in Saudi Arabia, and that will be a pre-recorded video on comparative efficacy of vibration ice and topical anesthesia for reducing abuthalin toxin injection pain. So for this, we'll also have Dr. Maxine Joss Williams as our judge, and we'll be having the video shown shortly.
And thank you to the jury and organizers. My name is Zina Abul Jamal, a medical student at King Saud bin Abdulaziz University College of Medicine, presenting on behalf of my co-authors. Our work titled Comparative Efficacy of Vibration Ice and Topical Anesthesia for Reducing Botox Toxin Injection Pain. This is a systematic review and a network meta-analysis. So for the background, Botox injection is a cornerstone of both aesthetic and therapeutic medicine, from facial lines to chronic migraine and spasticity. But injection site pain is a presenting barrier. It lowers the patient satisfaction and, importantly, discourages people from returning for the repeated treatments many of these conditions requires. Clinicians commonly reach for three simple, non-invasive options. Vibration, which works through the gate control theory of pain, ice, which produces cold-induced analgesia by slowing nerve conduction, and topical anesthesia like EMLA, which numb the skin directly. But here's the problem. Each of these has been tested in small isolated trials, but they've rarely been compared head-to-head. So we simply don't know which one is the best. Traditional meta-analysis can only compare two treatments at a time. And that isn't enough when you have three competing options and a mix of direct and indirect evidence. This is exactly the gap network meta-analysis fills. It compares multiple treatments simultaneously and produces a ranking. So our aim was clear: to compare and rank vibration ice and topical anesthesia for Botox toxin injection pain, and to look at the safety and patient satisfaction alongside efficacy. So for the how, we conducted our review following a Prisma extension for network meta-analyses, and we registered the protocol in advance on Prospero to guard against bias. We searched three major databases, PubMed, Scopus, and Embase, from inception up to August 2025, and supplemented that with trial registries and grade literature. That initially search returned nearly 13,000 records. Two reviewers independently screened them against a predefined PCOS framework, with disagreement resolved by consensus and, where needed, a senior third reviewer. We included randomized controlled trials and comparative studies of adult or pediatric patients receiving botulinum toxin for any indication where at least one of our three interventions was compared against a control or against ICE, being our primary comparator. After full screening, 22 studies met every inclusion criterion. Those 22 studies included 77 randomized controlled trials, and the rest were non-randomized. They were all published from 2002 to 2025, with a sample size ranging from 14 to 729, 7 treatment nodes with 23 pairwise comparisons. For the quality assessment, we use Cochrane Risk of Bias 2 tool, and for the non-randomized studies, we use the Newcastle Ottawa scale. Overall, the evidence base was judged methodologically sound. For the analysis itself, our primary outcome was patient-reported pain expressed as standardized mean difference, so we could pool different pain scales because we anticipated clinical variation across injection site pain and protocols. We used the random effect model, the more conservative and appropriate choice, and we then ranked every intervention using p-scores, where a value closer to 1 means a higher probability of being the best treatment. Secondary outcomes were safety, measured as pooled adverse events rate, and patient satisfaction. So now for what we found. For the pain, the result was clear. ICE was the most effective intervention. Compared with no anesthesia, ICE produced a large statistically significant reduction in pain, a standardized mean difference of about minus 1.8. And it stayed on top even in the conservative random effect model, ranking first with a p-score of 0.85. Topical anesthesia came second, and vibration came third. Critically, neither topical nor vibration reached statistically significant against control, so ICE stood alone as a reliable, effective option. On safety, the news is reassuring and simple. All three are exceptionally safe. Pooled adverse events rate were essentially zero, around 2% for ICE, limited to transient redness, and zero for the others. Clinicians can use any of these without meaningful concern for harm. But here's the finding that came as a surprise. When we looked at the patient satisfaction, the ranking flipped. ICE, our most effective analgesia, had the lowest satisfaction at just 19%. Vibration, which barely reduced pain, had the highest at 59%, with topical close behind the 55. I will discuss more in depth why could that be in our limitations. But this matters particularly because it tells us that objective pain relief and felt pain experience are not the same. The cold of ice may itself be unpleasant, while vibration distraction in its high-tech feel may make patient feel better cared for. So, in conclusion, before I conclude, I will discuss briefly our limitations, and I will be completely honest here. We had a very high heterogeneity rate, and for the adverse event rate and patient satisfaction, the data wasn't complete. So specifically for the ICE, we couldn't exactly find the patient satisfaction rate, except for 80% of our included studies, which affects the results and may produce this paradox we can see here. But in conclusion, our network meta-analysis demonstrates that while ICE therapy is the undisputed gold standard for objective physical pain reduction, it carries the lowest overall patient satisfaction due to the immediate discomfort of intense cold. Possibly. Clinically, this means we must look beyond objective pain scales to balance physical efficacy with subjective patient discomfort. Rather than choosing only one modality, clinicians can design optimized personalized protocol. For instance, applying a localized cold press immediately prior to the injection, followed by active mechanical vibration during the needle stick. This can provide the ultimate balance of physiological pain block and comforting sensory distraction. And again, for our limitations, as I said, heterogeneity across studies was very high. Our funnel plots just some publication bias and satisfaction data were spare, especially for ICE. So the ranking should be read as guidance only. What the field now needs is a high-quality trial comparing all three head-to-head with patient-reported experience treated as a co-primary outcome. And the takeaway for the clinicians is this. Lead with ICE for pain, but treat comfort and patient preference as a part of the outcome, not an afterthought. And thank you very much for your attention, and I'll be glad to take your questions.
All right, well, a great presentation. Now we will have Dr. Maxine with us as the judge for this. And Dr. Maxine, do you have any questions?
Yes, Justin. Yes, is the presenter here, or should I just put the questions in the chat?
Oh, you could just leave the question on the stream right now. We'll have that noted.
Okay. Well, I had two questions. One was, I was just wondering why Cochrane database wasn't included in the search for trials, clinical trials. And then the other was, I was a little thrown back by the fact that the data presented didn't have the patient numbers for each of the studies. And I would think that would have been important in terms of the weighting of each of the studies that were involved.
Understood. Other than the question,
so I wanted her opinion on that question about the weighting. That's one question, and the other one was why the Cochrane database wasn't part of her search.
Understood. We have those questions
noted
for
me,
our presentation. Thank you so much.
I'll type it in the chat as well.
All right, thank you so much. All right, so we'll be moving on to the code. We would like to remind everyone as well that the code is something you have to scan and to vote for the most preferred presenter. All rewards will be presented on the last session of the second day, and to remind all our judges as well to fill in their forms that was provided previously. Moving forward, we will have Nino from the First Faculty of Medicine, Charles University, Prague, Czech Republic, and she'll be discussing on the non-specific viral-like ocular symptoms as the initial presentation of aggressive primary CNS diffuse large B-cell lymphoma. And for this session, we would have Dr. Imad as our judge. So please do present, Nino.
Can you see?
It's gonna be there. Yeah. All right.
Yeah. So hello
start.
everyone. Nina, and I'm a final year medical student from First Faculty of Medicine, Charles University, and I'll be presenting a case study about non-specific viral-like ocular symptoms as initial presentation of primary CNS lymphoma on behalf of Abigail Fernandez and Dr. Marie Zavadova. First of all, what is primary central nervous system lymphoma? It's a rare and aggressive extranodal diffuse large B-cell lymphoma, 90% of the cases, that is involved, that can involve the brain, spinal cord, leptomeninges, or eyes. And in our case, the ocular involvement, called primary vitreoretinal lymphoma, may appear before the central nervous system disease, and it can mimic viral eye diseases. This case describes a 52-year-old man who first developed progressive painless visual decline in the left eye, and it was in 2020. Initial ophthalmologic testing showed that it hadn't been associated with any lymphoma. Also, what was done was vitreous sampling and cytology with flow cytometry as well. And also the infectious causes like cytomegalovirus, herpes simplex virus, varicella zoster virus, all of these viruses were excluded. The patient was initially treated with corticosteroids and antiviral therapy, but the improvement was only partial and temporary. Over time, his visual symptoms worsened, and they were associated with vitreitis and retinal involvement. Repeated vitreous and cerebrospinal fluid analysis remained negative. Because of this, the diagnosis was delayed. In 2022, after 2 years, was done MRI, and the brain MRI showed multifocal contrast-enhancing lesions, which were situated in deep brain structures, included cerebral peduncles, corpus callosum, and supratentorial regions. And you can see them with blue arrows. A definitive diagnosis was done in 2022 as well after the MRI, and it showed diffuse large B-cell lymphoma histology, and the immunohistochemistry also showed strong CD20 positivity. But on PET-CTs, there were no systemic FDG-avid disease, so it was said the diagnosis was primary CNS lymphoma. The treatment course was quite long. First of all, there was induction therapy with matrix, which includes methotrexate, cytarabine, thiotepa, and rituximab, after which there was consolidation when there was high dose of carmustine, followed by autologous stem cell transplant. There was a complete radiological remission after this, and a surveillance was done, should have been done from 2023. But in 2026, 3 years after the treatment, a relapse occurred, and the relapse was quite large, located in the posterior region, and it was also accompanied by vasogenic edema. The lesion was rapidly enlarging at this point, so salvage RICE therapy was initiated, which includes rituximab, ifosfamide, carboplastin, and etoposide. So this is the case timeline. Initially, the left eye visual decline was in 2020, and it was thought to be a viral illness and was treated as one as well. In 2022, after 2 years of symptoms, an MRI was done, which was quite late in this case, and brain biopsy was followed by it. In 2023, the stem cell transplant was done as well, which with other chemotherapy agents led to complete remission. And in 2026, there was a new relapse. And the goals of our study, so why we wanted to emphasize the study, is that you cannot dismiss ocular inflammation as a viral illness when it's been 2 years and more than some months. And also, negative cytology is not a definitive answer, as we had done a CSF analysis and other analysis as well, which were all negative. Biopsy may be necessary in this case, and surveillance must continue. And thank you so much. This is all.
Thank you so much for that presentation. So we will have Dr. Imad as our judge on this session.
Thank you so much. Am I audible?
Yes.
Am I audible? Okay. Thank you so much for this presentation. This is actually a very interesting case. I have a question. What do you think an initial test or investigation that could make the process of diagnosis, or at least make differential a bit faster? I mean, if we could like detect this lymphoma earlier, not before, not after 2 years, the patient survival and the patient quality of life would have been much better.
Thank you so much for your question. I think that 2 years is such a long time to diagnose because CNS lymphomas are usually diagnosed in like 40 days, 50 days. What I would change in this case, I would make sure that patient is followed up throughout the months. And if the symptoms, if there's no visual improvement for example, 2 months, 3 months, I would then consider that this could be some CNS malignancy.
All right. Would you recommend going for the MRI as fast as knowing that the labs are negative, the CSF are negative, and all are negative, or you would follow some sort of guidelines or go through the literature? As a researcher, besides being a clinician, what would you do?
I think in a year, I would still do MRI, or I would do some sort of CT initially. Maybe in 6 months, I would do CT. And if also it's negative, then I would consider MRI if it's been 1 year and the ocular symptoms haven't improved yet.
All right. What do you think the suspicion of ocular viral inflammation, optic neuritis, given or justifying the clinician to introduce corticosteroids, have somehow affected the labs or the investigations in this patient to be all of them negative in the first 1 month or 2 months of the presentation?
Yes, the interesting thing about the study is that after corticosteroids, visual symptoms improved for a short time.
Exactly.
And we found this because B cells were so multiplying in such a rate that corticosteroids could have slowed down their replication for some short period of time, but at the end, it's progressed and became larger.
Thank you so much. No further question.
Thank you.
Thank you both. Thank you for the presentation. All right, so we'll have the code on the screen. Just to remind everyone, is again to vote for your most preferred presenter. And all the awards will be there on the last session of our second day. So we do hope everybody will be joining us up to then. Judges, please do fill in the form that was provided to you previously. Up next, we would have Gabriella Boone, fourth-year medical student from St. Louis University School of Medicine, and her pre-recorded video will be on the silent sinus syndrome, an atypical neurocyclic manifestation. And for this, we would hopefully have Dr. Ahmad as well as our judge.
My name is Gabriella Boone. I'm a fourth-year medical student from St. Louis University, and today I'll be presenting a case of silent sinus syndrome with an atypical neuropsychiatric manifestation. Silent sinus syndrome is typically recognized because of orbital changes, such as enophthalmos or diplopia. However, our patient initially presented with recurrent panic attacks years before developing the classic features of the disease, making this an unusual presentation that highlights the importance of considering structural pathology in patients with atypical or refractory symptoms. Before discussing the case, I'd like to briefly review the relevant anatomy. The maxillary sinus drains through the osteomeatal complex, located within the middle meatus. This drainage pathway is critical because it allows normal ventilation of the sinus. As long as this pathway remains open, pressure within the sinus stays equalized with atmospheric pressure. However, obstruction of the osteomeatal complex disrupts ventilation and sets the stage for the pathophysiology of silent sinus syndrome. Silent sinus syndrome develops when chronic obstruction of the osteomeatal complex causes hypoventilation of the maxillary sinus. Over time, gas within the sinus is resorbed, creating negative intrasinus pressure. This negative pressure causes gradual inward collapse or atelectasis of the sinus walls. As the maxillary roof retracts downward, the orbital floor descends as well, resulting in characteristic orbital findings, including enophthalmos, hypoglobus, diplopia, and facial asymmetry. Because this process is gradual and often painless, patients frequently present only after these structural changes have become apparent. Our patient is a 45-year-old male who developed recurrent panic attacks beginning in 2019. Despite psychiatric evaluation and treatment, his symptoms persisted. Several years later, he developed chronic nasal congestion, facial pressure, diplopia, and lightheadedness. Imaging ultimately demonstrated silent sinus syndrome. Following functional endoscopic sinus surgery, not only did his sinonasal and orbital symptoms improve, but his panic attacks also largely resolved. This timeline illustrates the progression. In 2019, he experienced multiple panic attacks daily for approximately 8 months. He underwent psychiatric treatment in 2020, which produced only partial improvement. Several years later, he developed progressive sinonasal symptoms, including congestion, facial pressure, diplopia, and lightheadedness. In December of 2025, he presented to the emergency department, where CT imaging demonstrated right maxillary sinus atelectasis with inferior displacement of the orbital floor, consistent with silent sinus syndrome. He subsequently underwent functional endoscopic sinus surgery with septoplasty and turbinate reduction in February of 2026. At post-operative follow-up 1 month later, he reported marked improvement in his sinonasal symptoms, visual complaints, and importantly, a dramatic reduction in panic attacks. These CT images demonstrate the classic radiographic findings. On the coronal image, you can appreciate complete opacification and collapse of the right maxillary sinus, along with inferior bowing of the orbital floor. The axial image demonstrates obstruction of the right osteomeatal complex. These findings confirmed the diagnosis of silent sinus syndrome and explained both his sinonasal symptoms and diplopia. What makes this case unique is that neuropsychiatric symptoms preceded the classic manifestations of silent sinus syndrome. Our review of the literature found that reported cases almost universally present with orbital or sinonasal complaints. To our knowledge, panic attacks as the primary presenting symptom have not been previously described. Because his initial symptoms were psychiatric, he underwent evaluation across multiple specialties, including psychiatry, ophthalmology, and dentistry, before the underlying structural abnormality was identified. This case illustrates an important clinical pitfall. When panic symptoms are atypical, refractory to treatment, or occur alongside visual disturbances or chronic sinonasal complaints, clinicians should consider whether an underlying anatomic process could be contributing. Finally, the marked improvement after surgery supports a physiologic rather than purely psychiatric explanation for his symptoms. While we cannot establish causation from a single case, we propose a plausible mechanism. Progressive collapse of the maxillary sinus and inferior displacement of the orbital floor likely altered visual alignment and vestibular input. This abnormal sensory information may have created a mismatch between visual and vestibular signals, resulting in autonomic activation and panic-like episodes. This hypothesis is supported by prior literature describing links between vestibular dysfunction and panic disorder. In conclusion, silent sinus syndrome may present with symptoms extending beyond the orbit and sinonasal cavity. Patients with refractory panic-like symptoms, particularly when accompanied by visual changes or chronic sinonasal complaints, may warrant evaluation for an underlying cause. Finally, this case demonstrates that functional endoscopic sinus surgery can improve not only the classic manifestations of silent sinus syndrome, but also secondary symptoms that may arise from the underlying anatomic abnormality. Thank you for your time.
Okay, great presentation. Now let's welcome Dr. Imad and Dr. Dars to be our judges for this pre-recorded video. Welcome both. what will be your questions or even clarifications for the pre-recorded video we have just seen earlier.
So, wonderful presentation of the case on atypical silent sinus syndrome. So my question would be that if you could change any aspect, or if you could integrate rather any aspect of current clinical practice to improve the early diagnosis of the syndrome, what would be based on your experience with this case during your posting or presentation or discussion?
That is well noted. So the questions will be noted for our presenter. Dr. Imad, welcome back. Do you have any questions for our presenter?
Is there a discussion or just noted for the presenter?
Sorry?
Is the presenter around or just not
No.
questions
We'll just be
shared?
leaving the questions here. Yes, for them to come back.
All right. It was a very interesting case, but I wouldn't like connect the psychiatric symptoms like panic attacks with physical symptoms like the maxillary sinus or silent syndrome. Also, she mentioned that there is vestibular involvement that affected or that led to the psychotic and panic attacks, all right? But we can't like establish a relationship between vestibular involvement or the balance affection in short term with the psychiatric symptoms and the physical symptoms. Usually the vestibular nerve or the vestibule system in general is affected by a tumor, mass effect, calcification, degeneration, and so on. This would result to change in balance and so on. Besides, thorough clinical examinations should be performed in the initial presentation of the case. So yeah, these are my questions, and thank you so much for the presenter.
Thank you for sharing those, Dr. Imad. Now we'll be going to the code. So please do scan the code to vote for your most preferred presenter. All of our awards will be there on the last session of our second day of this conference. And to remind all our judges as well to please fill in the form that has been provided to you previously.
All right. Hello, everyone. My name is Saili Kulkarni, and I'm a medical student from Tbilisi, Georgia. And I will be covering the role of Master of Ceremonies for the afternoon session. So, as for the next presentation, we have Georgios Boliaris from University of Patras. And the topic is an unusual case report of Kuhne's syndrome following cystoscopy. And the judges with this will be Dr. Ahmad and Dr. Anjod. So
Hello,
yeah,
can you hear me?
Dr. Georgios, you can take over. Yes,
Okay,
yes,
can you hear
you're
me?
audible.
Can you see my slides?
Yes, it is visible.
Let me, okay. All right, so greetings everyone, dear judges, audience, and fellow presenters. Thank you for the opportunity to present our works today at the IJMS 2026. So my name is Georgios Boliaris, and I'm a Greek medical student. And on behalf of my co-authors, I will be presenting a rare case of Kuhn syndrome following cystoscopy. So firstly, let's start with what is Kuhn syndrome. It is an acute coronary syndrome induced by hypersensitivity, and it is further subclassified into 4 types. First, it's vasospasm on normal coronary arteries. 2 is plaque disruption causing spasm or thrombus. 3 is stent thrombosis or stenosis, and the recently introduced type is type 4, which is thrombosis of a CABG, which is a coronary artery bypass graft. It mainly affects middle-aged to elderly men. However, it has been reported to affect 2-year-olds all the way up to 90-year-olds. So as we said, Kuhn syndrome is primarily hypersensitivity mediated. So how will a Kuhn syndrome patient typically present? There will be manifestations of cardiac and allergic etiology. So you have chest pain, dyspnea, ECG changes, arrhythmia, and symptoms related to infarction. And allergic symptoms, so urticaria, flaccid, pruritus, angioedema, hypotension, wheezing, or a combination. And what we should take note is if a patient has both allergic and cardiac symptoms, they do not necessarily need to be present at the same time. The most common triggers have been described in the literature to be antibiotics and stink bites, although there has been a wide variety described. So Kuhn's syndrome does have a described pathophysiological mechanism with mast cell degranulation as its main axon. And the most holistically representative pathway is the following: there's exposure of an allergen, there is degranulation of the mast cells, and then we have vessel damage or vasospasm. As for exposure, we have an allergen, which classically binds on IG on the surface of the mast cell, or an alternative pathway, which is called pseudoallergy, where a drug or an allergen directly activates mast cells. Then we have degranulation. I'm sorry, I went forth. Then we have the degranulation of mast cells and mediators like histamine, tryptase, platelet-activating factor, cytokines, and leukotrienes. And these mediators, which are mainly cytokines, cause spasm of the vessel, either because histamine acts directly on endothelial receptors or in different pathways. And we have plaque destabilization, mainly on type 2 Kuhn syndrome, due to kinase and tryptase dissolving extracellular matrix. Now, let's go to our case. We had a 73-year-old male presenting to the emergency department shortly after cystoscopy. He complained of chest pain and dizziness. He was diaphoretic, tachycardic, hypotensive with a blood pressure of 90/60, and exhibited pruritic plaques over the trunk and extremities. He had a medical history significant for smoking, hyperlipidemia, hypertension, and an acute coronary syndrome 17 years ago, which was treated with a stent on the left circumflex artery, benign prostate hyperplasia, and bladder cancer, for which he received regular cystoscopies. And in fact, this is the patient was at the hospital, he was receiving cystoscopy. He reported no known allergies, which might initially seem perplexing, and we'll discuss that. And his medication regimen was aspirin, atorvastatin, olmesartan, nebivolol, tamsulosin, etanolozine. So, our initial investigation included elevated D-dimers and elevated troponin, which was of note elevated on the second test. And this whole thing suggested cardiac ischemia and possibly prior thrombotic process. ECG, cardiography, chest X-ray, and CTPA were all unremarkable. And at this point, due to increase in biomarker and chest pain in NSTEMI diagnosis, we made a diagnosis of NSTEMI. So what is important at this point is that due to the primarily allergic presentation the patient was exhibiting, he was treated with IV fluids, methylprednisolone, a steroid, and dimetadine, and antihistamine, and that indeed did lead successfully to the resolution of symptoms. 3 days post-event, as shown here, there was a coronary angiogram, and it revealed no obvious spasm, thrombus, or other anomaly. However, although it does show that the anti-allergic medication that we treated him with was successful in resolving the cardiac event, we could not visualize the culprit lesion, and thus the type of Kuhn syndrome in this case was kind of uncertain. So in this patient drug regimen, methylprednisolone, levocetirizine, and inhaled ipratropium were added. And at this point, the combination of cardiac and allergic symptoms plus the rapid response to the anti-allergic we administered pointed strongly to the diagnosis of Kuhn syndrome. During the hospitalization, troponin rapidly normalized, the patient remained stable, and he was later discharged. The trigger was hypothesized to be associated with a new hardware used in cystoscopy. However, it hasn't so far until today been identified with a skin prick test or other allergy investigation. Fortunately, a 1-week follow-up afterwards revealed no permanent functional deterioration of a patient. So finally, what's really important for the audience to learn from this presentation is the following. Firstly, allergic reactions plus cardiac signs should always raise the suspicion of Kuhn syndrome, since anti-allergic therapy might actually be a better option than regular HCS treatment. Additionally, careful history prevents, helps navigating the type of Kuhn syndrome. However, a diagnosis can never be 100% certain without visualizing the lesion with angio. In the same note, the careful history regarding recent exposure should be obtained since it may strengthen the diagnosis, and very importantly, the absence of allergy or atopy does not exclude Kuhn syndrome. Additionally, a normal angio does not exclude the syndrome, since timing after onset of the culprit vessel event varies along with symptoms. Last but not least, we should individualize treatment. So we should address allergy, which might be the causal agent of the cardiac symptomatology and also cardiac symptoms by themselves, because especially in these cases, if allergy is not the causal agent, then cardiac symptomatology should have its own treatment. Additionally, you should keep in mind that histamine-releasing agents like morphine may worsen Kuhn syndrome because they lead to more degranulation, and that has led many authors to suggest that it should be avoided. At any rate, clinicians should have high suspicion for Kuhn syndrome when encountering the combination of cardiac symptoms plus allergy and plus minus the rapid resolvement of symptoms after administration of anti-allergic medication. And yes, the treatments should be individualized in these cases. This is the literature I used for my presentation, and I'd like to thank you for listening and welcome any questions you may have.
Thank you so much. That was a wonderful presentation. I would like to ask our judges, Dr. Njodo and Dr. Imad, if you have any questions, you may please ask.
All right. Dr. Najid, would you like to go?
Hello, I think you could start, Mr. Mohammed.
Oh,
Mr. Mohammed.
okay. Thank you so much for your presentation. This is a very interesting case, and I'd say that we might say some of them in the ER from now on. So, from your presentation, we can say for the clinicians, the good history taking during the attack or during the presentation to the ER can help the clinician while diagnosing or while working on the ABCD in terms of treating the acute myocardial infarction to reduce any allergens or any antigens during their treatment or interventions, and also trying to help or at least differential that there could be allergic reaction or Connors syndrome in this case, and hence treating both in the same manner or spontaneously. Is that correct?
Yes. So for the first part of your question, the definite diagnosis, the definite way to visualize the pathophysiology of Kuhn syndrome at the ER is to have a coronary angio. However, because this is not always viable, especially if the troponin is low and there are no ECG changes, the diagnosis is usually and should be, I believe, clinical. So once physicians would see cardiac symptoms plus allergy, such as in this case urticaria, hives, or any anaphylactoid symptoms, they should treat the allergy, and then there should be followingly more investigation of the etiology of the cardiac ischemia. But at the same time, there should be monitoring of the cardiac biomarkers and imaging done as soon as possible in order to determine whether the cardiac ischemia is deteriorating or has a good clinical course.
All right. Since we are dealing with life-threatening condition like acute myocardial infarction, could be superimposed with Connors syndrome. Is there any study that you have read in your literature review that would help us going through the guidelines or going through recommendations that we can help reduce the incidence or the percentage of anaphylactic shock or any like worsening hypersensitivity reactions when a patient presents to the ER having acute myocardial infarction?
Yes.
And
So
it's okay
first
if
of all,
you
the
want
thing
to
is,
reply further by this on email or.
oh, so we're out of time.
No, no, no.
Okay.
Just we're asking if there is a certain study that you would recommend for that. That's it.
Well, the thing is that since Kuhn syndrome is quite rare, there have been less than 1,000 cases ever reported. It was recently discovered. And so the thing is that there has been no official recommendation, as we see in AI AIDS guidelines, as to what exactly to do in cases of Kuhn syndrome. So the main thing that we can do is read the case reports. There is one study that I can actually forward you with email that has made a mini review of case on the treatment and what exactly has gone wrong and right. For example, with beta blockers, because on the one hand, you have the beta adrenergic action, which is useful in the case of anaphylaxis in order to reverse the bronchospasm. But on the other hand, you give beta blockers in the context of an ACS or afterwards. So it's quite ambiguous what you should do in acute setting. So there has been a small, I'd say it's a review that has reviewed treatments of Kuhn syndrome, and I'd be happy to forward you with this via email. So the main thing that this study reported is that the most definite thing is do not use morphine because morphine tends to worsen mast cell degranulation, and that releases into worsening of the Kuhn syndrome.
Well, that's the ground understanding and answer we were looking for. Thank you so much. Dr. Majid, you can go.
Thank you.
Okay, thank you, Dr. Mohammed. Thank you for your beautiful presentation, Georgios. I think I have just two concerns.
Okay.
The first is around the rationale for your study. It was not quite clear. So I don't know if you could maybe elaborate more on your rationale at the level of the background, because I read your abstract. You mentioned the signs and symptoms of the patient. You also spoke about cardiovascular risk factors mainly. So I would like to know what the rationale for this study was actually. So maybe clarify me more on that, the rationale. Yes.
You mean the cardiovascular risk factors? Are you referring to that?
No, I mean the motivation behind the study, because in the background,
Okay. Sure.
I got more
Yes.
of just the clinical presentation.
Yes, yes. So the rationale behind this case report is, as I mentioned, there have been very few Kuhn syndrome case reports. There has been less than 1,000 ever reported in the literature. No big scale study done. So the main thing that we targeted, me and my co-authors, was first raise awareness about the fact that allergic etiology can actually lead to an acute coronary syndrome, so that clinicians can keep that in mind, and the fact and also described everything along the way. So the cardiovascular risk factors, the age, the sex of the patient, and what happened to his clinical course, so that we gather more data in order to create a bibliography, a literature that can accurately describe Kuhn syndrome, so that it is more easy for new doctors and students to understand the syndrome. So at this point, at such low number of cases, we need as more data as we can. So that was the point of the case report.
All right.
That
Okay.
it's
Because it was
supposed to
not
be
quite clear. Thank
absolutely
you.
sure.
Okay. Okay.
All right.
So the last question, could you maybe mention some other cardiac biomarkers apart from troponin, which you mentioned?
Sure. So another biomarker is creatine phosphokinase. However, as we know, the kinetics of this specific enzyme are a bit different. So it rises a bit earlier and it falls a bit, actually quite a long after troponin. So troponin is the most sensitive molecule we have in assays to accurately determine the time that the ACS happened. So that's why we regularly use troponin. So troponin in this case was to see whether first of all, whether there was an acute coronary syndrome, and second, if it was acutely associated with the allergic etiology we saw, or there was something else going on.
Okay, thank you very much. That's all for me.
Thank you. Thank you. All right.
Thank you so much, judges, for your questions, and thank you, Georgios. It was great.
Thank you.
Okay,
Thank you so
so
much.
now we'll be thank you. So now we'll be displaying the QR code, and please scan it, everyone, and vote for your favorite presentation. This will determine the awards, which will be announced tomorrow at the end of the session. Okay, so for the next presentation, we have Iphigenia Stasinau, who is also from University of Patras. We have a pre-recorded video of her, and the topic is pulmonary artery pseudoaneurysm following necrotizing pneumonia after autologous stem cell transplantation, which is a case report.
Hello everyone, and thank you for the opportunity to present our work. My name is Iphigenia Stasinau, and I'm a fifth-year medical student at the University of Patras, Greece. Today I will present a rare case of pulmonary artery pseudoaneurysm that developed following necrotizing pneumonia in a patient who underwent autologous peripheral blood stem cell transplantation. This case highlights how an apparently resolving infection can evolve into a potentially fatal vascular complication, emphasizing the importance of early imaging and intervention. To better appreciate the significance of this case, I will begin with a brief overview of pulmonary artery pseudoaneurysms as an entity. Pulmonary artery pseudoaneurysm is a rare vascular lesion resulting from disruption of the pulmonary arterial wall. Unlike a true aneurysm, it does not involve all three layers of the vessel wall, but represents a contained arterial rupture. Although uncommon, it's clinically important because the wall of the pseudoaneurysm lacks the normal arterial layers, making it significantly more prone to rupture than a true aneurysm and leading to massive hemoptysis and a high risk of mortality. Pulmonary artery pseudoaneurysms may develop secondary to trauma, often iatrogenic, infection, vasculitis, or malignancy. In infectious settings, necrotizing pneumonia can progressively destroy the surrounding lung tissue, allowing inflammation to erode the adjacent pulmonary artery and ultimately result in pseudoaneurysm formation. Clinical presentation ranges from incidental radiological findings to life-threatening hemoptysis. Therefore, a high index of suspicion is essential, particularly in immunocompromised patients who are more susceptible to necrotizing infections. CT angiography is the imaging modality of choice because it accurately demonstrates the vascular nature of the lesion, its direct communication with the pulmonary artery, and provides the anatomical detail required for treatment planning. With this background, I will now present our patient. Our patient was a 65-year-old woman with a history of Sjogren's syndrome, rheumatoid arthritis, and beta thalassemia minor. She was diagnosed with peripheral T-cell lymphoma of the T follicular helper subtype, Ann Arbor stage 3. You can see the treatment timeline on this slide. She initially received 6 cycles of CHOP chemotherapy and achieved partial metabolic response with a Duvel score of 3. However, 5 months later, she relapsed. Salvage treatment with 3 cycles of ESAP failed to induce remission, and she subsequently underwent autologous peripheral blood stem cell transplantation. The early post-transplant course was complicated by a severe bacterial infection. Immediately after transplantation on day 0, the patient developed febrile neutropenia. Blood cultures grew Staphylococcus aureus, confirming bacteremia. Chest CT demonstrated necrotizing pneumonia involving the right upper lobe. In immunocompromised patients, the intense inflammatory response in necrotizing pneumonia can extend beyond the lung and involve nearby vessels, increasing the risk of vascular complications. Broad-spectrum antimicrobial therapy was initiated promptly and later tailored according to microbiological susceptibility testing. The patient's clinical condition gradually improved and she was discharged on day 40. However, despite this apparent recovery, follow-up imaging revealed something unexpected. 7 days after discharge, on day 47, routine follow-up CT demonstrated partial resolution of the necrotizing pneumonia with residual consolidation and cavitary changes in the right upper lobe. Within this residual consolidation, a new 9 mm avidly enhancing lesion was identified. Subsequent CT angiography demonstrated arterial phase enhancement with direct communication to a segmental branch of the right pulmonary artery, establishing the diagnosis of pulmonary artery pseudoaneurysm. Importantly, the lesion was detected before rupture occurred, allowing definitive treatment at an early stage. Given the substantial risk of rupture, prompt intervention was indicated. The patient underwent selective coil embolization of the anterior segmental branch of the right upper lobe pulmonary artery. Completion angiography confirmed complete exclusion of the pseudoaneurysm without immediate or delayed complication. The patient's subsequent clinical course was uneventful. She achieved complete remission and remains alive and well 5 years after transplantation. This case highlights the pathophysiological sequence that led to pseudoaneurysm development. Following autologous peripheral blood stem cell transplantation, the patient entered a period of profound neutropenia and immunosuppression, predisposing her to Staphylococcus aureus bacteremia and necrotizing pneumonia. The infection likely resulted in arterial wall erosion and pulmonary artery pseudoaneurysm formation. It should be noted that despite clinical improvement after antimicrobial therapy, persistent cavitary lesions, newly developed enhancing nodules on follow-up imaging, or hemoptysis should all prompt consideration of an underlying vascular lesion. Early CT angiography and endovascular embolization play a pivotal role in preventing catastrophic hemorrhage and significantly improving patients' outcomes. In conclusion, our case demonstrates that, although uncommon, pulmonary artery pseudoaneurysm is a life-threatening complication of necrotizing pneumonia in immunocompromised patients that should always be included in the differential diagnosis, and that careful radiological follow-up, early recognition of suspicious imaging findings, and prompt intervention are essential for a favorable long-term outcome. Thank you very much for your attention.
Okay, may I have Dr. Magazine and Dr. Ahmad as the judges for this one? Yeah, if you have any questions, you can just let me know and I'll note it down for the speaker.
Okay, thank you. Sayali, hope I pronounced the name correctly.
Yes.
Okay, so for me, it was an interesting case. It would have been nice to have the presenter here to find out, what was interesting, what was the rationale for, wanting to bring this case out. I noticed she did say that it's a rare occurrence, but, it would have been nice to have her aspect. My question relates to the fact that she kind of was just pointing to the possibility of the bacteria being associated with it, but I wondered if there was any consideration to whether it might have been drug-induced. The patient was on quite a number of anti-cancer agents, so and immunosuppressants, so it would have been nice to find out if that was explored. Thank you.
Okay, I'll note it down. Yeah. Thank you for your question. How about Dr. Ahmad?
Thank you, Dr. Maxine, and thanks for her presentation. I would say that the flow of case treatment and handling the case was somehow valid, and the monitoring was great. But I would suggest that for future practice, the clinician an immune-compromised patient, they should think about considering a more prophylactic and protective antibiotics broad spectrum to prevent such cases. Thank you.
Okay, thank you. Okay, now we'll have the QR code displayed. Please vote for your favorite presentation. And the awards will be announced tomorrow at the end of the session. And I would also like to remind our judges to fill the form that was given to you previously. Okay, moving on, we have our next presenter, Leah Farhadi, who is from University of Miami, and the topic is differences in most preoperative and postoperative lesion and defect sizes for patients with squamous cell carcinomas living in suburban and urban communities. And for the judges, we have Dr. Valusha and Dr. Njodo. Yes, Leah, you can start.
Good afternoon. My name is Leah. I'm a medical student at the University of Miami Miller School of Medicine. I'm presenting on our team's work on whether where a patient lives, suburban or urban area is associated with more advanced squamous cell carcinoma at the time of mole surgery. So a little bit about why this project was done. We know that health disparities research consistently shows that suburban residents have higher household incomes and greater educational attainment than residents of urban core communities. Both factors, such as income and education, have independently been linked to earlier skin cancer diagnosis. So that raised a question for us. If suburban patients are typically diagnosed earlier, does that actually show up in the operating room? In other words, do urban patients present with larger, more advanced squamous cell carcinoma by the time they reach a mole surgeon? Squamous cell carcinoma is one of the most common skin cancers worldwide, and mole surgery is a gold standard treatment for high-risk lesion because it maximizes tissue conservation. Lesion size, wound size, and the number of layers needed to clear the tumor are all reasonable proxies for how advanced a tumor is at presentation. So our aim was pretty much straightforward. We compared preoperative lesion size, post-operative wound size, and the number of Mohs layers removed between urban and suburban patients treated for a squamous cell carcinoma. To answer this, we performed a retrospective chart review of 274 patients who underwent Mohs surgery for biopsy-confirmed squamous cell carcinoma, all under a single physician at an academic hospital in Miami. Using each patient's home zip code, we classified their community as urban or suburban using the Pew Research classification. The Pew Research classification, we specifically used a zip code was considered urban if it was within 12 miles of a city center with a household density greater than 1,314 households per square mile. And it was suburban if it was within the same 12-mile radius but had a lower density, down to 106 households per square mile. We cross-referenced every zip code against census data and identified 117 urban patients and 154 suburban patients. For each patient, we recorded the lesion size before surgery, the wound size after surgery, and the number of Mohs layers needed to achieve clear margins. We then compared the means between two groups using a two-tailed t-test with statistical significance set at a p-value less than 0.05. So what we found for urban patients, the average preoperative lesion size was 1.71 centimeters. The average postoperative wound size was 3.4 square meters. And the average number of layers removed was 1.79. For suburban patients, those numbers were 1.81 centimeters, 3.77 square centimeters, and 1.58 layers, respectively. So when we ran the statistics, lesion size and wound size showed no significant difference between the two groups. The number of layers removed did reach a statistical significance at a p-value less than 0.02. But an important thing that we found here was that when we rounded these two numbers, they both averaged to 2 layers to achieve clear margins. So while the difference was statistically significant, it wasn't very clinically meaningful. A surgeon planning a case wouldn't treat these two populations any differently because each one was very much close to 2. So practically, this tells us that at this single academic center in Miami, urban versus suburban does not translate into a meaningful difference in how advanced these squamous cell carcinomas are by the time patients reach the operating table. That's a reassuring finding. It suggests that whatever access or timing disparities may exist upstream, essentially here in Miami, since it was done only in Miami, they aren't producing a measurable gap in surgical burden downstream, at least in this population. So to conclude, we found no statistical difference between urban and suburban patients in preoperative lesion size or postoperative wound size. And although the number of layers removed differed statistically, there was no clinical significant difference between the two groups, as both rounded was equal to 2 layers on average. Essentially, a few limitations worth noting. The study was limited to 1 physician and 1 academic center in Miami. And it did not include rural patients because we had too much of a small sample size. There isn't much rural population here in Miami. So these findings may not generalize beyond the setting. And I would like to thank my co-authors, Ryan, Sarah, Sheila, and Dr. Jean-Pierre and Dr. Nori, and I'm happy to take any questions. Thank you.
Thank you so much, Leah. It was wonderful.
Thank you.
Hi, Leah. So if I can begin my questions,
Mm-hmm.
Would you be ready to answer? Can I begin the questions?
Yes. Do you hear me? Yes.
Okay, so the first question is, your hypothesis was that socioeconomic differences would show up as a different lesion sizes at presentation, but you found essentially none. Is that because SES doesn't matter here, or because a single Miami practice draws a fairly homogeneous population?
So that's what I believe is happening with the patient population here, because Miami has a very prominent dermatology practice here. I believe it's number 4, number 5 in the country. I think that we do get a homogeneous group because they come from very far and they know where to go. I think if we did this mainly in places that were more rural, like Hawaii or somewhere where dermatology and finding dermatology, especially mole surgeon, like maybe Alaska, we would find something different.
Okay, my next question to you would be, you found a significant difference in number of layers, that's P equal to 0.02, but discarded it as not clinically meaningful. So how do you justify dropping your significant finding, and could it hint at a real difference in tumor complexity?
So when we rounded out the numbers, it was essentially both rounded to 2. So it was the layers was 1.79 for the urban and 1.58 for the suburban, which is a very, very small difference. So it's just statistically it was significant, but clinically, since they're both rounded to 2, it's not very clinically significant and wouldn't make much of a difference if a mole surgeon was removing that, because it's not very significant. A significance clinically will most likely be greater than maybe 0.5 centimeters.
Okay, my final question is, zip codes assigns a neighborhood's characteristics to individuals, which is an ecological fallacy. So how does that limit your conclusions, and would individual level SES data have changed the design?
I believe so. We use these zip codes mainly using the Pew Research. And I think if we use something else, maybe relying more on census or relying on other measures, it would have been different.
Okay, thank you for your answers. That's all from me. Thanks.
Thank you.
Hello, Leah. Thank you for your beautiful presentation.
Thank you.
All right. I have just 2 concerns. The first is about your conclusion. It was not quite clear. So based on your findings regarding the significant difference in the number of layers for the lesion between the 2 groups, the urban and suburban, so what conclusion can you make?
So we concluded that based on the layers, it did have a statistical significant difference based on the two-tailed t-test of less than 0.02. But the measure was just not clinically significant, because it was a fractional difference. So for urban, we had 1.79 layers were removed and 1.58 layers were removed in suburban, and it's just not very clinically significant in practice because it's very much fractional. If it was greater than 0.5 centimeters, that would have made a difference surgery-wise. But yeah, in practice, the numbers are very insignificant.
Okay, thank you. So how does that translate in terms of the patient's morbidity? Since you said you are assessing patient's morbidity in terms of those three aspects.
Yeah, so the preoperative lesion size, postoperative wound size, there was no significant or clinical significant difference between the two patients, suburban and urban. And while we did find a statistical significance between the layers removed, how many processes the skin had to be removed until the tumor was totally clear, while it was significant with numbers, a surgeon wouldn't remove based on fractional centimeters. That wouldn't be relevant to his practice.
So could we say the urban patients are they are more morbid than the suburban patients?
Well, here, based on statistical significance, we could say that the suburban patients are found to have less of the squamous cell carcinoma is less advanced based on numbers, but based on clinical judgment, no.
Okay.
Because we use centimeters to remove the skin cancer because it's on the face, and we want to preserve as much skin on the face as possible because of the scar. And because it was a fractional difference, it really doesn't make much difference in the scar that would be produced.
Okay. So what could be the take-home message or maybe an implication of your study?
The implication of our study could be that because Miami dermatology is close to both urban and suburban areas, and it's maybe like the number 4, number 5 in the country dermatology wise, and we do have 3 Mohs surgeons on site at one practice, and in total I believe there's 5 just at one academic center. We can say that being in a suburban area versus an urban area doesn't provide any protective factors, and they're both the similar. So the implication is we would have to do this at a different state or a different part of the state to see if there's actually a difference.
Thank you very much, Leah. Thank you.
Okay, thank you so much, Leah. It was an amazing presentation.
Thank you.
Okay, so we'll be displaying the QR code. Please, everyone, scan it and vote for your favorite presentation. Okay, so for the next presentation, we have Noor Azaldin Sharif Taha, who is from University of Khartoum, Faculty of Medicine, Sudan. And the topic is sleep disorders among University of Khartoum medical students during armed conflict in Sudan, which is a cross-section study in 2025. And the judges will be Dr. Ahmad and Dr. Saad.
Good evening, everyone.
Yes.
My name is Noor Izzeddin Sharif Taha, fifth year medical student, University of Khartoum. I am the role presenter of sleep disorder among University of Khartoum medical student during the armed conflict in Sudan 2025 cross-sectional study. Before starting, I would like to express my sincere gratitude to the Community Department, Faculty of Medicine, University of Khartoum, and for Student Association, Faculty of Medicine, University of Khartoum. And let's move to the background section. As we know that sleep is a fundamental part in the physical and mental health. It is essential for cognitive function, memory, and emotional regulation. And medical students are especially vulnerable to the poor sleep due to the demand of a medical training. Since April 2023, the ongoing conflict in Sudan has disrupted the academic and social life of University of Khartoum students through displacement, insecurity, and psychological stress, which may contribute to sleep disturbances. So, the aim of the study is to assess the prevalence of sleep disorders among medical students at University of Khartoum and to examine the relation between the academic stress and conflict exposure. Moving to the methodology part of our study, to achieve this, we conducted a cross-sectional study at the University of Khartoum 2025. A total of the 274 medical students participated with a response rate of 99.6%. Data was collected using a structured questionnaire that include socio-demographic data, conflict exposure and academic stress, and sleep quality assessment used the Pittsburgh Sleep Quality Index. Participants were classified into the good and poor sleep quality based on the Pittsburgh Sleep Quality Index scoring. Conflict exposure and academic stress were categorized into the mild, moderate, and severe levels. We analyzed the data using the chi-square test, and statistical significance was set at the p-value less than 0.505. Now let's move to our results section as appear here in the PowerPoint. Our result showed that sleep problems were highly prevalent among students. 67.4% of the participants had a poor sleep quality. The most common sleep problem was difficulty in falling asleep, reported by 48.2%, followed by nighttime awaking, reported by 32.6%, and thermal discomfort during sleep, reported at 22.8%. Also, regarding exposure level to conflict, most students experience moderate to high stress. 30.4% had a severe conflict exposure, 41.7% had a moderate exposure, and only 27.5% mild or no exposure. Also, for academic stress, we had 41% of the students reported a high stress, and 45% reported moderate stress, and low stress reported by 14% of the students. And the important finding was that the conflict exposure had a statistically significant association with the poor sleep quality, with the p-value is 0.013. However, academic stress was not statistically significant, with the p-value reported as 0.175. This leads us that the conflict-related experience such as insecurity and displacement may have a stronger impact on sleep than academic stress alone. Now let's move to the discussion part as mentioned in this presentation. On discussion, this study revealed a high prevalence of a poor sleep quality among medical students at the University of Khartoum, with a difficulty initiating a sleep and nocturnal awaking, being the most common disturbances. Exposure to conflict was significantly associated with a poor sleep quality independent of academic stress and socio-demographic factors. These findings highlight that the urgent need for targeted intervention, including promoting sleep hygiene and providing mental health support, especially for students exposed to conflict. So, in our conclusion, we find that sleep disorders are highly prevalent among University of Khartoum medical students during the armed conflict, and conflict exposure is a significant predictor of poor sleep quality. Thank you for your attention, and I will be happy to answer to all your questions.
Thank you so much, Noor. It was really interesting. Dr. Ahmad and Dr. Sajid, if you have any questions, you can go ahead and ask.
All right. Thank you so much, Dr. Noor. I'm sorry to see these statistics in conflict-affected areas. First of all, how did you calculate your power analysis and how did you estimate your sample size? How did you make sure that your questionnaire has been delivered to students? Yes, I'll follow up later.
I calculated the sample size from a population of my population using the Korpach formula, and also we use a random stratified sampling technique, and we also reported the questionnaire and collected the data from the student using online questionnaire via the Telegram and WhatsApp.
All right. What was your sleep quality questionnaire? Like the
What's the
validated questionnaire, the name.
It was a validated questionnaire. It's called the Pittsburgh Sleep Quality Index, and it's a validated questionnaire from 0 to 21, and it's a
Yes.
scale any scale more than 5. It's poor quality.
All right. Thank you. And last question would be, uh, why do you think there was no statistical difference between academic stress and poor sleep quality, even though in other studies, like one I've been involved myself, there was association.
Thank you for this point. It is important point. Yes, there is academic stress and the association between them also uh, perfectly. But in that moment and in that time, the conflict exposure was very high and had a very stronger impact than the academic stress. The student have going through several mysterious event, displacement, and loss of personal home and mysterious events, so that because of that the conflict exposure was more higher impact than academic stress at that moment.
So we can say that according to Maslow pyramid, saving life and seeking security is more important than
Yeah.
being high achiever.
Yes.
Thank you.
Yes. Welcome. uh, Dr. Sajid, I can't hear you.
Hello.
Dr. Sajid, do you have any questions? Yeah, we can hear you now.
You gave the good result and the prevalence about the sleep disorder in your university. So I have a question about that. In your what are the results? Whatever the participants are there, is there anyone who are taking the medicine for the sleep disorder, or any result you have found that someone is already taking this medicine from long time or anything?
If I heard you well, our study population was undergraduate medical student from the first to sixth medical student. So, did I answered you?
No, no. My question is that sleep disorder is prevalent in your university. So, what any of your participants was on the medication for the sleep disorder?
No. Our scope of our research is to assess the association between the sleep quality, and conflict exposure. Your question is out of our scope, but we can put this point in further research. That is the very question. Excellent question. Thank you.
Yeah, good.
Thank you so much, judges, for the questions, and thank you, Noor, for the presentation. We'll be displaying the QR code now. Everyone, please scan it and vote for your favorite presentation. Your votes will help determine the awards, which will be announced at the award ceremony tomorrow. And I would also like to remind our judges to fill the form which was given to you guys previously. Thank you. Okay, for the next presentation, we have Dr. Riya Sangrawat from India, from BGS GIMS Hospital, and the topic is intermediate syndrome in organophosphate poisoning, early neuromuscular predictors of respiratory failure in the emergency department. For the judges, we'll be having Dr. Adinei and Dr. Njiodo. Dr. Riya, you can start.
Okay, hello, am I audible? Hello.
Yes.
Am I audible? Okay. Hello, everyone. Hello, judge panel. I'm Dr. Riya Singh Rawat from BGS GIMS India. I will be presenting my topic, that is the intermediate syndrome in organophosphate poisoning, early neuromuscular predictors of respiratory failure in the emergency department. I conducted this study along with my colleagues, that is Dr. Josh Reggie, Dr. Umamya, under the guidance of Dr. Srijamya. So, what is intermediate syndrome? Intermediate syndrome is basically the muscular paralysis that is caused by the acute organophosphate poisoning that is due to the inhibition of the neuromuscular junction, which typically emerges 24 to 96 hours post consumption following initial cholinergic crisis. Acute organophosphate poisoning is one of the leading causes of mortality all over the world, especially in South Asian countries, due to the easy availability of pesticides and insecticides. So it is important that the ER department recognizes it, because patient might come in altered sensorium or with low GCS. So we need to see the signs, symptoms, recognize it, start the standardized antidote therapy, that is atropine and oximes, and give prompt respiratory support if and when needed. So the aim and objective of this study was to evaluate the predictive values of early neuromuscular and biochemical markers in patients in risk of developing IMS, that is intermediate syndrome, and subsequent respiratory failure, because then they might require ventilation. So the methodology was, we conducted a systematic research by the search from taking data from the search engines like PubMed, Google Scholar, Scopus, according to PRISMA guidelines. We included all the adult patients who consumed organophosphate poisoning for this study. The inclusion criteria were the studies which have more than 5 patients. In English, they had biochemical values and SFEMG jitter, that is single fiber electromyography jitter, and then they were diagnosed with IMS. The exclusion criteria were where they had very few patients, or else duplicate publications, or they lacked data or case reports. So the data was extracted, then pooled, and then assessed using the I-square statistics. Now for the results, as you can see the results, we assessed 4 main parameters. First parameter was RBC acetylcholinesterase, that is red blood cell acetylcholinesterase. So it shows heterogeneity of 33%. That indicates results across the studies, that is highly significant. So the patients whose red blood cell acetylcholinesterase drops below 20% of the normal baseline, that is 24 hours after the consumption of OP poisoning, it was shown that there is a chance of 5.2-fold increase in the odds of developing IMS compared to those who maintain higher levels, because of the confidence interval, which is not touching the no effect line. You can say that it provides a strong statistical certainty for clinical risk stratification. Next was elevated serum creatinine kinase. Out of the 100,044 patients, it was shown that it has a positive significant correlation. It showed that it serves as a discrete biochemical marker for muscle damage and impending neuromuscular failure, advising clinicians to initiate aggressive monitoring as soon as they can. The third one was serum cholinesterase. As it is seen in the forest plot, that the pooled diamond and individual study interval that crosses the no effect line. This means that the standard serum cholinesterase levels do not reliably correlate to developing IMS. So relying on this during emergency triaging, especially in emergency room, might be mismanaged. The fourth one is SFEMG jitter, that is single fiber electromyography jitter. That is basically the transmission, it shows the transmission between the nerve and the muscle. So that time is usually less than 30 micromilliseconds. So if the jitter is increased more than 33 microseconds, it showed the heterogeneity was high, but the sensitivity was 86%, which means that if a patient is at a risk of developing IMS and will need respiratory ventilatory support, there is a 86% chance percentage where this will detect it. It will detect in the OP poisoning patients. There were certain limitations to this study, like the study pools were different. One biochemical marker showed 1,000 patients, while the other one was 863. There are other certain parameters which were not included, such as the pathological variations and physiological variation. Pathological variation, like we included other patient, but not the, suppose the patient has CLD or CKD, that might change the level of baseline pseudocholinesterase in that patient. And then the other physiological marker might be like in pregnant patients or in patients who are taking estrogen therapies, the baseline level is reduced. And in male people who have more RBC, for them there will be an increasing trend in the acetylcholinesterase. So those were the limitations. Other than that, I would like to conclude that in this study, to develop to identify patients who might develop IMS in the ER, it is critical to utilize RBC cholinesterase, serum creatinine kinase, and an electrophysiological testing, that is SFEMG jitter, as it can provide a sensitive window for early detection and potential neuromuscular weakness that can lead to respiratory failure requiring mechanical ventilation. Utilizing evidence-based predictors will allow for better triaging of the patient in the ER, and it might potentially decrease the substantial risk of mortality associated with acute organophosphate poisoning. Thank you. This was my presentation.
Thank you so much. We'll be having Dr. Maxine to ask any questions if she has.
Thanks, Dr. Rawat. This is very interesting. It really is important for us to be aware of poisoning and managing of poisoning. I was just wondering, how prevalent is this likely to occur in your country, exposure like, and how do you see it actually informing your personal journey in this area?
Organophosphate poisoning is really common in my country.
Did you get my question? It looks like you're freezing up.
Could you repeat the question, ma'am? It was cut. Hello?
Yes, I wanted to know how common is this kind of poisoning taking place in your country, and on the basis of why did you do this study? I mean, so what? How is it going to help you?
Yes. So thank you so much for the question. So OP poisoning is actually one of the leading causes of poisoning in my country, India, for mortality, as it is very common for anyone to get organophosphates, insecticides and pesticides, and they can buy it. And why is it significant is because there is a lot of delay that happens, especially in my country. If you see, people go, maybe I am working at a tertiary care, but like farmers, they first go to a clinic and then there's a delay. After that, they'll come to our hospital where there might be more delay. So there is no easy access to treatment. So if suppose a patient is coming from a normal primary clinic to our hospital and there is already a delay, we should know why. The first of all, we should see the signs and symptoms, because the patient might not be able to talk to us. So we should see the symptoms like excessive salivation or bradycardia and such things. And then we need to immediately send the necessary biochemical markers, like as it was shown that rbc acetylcholinesterase, that is, it was very significant, but that values drop by 20% within 24 hours. So to reduce that delay time, we should send the important investigations from ER, because ER is the first line of defense. So we need to recognize, give ABC, ventilatory support, and send the necessary investigations that is required from our side.
Thank you. No more questions from me.
Thank you so much.
Thank you so much, Dr. Ria. It was really amazing.
Thank you.
Okay, so we'll be having the QR code displayed now. I request you guys to vote for your favorite presentation, and the awards will be announced tomorrow at the award ceremony. For the next presentation, we have Dr. Rahul Radhakrishnan Pillai, also from BGS GIMS Hospital, India. And the topic is sepsis-associated encephalopathy as an early predictor of mortality using neurological status upon ED admission to predict long-term outcomes in septic patients. So you can go ahead, Dr. Rahul.
Thank you so much. I'm Dr. Rahul Radhakrishnan Pillai, Casualty Medical Officer, BGS Global Institute of Medical Science, Bangalore, India. And my topic is sepsis-associated encephalopathy as an early predictor of mortality using neurological status, GCS, or delirium score upon ED admission to predict long-term outcomes in sepsis patients. And my team members are Dr. Riya Singh Rawat and Dr. Gautam Gogul, under the guidance of Dr. Sunitha Parmar. And thank you so much for having me here. So, sepsis-associated encephalopathy is a dangerous multifactorial complication of sepsis, causing diffuse dysfunction of the brain, and is a common presentation in emergency department. Sepsis-associated encephalopathy presents a spectrum from mild cognitive deficit to deep coma. However, the lack of specific biomarkers and the confounding effects of sedation make the SAE a challenging diagnosis of exclusion. It requires the systematic elimination of alternative etiologies for altered mentation in the febrile and critically ill patients. So, main aims and objectives. To evaluate the efficacy of neurological assessment tools and biochemical markers at ED admission as early predictor of sepsis-associated encephalopathy and long-term patient outcomes. So the main methodology which I'm using for this studies. A systematic search of PubMed, Scopus, Embrace, and Cochrane library was conducted from inception to March 2026 according to the PRISMA guidelines. Studies involving adult patients reporting efficacy for safety outcomes with at least 5 patients. Full text article published in English showing the GCS scores and delirium screening in ED during admission for early identification of SEA and determination of 28-day mortality and long-term cognitive outcomes were included. Studies with fewer than 5 patients, review articles, editorials, and case reports, duplicate publications, lacking outcome data, conference abstracts without sufficient data were excluded. Heterogeneity was assessed during the statistical period. So, as a person working in emergency room, seeing these kind of cases every day, plus the evidence which you are getting from the studies which show us the prevalence of 70% among the sepsis patients with the sepsis-associated encephalopathy. Among that, when we are watching on the GCS score, if it is less than 14, then the prevalence is, then the incident rate is 49.3%. But on the other hand, if the GCS is 3 to 8, in between 3 to 8, then the mortality rate is increased to 63%. In essence, if the delirium is also present, then the mortality is increasing by the 4.3-fold, showing a 15% mortality after 28 days of long-term cognitive decline. Among this, there are some challenges which we are facing among the SAE patients, which are inadequate biomarker availability in some laboratories. For example, like NSE, like neuron-specific analyze or neurofilament light chain. In some laboratories, these are unavailable. In these cases, as a doctor working in emergency department, we are fully depends upon clinical diagnosis on glucose GCS scores plus delirium findings. So these are some challenges which we are facing among the patients with the SAE. So conclusion. Early identification of sepsis-associated encephalopathy, clinically calculating the GCS score and delirium screening on arrival in ED is essential and beneficial, as these assessments serve as a powerful, independent and non-invasive predictors of 28-day mortality and long-term cognitive impairment, enabling clinicians to implement critical neuroprotective strategies and improve prognostic chances immediately upon admissions. Thank you.
Thank you so much, Dr. Rahul. As for the judge, we have Dr. Ahmad with us and Dr. Magzine.
Dr. Ahmad, maybe you should go first.
Yes, thank you so much for your presentation. I haven't been following the presentation from the start, so could you just briefly mention about the heterogeneity and risk of bias in your study?
Yes, sir. So based upon the studies and the article which I am using for this studies, the patients which are getting on SAE, heterogeneity from different age group and different categories of people from different socio-economical background also. So based on this, as I explained, that there are some challenges also which are facing among the patients.
All right.
Plus, so?
Yeah, all right, I'm following.
Yes. Then there are in different setups and different hospital setups, we are facing some challenges. Like I explained previously, that some biochemical markers also, like NSCs and neurofilament light chains. Then based on this, depends upon the patient age category and the different socio-mechanical group, these things are changing. So we try to keep an heterogeneity among the people, among the number of patients which are getting on the emergency department, as much as which are getting from the patients mentioned in the article. So of course we are keeping a proper heterogeneity among the studies category of people.
All right. So in your mortality rates, yeah, they recommend like the screening for all patients, or for just high risk patient with the Glasgow coma scale like less than 8, or what is your recommendation based on your study results in this case?
Yes, sir. So as a doctor working in emergency room, we cannot fully trust on instrumental diagnosis or biochemical analysis, because we need a fully clinical assessment for the patients, because we don't get enough time in the emergency room for every patient. So it's better to depend upon GCS or delirium score to find a proper 28-day or even outcome in the patients. That's why moreover we are using clinical statistics, as I mentioned above.
Yeah. Sorry, Dr. Magzine, usually I'll let you lead first, but one last suggestion from me, elaboration. In these settings, we would prefer as researchers to inform future practice the a more targeted systematic review and meta-analysis on patient outcomes and patient safety profiles, right, to be conducted, and also calling for RCTs that involve a certain population of patients, so that we can have eventually established guidelines in terms of treating patients with a coma scales less than 8, or those who have shown high sepsis-associated encephalopathy. Thank you so much.
Thank you.
Okay, thanks, Dr. Mal. Yes, you asked my question, so I really don't have much more except to ask, based on your environment, and you did mention limited resources, how do you actually confirm sepsis in your emergency environment?
You mean the clinical diagnosis of sepsis, ma'am?
Yeah.
Okay, ma'am. Based on the clinical criteria, like moreover, we are depending on the vitals of patient upon the arrival in emergency room. We're checking both on the pulse rate plus normal heart blood pressure and all. And usually, some patients with the sepsis, if patient is going to the septic shock and all, we get the patient in a hypoglycemic state or hypertensive state. So first we need to assess all these vitals as a primary management. Then we will go for the further treatment procedures and all. In essence, we are actually sending all the biochemical markers which I earlier like procalcitonin or NT-proBNP and all, which is really helpful in the diagnosis of clinical diagnosis of sepsis-associated sepsis encephalopathy. Other than that, in emergency setup, we can go for an arterial blood gas analysis, which clearly shows the present condition of the patient in most of the scenarios.
So in your study, was it confirmed sepsis, or were you using suspected sepsis?
Upon arrival on ED, we cannot make a proper diagnosis based upon ED arrival. So we will conclude with a provisional diagnosis. Plus, based upon the clinical criteria and the biochemical markers, which I earlier mentioned, we can come to a proper diagnosis, which will take some time for proper diagnosis. Before that, we are treating the patient with the provisional diagnosis.
Thank you very much.
Thank you, ma'am.
Okay, thank you so much for your presentation. We'll be moving on. Let's display the QR code for voting. Please vote for your favorite presentation. And I would also like to remind our judges to fill the form which was given previously. Okay, so next up we have Sophie Kazarin from California University of Science and Medicine. The topic is Narrative Medicine Workshops Promote Empathy and Humanistic Development in First-Year Medical Students, a Mixed Method Study. Yes, Sophie, you can go ahead.
Okay, can everyone hear me? Can you hear me?
Yes, we can. Yes.
Okay, great. So hello everyone, my name is Sophie Kaiserin. I'm a medical student at the California University of Science and Medicine in California of the United States. And today I'll be presenting our research study called Narrative Medicine Workshops Promote Empathy and Humanistic Development in First-Year Medical Students, a Pilot Mixed Method Study. So the focus of our research is empathy. So we know that empathy is associated with improved patient outcomes, satisfaction, and physician well-being. However, numerous studies have found that empathy often declines during medical training, and that is including in the preclinical years. So in response to such findings, a field called narrative medicine emerged from collaborative efforts between physicians and various humanities scholars. Narrative medicine is an interdisciplinary field that incorporates the power of narratives and storytelling into medical practice in order to humanize the healthcare experience for both the patients as well as the clinicians. And over the years, it's been shown that narrative medicine can support empathy, reflection, as well as professional identity formation. However, a lot of the narrative medicine interventions occur over extended periods, which unfortunately then pose challenges for integration into time-constrained medical school curricula. Therefore, for our study, for this mixed method study, we evaluate whether brief narrative medicine workshops can enhance empathy in first-year medical students and also explore their feasibility for curricular integration. So for our study, first-year medical students participated in optional 60-minute narrative medicine workshops, and we measured empathy pre and post-workshop using the Jefferson Scale of Empathy, the medical student version. In addition, we also conducted open-ended one-on-one interviews with the participants and analyzed a transcript via thematic analysis. And then on the right side of the slide here shows the format of the workshops that we facilitated. So participants first completed the Jefferson Scale of Empathy, the JSC pre-workshop, followed by a brief overview of narrative medicine, as well as the ground rules for the sessions. And then as a group, we completed a close reading of either a poem or a short story, and discussions were then facilitated by an experienced narrative medicine practitioner who has a master's degree in narrative medicine, along with a physician faculty member at the medical school who is trained in the principles and the methods of narrative medicine. And then we had our participants engage in prompted reflective writing, which was then followed by sharing of the writing and facilitated discussions. And then last but not least, we wrapped up the sessions and participants completed the post-workshop empathy survey, the JSC. So here are the results. So on the left side here, we have the quantitative results from the JSC, the Jefferson Scale of Empathy. And the top graph here shows the overall results from all the workshops that were facilitated. So the blue bar here shows the pre-workshop JSE data, and the orange bar shows the post-workshop JSE data. And we were very happy to find a statistically significant increase in empathy scores from pre to post-workshop. And then the bottom two bar graphs here are specific to the workshop using a poem, which is the one on the left-hand side, and then the one that was specific to using a short story, which is the other one on the right side. And we were, again, very happy to find that there was a statistically significant increase in empathy from pre to post workshop for both of the workshops, as well as all the sessions combined. And then on the right side of the slide here shows the themes that were found from our interview data. And the themes here are written out in bold. So they included perspective taking and empathy, reconnecting with initial purpose in medicine, community and peer connection, reflective supportive environment, and last but not least, desire for curricular integration. And so then to highlight some of the quotes here, I'm going to go ahead and read the third quote that's listed here that I think is quite meaningful. And it goes, "This workshop experience reminded me to stay grounded in patient-centered care, doing right by my patients in whatever way best supports their needs. It reinforced the importance of listening to patients and speaking with them, not to them. More broadly, it brought me back to my original sense of purpose in medicine, a commitment to service and caring for others. In difficult moments, it helps me reconnect with the motivation that led me to pursue medicine in the first place." Now, the conclusions of our study. So we found that brief narrative medicine workshops demonstrated significant improvement in medical student empathy. Workshops were perceived as meaningful, reflective, and community-building experiences. Last but not least, results highlighted that narrative medicine workshops are a scalable, low-burden curricular strategy to counteract early empathy decline, and they reinforce humanistic formation in medical training. And looking forward, we think that increased iterations of the workshops can be helpful to obtain larger data sets. And we recommend that for future studies should evaluate long-term impact, optimal frequency, and integration strategies within the required medical school curricula. Thank you.
Thank you so much for the presentation. Now I would request our judges, Dr. Ahmad and Dr. Maxine, to ask their questions.
Okay, thank you very much, Dr. Kaiserin. That's very interesting work. We do see it all the time with students, they just lose that, and it's easy for them to lose it, especially when they're working on wards like Department of Medicine, where people are just dropping left, right, and center, and they know the physiology, they know the pathology, so it's important.
Hello, the audio got cut out.
Coursework, or did they voluntarily? Was this done as a part of a course that they would have gotten a grade for, or was it a voluntary activity?
Yes, this was offered as an optional activity. So we first wanted to offer these sessions to the students in order to kind of test out what the reception would be. And ultimately, because we got such positive feedback and great reception, as well as great data from the participants, our hope is to then transition into offering this more as a part of a required curriculum.
Okay, so what was the response or the interest in terms of the percentage of students who could have done it and who did it?
Yeah, so out of 130 students that were invited, we had around 30 participants who signed up and participated in the data collection, which included the survey and the interviews. So we think that it's a pretty good turnout, given that this is completely an optional activity that no one was required to do as part of their curriculum.
But that 130, was that the full cohort of students that could have done it, or you just selected 130?
That's the full core of students who could have done it if they were available for the session.
Okay. Did you do any follow-up to see if it really did make a difference? I mean, how long did you follow them for?
Yeah, so this was a very short-term study. So we collected the quantitative data with the JSC during the workshop, and then we followed up with almost all of them as an interview after the sessions. So as for the next steps, for our recommendations for future studies is to measure long-term effects, because we would like to know if, their empathy increased following the sessions, but can that increase be maintained over long term? So that would be a question that we would like to find out going forward.
Okay. Thank you. Dr. Ahmad, your time.
Thank you, Dr. Maxine. Thanks, Sophie, for this thoughtful project. And I personally love the projects that leads to research, like cohort. I mean, making sure that we benefit from these projects. How confident are you from your results that the empathy increased because of the workshop, or because of the lectures that were presented to the interested students in raising their awareness about empathy and medicine?
So
Yeah.
Go ahead.
Did you think of a control group? Did you think of measuring the empathy against those who didn't take the workshop?
Yeah, so as far as our data that we were able to collect from the workshops that were conducted already, we're pretty confident that the workshop had a positive impact on these students, because our statistical analysis involved the pre-workshop survey data, which was conducted immediately before the workshop, and then the post-workshop, which is then collected immediately after the workshop. So that given the fact that, the intervention that occurred between the pre and the post was the workshop, that 1 hour of the workshop session, we are pretty confident that the workshop, must have had an impact on the increase in the empathy scores in the pre-workshop data. As far as for students, this is a really good question, which is we did have a lot of students show up, even though this was a completely an optional activity. But something that we would like to work on is how to attract students who are not interested in activities of this nature, right? Because we had a lot of students come who are already interested in poetry, who are already interested in short stories and literature. And those were the students that primarily attended our sessions because they already had that interest. But then the next question that we would like to address is, how do we attract other students who otherwise would not come simply because this is not required for their, graduation credits? So that would be
Yeah,
something that we would like to explore, because we do want to offer this to as many students as possible because of the positive results that we got from the study.
yeah. Thanks for your elaboration on this question. It's simply not about interest. Eventually, it's about more saving lives and about being sympathetic with patients and their families. I mean, it could be our families at the end in the doctor's hand one day. Moreover, you have conducted interviews on only 10 students, I believe, right?
Yes. So
And
10
just excuse me if I may. And also, were there any like independent reviewers that made the thematic analysis? How confident are you from your thematic analysis? Were like established categories, for example, some highlighted words that fall in categories, and those independent reviewers could review independently, and then the supervisor of the study have made sure that those reviews aligning together. I mean, just making sure of the reliability and adaptability and validity of the results of this study, of these interviews.
Are you asking about our confidence level with our interview analysis?
Yeah, about the thematic analysis. Have been there independent reviewers in terms of the thematic analysis in the study? I mean, I understand that this is only a poster, but we are just giving comments for potential and future publications or future projects. That's it.
Yes, I understand now. Yeah. So the interviews were conducted by one of the two co-facilitators. And we did that way for purposefully. We wanted to keep the data collection method consistent across all of the interviews that were conducted. And then we had that interviewer complete the entire thematic analysis as well. And then we had the other co-facilitator would then review the transcripts and confirm. And so we wanted to keep the interviewer consistent across all the interviews, because we didn't want to introduce new variables by having, one interviewer for this person, two for that, and then switch it up.
Thank you so much, and we would love this kind of a project to be implemented on more senior levels and doctors in the future. Thank you.
Thank you.
Thank you so much, judges, and thank you so much, Sophie, for the wonderful presentation. So next up, we'll be having the QR code displayed on the screen, and I would request all of you to vote for your favorite presentation, and the awards will be announced in the award ceremony at the end of tomorrow's session. So we request you all to stay with us till the end of tomorrow. Okay, moving on, we have our next presenter, Muzan Ibrahim, a medical student from the University of Khartoum, Sudan. The topic is educational continuity among Sudanese medical students during armed conflict, a cross-sectional study. And for the judges, we'll be having Dr. Adinay and Dr. Tanya. Yes, Muzan, you can share your screen.
Okay, well, okay, can you see the screen?
Yes.
Okay, well, um, good evening, everyone. My name is Muzan Ibrahim, and today I'm so pleased to present our study entitled Educational Continuity in Crisis, Determinants of Educational Situations among Medical Students During the Armed Conflict in Sudan. Okay, the question will be, how many medical students have had to interrupt their education because of the war? What factors prevented them from continuing? And what can be done to help protect the future of medical education and the healthcare workforce? Since the armed conflict began in Sudan in April 2023, higher education institutions have experienced severe disruption. More than 100 educational institutions have been damaged and millions of people have been displaced. Medical education has been particularly affected, with students facing not only interruptions to their academic programs and activities, but also reduced access to clinical training, psychological challenges, financial difficulties, and uncertainty about the future healthcare workforce. In this context, it is important to understand the factors that enable some students to continue their education while forcing others to discontinue it. Identifying these factors is essential for developing effective education strategies and policy responses during times of crisis. Accordingly, this study aimed to assess the impact of the Sudanese conflict on the educational continuity of medical students and to identify the socio-demographic, financial, and contextual factors associated with educational continuity and cessation. So, to achieve this, we carried out a descriptive cross-sectional study involving 247 medical students from both public and private universities. Participants were selected using disproportionate stratified samplings, and both descriptive and inferential statistical analysis were performed, including multivariate logistic regression to identify independent predictors of educational cessation. Ethical approval was obtained and informed consent was received from all participants. Regarding the results, we found that the conflict had a significant impact on medical education. Among the 247 participants, 21.9% reported interruption of their studies, with the majority being temporary interruptions. Financial constraints were the most commonly reported barriers to continuity, followed by psychological stresses and safety concerns. Despite these challenges, many students found ways to continue their education. The most common approach was transferring to another university, reported by 79.8% of students, while 55.9% continued their studies through online learning modalities. Further analysis using multivariate logistic regression identified several significant predictors of educational continuity. Older age was positively associated with educational continuity, while adequate financial capacity reduced the likelihood of educational cessation. In addition, students attending private universities experienced significantly higher rates of educational interruption than those enrolled in public universities. These findings raises concerns not only about maintaining educational continuity today, but also about retaining the future healthcare workforce. Regarding the conclusion, our findings show that the ongoing conflict poses a serious challenge to the continuity of medical education, particularly for younger students and those experiencing financial constraints. Based on these findings, we recommend expanding financial assistance programs, strengthening mental health support services, and adopting more flexible learning modalities to help students remaining engaged in their education because it is it is a right for them. Nevertheless, overcoming these challenges should not rely on universities alone. Students themselves also have an important role in supporting their colleagues and developing community-based solutions. One example is the AWN initiatives established by students at University of Khartoum Faculty of Medicine. This initiative has helped many students continue their education despite financial hardships. Likewise, the Mass Mental Health Associations that help many students to overcome the psychological problems that they face, and it provides a valuable psychological support throughout the conflict. These initiatives demonstrate how students-led efforts can make a meaningful difference in addressing both financial and mental health challenges. We hope that similar initiatives will be adopted by others universities across Sudan and the world, um, because ensuring the continuity of medical education during times of crisis requires not only institutional commitment but also collaborations and active students' participations. Thank you very much for your time and attention.
Okay, thank you so much for the presentation. We'll have Dr. Adinay and Dr. Tanya for the questions now.
Hi, Musan. I think your research, your research work is really important in places where insecurity or conflicts like this are taking place. So I congratulate you because this is like the first thing I have ever seen, and you gave me a lot of ideas for my country. Okay. The other thing that I wanted to ask you is like you said like those that were enrolled in private universities were those that had the highest interruptions in their medical studies. And also you had another result that was that those that had higher income, for example, they had the less possibility or the lower possibility to interrupt their studies. So I don't know if you made some analysis, integrating these variables. For example, how many students from those 247 participants were from private school and those from governmental school. And obviously, we may think, but that's not like the rule, that those that attend to private school have a higher income, no? So I don't know if you made these differences or this type of analysis.
Okay, well, if I understand you well, you asked that I said private students who are enrolled in private universities has more chance to discontinue their education, despite that they are more has more income. Is this true?
Kind of. That would be kind of. If you had any analysis on, like, if you went further in that analysis.
Okay, well, when we do analysis for this, we found that students who are enrolled in private universities has more chance to discontinue their education. I think one of the reasons is that these students, the universities are found in war areas. So these are one of the factors that make them not continue their study in their universities. Because their universities are located at war zone areas. Okay. Also, another factor that many of these universities are increasing the fees of the students. Even they multiply the fees of the students. So many students are become unable to continue their education because of the financial constraints. Also, we know that the war that happened in Sudan let many families and even those who are providing monies for these students to just they leave their jobs because of the war situations and that. So many of these students are now become without any someone who can provide them with monies to pay it for the universities. So many of them are enforced to discontinue their education, and even they can't now uh, return back to their education.
Okay, thank
So
you
I
very
think
much.
this some of the reasons that make them has more chance to discontinue from the education than those who are enrolled in um, governmental universities.
Okay, thank you very much, Musan.
Oh yeah, thank you very much, Ibrahim, for the presentation. It was a very wonderful presentation. I have a very simple question for you. Please, can you indicate how you arrive at the 247 students? What formula was used? I asked this question for the sake of reproducibility, so that if anyone wants to repeat the study, so that they can be well guided. So how did you arrive at the 247 students? Thank you.
Okay, if I understand, you ask about how we reach those students. Is this the question?
240, how did you arrive at 247? Why not 250? Why did you arrive? How did you arrive at 247? What method did you use to get 247? Do you understand? There are many students in Sudan. So how did you get 247? You get my question?
Okay, well,
Yeah.
can you explain it more, please? Because
Yeah.
I don't understand it.
Yes. Usually, when you want to do a research, there are methods that are used in calculating the sample size. Do you understand? Now, so that
Okay.
when you use that method gives you the number. You get it now. So that's why I'm asking you that. What method was used to arrive at 247 students?
Okay, if I understand, you ask about the method that we use to choose these students. Is this the question?
To arrive at 247, the method used to arrive at 247 students. You get my question? Which method was used? Which formula did you use to get 247?
Okay, the calculations that we are used to reach the number of these students who are enrolled in this research. Is this the question?
Yeah.
Okay, we use the formula that first we know the populations. We calculate the whole numbers of students who are enrolled in these universities. Then we are use a disproportionate stratified samplings. Also, we use a kind of formula. So I can't remember it now. I'm so sorry. Just can search for it. Just wait. It's just that first thing we taking the whole number of students who are enrolled in these universities. Then after that we use a kind of formula. Just now I can't remember its name.
No
To
problem.
calculate the numbers of students. The actual number is not about 254 students. The actual number is about 418 students, but because of the um, inappropriate ways to reach these students, we mainly reach about 215 students from them. And the whole number we reach is about 254 students.
It's okay. All right. It's okay. No problem. Thank you.
Okay, thank you so much,
Okay, thank you.
Mazan. We'll have the QR code displayed on the screen now. And please vote for your favorite presentation. Your votes will help determine the awards, which will be announced tomorrow at the awards ceremony. And I would also like to remind our judges once again to fill the form given to you previously. Okay, so moving on, we have our next presenter, Parvati Sudhahari from Government Medical College, Thiruvananthapuram, Kerala, India. And the topic is Assessment of Psychological Distress in Cancer Patients and its association with quality of life, a cross-sectional study.
Thank you. Is my voice clear?
Yes, you're audible.
Great. Okay. Greetings, everyone. I'm Parvati Sudhahari, a recent medical graduate from Trivandrum Medical College, Kerala, India. Today, I'll be sharing a research work titled Assessment of Psychosocial Distress in Cancer Patients and its Association with Quality of Life. As we all know, cancer is one of the most formidable diagnoses worldwide. Advances in early diagnosis and treatment have significantly improved the cancer survival rates. While this remains as a remarkable achievement, it also brings substantial challenges across multiple domains of life. Psychosocial problems are now considered as one of the most critical yet under-addressed factors influencing the quality of life among cancer patients. This is mainly due to the stigma surrounding the mental health and due to the absence of routine screening in the oncological settings. Based on this background, we conducted a study aimed to identify the following objectives. A primary objective was to determine the prevalence and level of psychosocial distress and to assess its association with quality of life among cancer patients. A secondary objective was to identify the socio-demographic and the disease-related factors associated with distress. Moving on to our methodology, we conducted a cross-sectional study across a period of 6 months among 113 adult patients with histopathologically confirmed malignancies. These patients attended the Department of Radiation Oncology at a tertiary care center. Patients were selected using consecutive sampling, and those who were critically ill and having major psychiatric and neurological disorders were excluded from our study. The sample size was calculated from a similar previous study, assuming 95% confidence interval. Data on socio-demographic and disease-related factors were later collected from the patients and their medical records after obtaining informed patient consent. Psychosocial distress was assessed using the National Comprehensive Cancer Network Distress Thermometer version 2025 with a cutoff score of 4 or above, indicating clinically significant psychosocial distress. Quality of life was measured using the European Organization for Research and Treatment of Cancer Quality of Life Questionnaire Code 30, which is the 30-item questionnaire. Raw scores obtained were then converted using linear transformation to standardize them on a score of 0 to 100 based on the scoring manual. Data was then statistically analyzed using the SPSS software version 25 and using various tests such as chi-square test, logistic regression, and Pearson correlation with a p-value less than 0.05 considered statistically significant. Now, moving on from how we studied to what we found, here are our key results. We found that 63.7% of our study population, that is 72 patients, had a clinically significant psychosocial distress. They had an average distress score of 4.735 with a standard deviation of 2.909. 66% of these clinically distressed patients reported a need for psychosocial support. On analyzing the problem list of a distress thermometer, strong association was found between various variables. They were namely pain and changes in physical abilities among the physical concerns, fear, sadness, anger, feelings of worthlessness among the emotional concerns, prejudice and relationship with family members among the social concerns, self-care and work among the practical concerns, and changes in belief, meaning of life amongst the spiritual concerns. Higher levels of distress were noted among various groups. They were namely younger age group, aged less than 40 years, female patients, unemployed patients, sole breadwinners, those coming from the rural areas, those availing rented vehicles for conveyance, and so on. On analyzing the disease-related factors, we found that cancer stage and treatment modality, particularly those undergoing chemotherapy and surgery, had a significant association with psychosocial distress. Turning to the quality of life outcomes, we found that 46.9% of our study population had severely impaired quality of life, which was scoring less than 40, and only 14.2% demonstrated normal quality of life. Importantly, quality of life and clinically significant distress showed a moderate negative correlation with a correlation coefficient of minus 0.480. This indicated that as distress increases, quality of life decreases correspondingly. We found that 45.1% of our study population has severely impaired global health status. Also, we found that global health status had a strong positive correlation with quality of life, with a correlation coefficient of 0.881, indicating highly significant relationship. On further analysis, we found that all the functional domains of quality of life had a statistically significant association with distress. Similarly, symptom severity also showed a significant association. Further analysis reveals significant interdomain correlation amongst the various study variables. Strong positive correlation was noted between physical functioning and fatigue, role functioning and fatigue, cognitive functioning and pain, social functioning and emotional functioning, fatigue and appetite loss, emotional functioning and global health status, pain and global health status. These highlighted that deterioration in one domain is closely mirrored with deterioration in the other. Moderate correlation were also noticed among different study variables across different domains, and that highlighted the broader impact of symptom burden and financial strain on the overall quality of life of the cancer patients. Our study had some limitations. These were it being a single center study, it has a cross-sectional design, and also due to the lack of specificity regarding the patient age, cancer site to stage, and also the disease trajectory time point. Based on the results we got, we arrived at the following conclusions. Psychosocial distress is highly prevalent among cancer patients, and it is significantly associated with poorer quality of life and impaired global health status. Furthermore, it is shaped by multiple interconnected biopsychosocial factors that highlight the multidimensional nature of suffering. Our study underscores the imperative to integrate routine distress screening across the entire trajectory of the disease so that it will facilitate earlier detection of psychosocial distress and also improved access to comprehensive supportive care. With regard to future research, evaluating the cost effectiveness of such integrations is essential. In expansion of psycho-oncological services in the oncological settings, has a potential to positively influence the treatment outcomes, quality of life, and the overall well-being of our patients. Ultimately, healing cancer is not just about treating the body. It is about restoring the whole person. Thank you and have a great day ahead.
Thank you so much.
Thank
Now
you.
I would like to ask our judge, Dr. Tanya and Dr. Adunay, to ask their questions.
Yes. Yes. Thank you very much for the presentation.
Yes, thank you, sir.
Yeah. My question. I have some questions for you. The first one is this. In your studies, you discovered that people who are aged less than 40, they have a higher distress.
Yes.
Now my question is, why do you think it's like that? Why do you have that kind of result? Then again, in your cancer study, which type of cancer is most predominant when you're doing your cancer study? Which type of cancer is more? Because I see you talking about females having higher. They are also more. They also have a higher distress. So that's why I'm asking that question. That which type of cancer do you think is the most prevalent? Thank you very much.
Thank you for that question, sir. So yes, regarding the younger patients, it could. Well, I have while preparing for this research topic, I have went through a lot of literature too, and from that I understood that the younger patients could be more affected because they are in their stage of developing their careers, and they will be wondering, they'll be worried whether that this cancer might be a roadblock in their career development, and also they want to be self-sufficient. That's the younger age groups, they want to be self-sufficient and all, and this cancer, they might be this cancer disease, the disease might hinder them, it might worry them a lot, and that can cause a distress in them. And also I have also read up a lot of literature saying that older patients, they might have developed resilience because of the accumulated life experiences they had, and also that can help them to face difficulties. That could be one of the reasons why the younger patients showed higher levels of distress. And I hope that answers your question, sir. And regarding the female patients, our study was a single center study, and most of them, yes, we did have equal representation of male and females, but among when we analyzed the type of cancers, most of them were breast cancers. So so that, yes, breast cancer, it can result in a lot of bodily disfigurement, and that can affect their social interactions and all. Maybe that could be one of the reasons why female level of distress. So yeah, I hope that answers your question, sir. It was a really good question. Thank you.
Thank you, Parvati.
Yes, thank you.
It is a very interesting topic. And I think all the oncology clinics must address this topic for each cancer patient. I think cancer per se is like a very demanding, exhausting disease, plus the mental health issues that it turns into at the end of all the outcomes that may be in the treatment. I just have one question. I don't know if you have, as I understand, and in your one of the limitations was that it was just one center. I think it is just only one clinic that was analyzed. I mean, patients were from there. Do you know if in this clinic you have this psychological support, like pain clinics, for example, no, algology, which is like the study for pain and treatment of pain. Do you have this information? And if these patients, the ones that participated in your study, they had the opportunity to have this type of intervention?
Thank you for that question, ma'am. In our home, this study was done in my home institution in the Department of Radiation Oncology, and there it is basically focused on treating the patients by radiology, radiotherapy, chemotherapy, and all. Yes, but we have a central institution nearby named Regional Cancer Center, and they have dedicated departments for pain and palliative, and so do we. So in our home institution also, we have a clinic, a pain clinic in our OP settings, yes, and they also give them the pain medications for supporting these. But the psychosocial, coming to the psychosocial part, it's not well addressed. That is the reason why that's the main rationale why I took up this project too. So this I believe giving a patient a holistic care more than just a cure is the best thing to do, and I think that can be achieved by addressing this psychosocial distress or any kind of psychological support that we can provide. So through this study, what we did is those patients who had a clinically significant distress, where they were actually referred to the appropriate mental health and social support services that were available within our institution. So maybe in future we can conduct a larger study, and maybe we can provide better services and help them a bit more in future. I hope that happens too, because ultimately it's just not just medicine is not just about treating just a disease. It's about treating the overall well-being of the patient. So I hope it happens in the future. Yes. So I hope that.
And also integrate this medical part with the mental part, no? Not only addressing like the one part, no? Like all departments should work together, all the clinics should work together. And maybe patients they don't need to travel to another clinic that is like far away in the city, just in the same place, have the same structure, and everything should be organized just for the patient, no? But I think that's wishful thinking, but hopefully one day it comes true. Okay. Thank you, Parvati.
Thank you, ma'am. Thank you, doctor.
Thank you so much, judges. Thank you, Parvati. It was amazing. So next up, we'll be having the QR code display. Please vote for your favorite presentation. And the results will be announced tomorrow at the end of the session. So we hope to have you all till then. So moving on, next up we have Dr. Sakshi Durga from Our Lady Fatima University, Philippines. The topic is stem cell therapy for post-myocardial infarction, myocardial regeneration. Dr. Sakshi, you can present your screen.
And everyone, I am Dr. Sakshi Durga, and I am graduated for Our Lady of Fatima, Philippines, and now I am currently doing my internship at ASMC Lakhimpur, India. Today I am representing our systemic review and meta-analysis titled Therapeutic Roles of Stem Cell-Based Cardiac Regeneration After Myocardial Infarction. So, now talking about the background. A myocardial infarction remains one of the leading causes of mortality and heart failure worldwide. Although current treatments such as primary PCI, medical therapy restores coronary blood flow, they cannot replace the cardiomyocytes that are permanently lost after infarction. As a result, scar tissue forms, leading to ventricular remodeling, reduced cardiac function, and eventually heart failure. Stem cell therapy has emerged as a promising regenerative strategy because it has the potential to promote angiogenesis, reduce fibrosis, and improve myocardial repair. Aim of this study is to evaluate whether stem cell therapy improves cardiac function and myocardial regeneration after myocardial infarction by systemic reviewing and combining the available clinical evidences. Now we will talk about the method. Uh, we conducted a systemic review and meta-analysis following the PRISMA 2020 guidelines, which ensures a transparent, standardized review process. We searched for basic major databases, that is PubMed, Scopus, Embase, and Cochrane Library. These search included studies published from January 2016 to March 2026. Our PICO framework that includes population, intervention, comparison, and outcomes. Population we include adult patients with myocardial infarction. Intervention is stem cell based therapy. Comparison is placebo or standard medical therapy. Outcome is improvement in left ventricular ejection fraction, that is LEVF, scar reduction, myocardial perfusion, angiogenesis, ventricular remodeling, and safety. We included randomized control trials and eligible observational studies. Animal studies, laboratory studies, review articles, editorials, and duplicate publications were excluded. Finally, 16 randomized clinical trials met the eligibility criteria and were included in the quantitative analysis. Because the study differed in stem cell type, doses, delivery route, and follow-up duration, we use a random effect model and heterogeneity was assessed using the I-square statistics. Now we will talk about the results. The most important part of this study is that our review included 16 randomized clinical trials involving 1641 patients. The pooled analysis demonstrated a significant improvement in LEVF with an average increase of 2.55% compared with the conventional therapy. We also observed an average 7.8% reduction in infarct scar size, indicating better myocardial healing. Several studies consistently demonstrated improved myocardial perfusion and enhances angiogenesis, supporting the regenerative potential of stem cell therapy. When different stem cell types were compared, mesenchymal stem cells showed better improvement in ventricular remodeling and functional recovery than bone marrow mononuclear cells. Importantly, no statistically significant increase in mortality or any major arrhythmias were observed, suggesting that stem cell therapy has a favorable safety outcome. Overall, these findings indicate that stem cell therapy can improve cardiac repair after myocardial infarction. Now come to the conclusion. In conclusion, stem cell therapy demonstrates promising potential as an adjunctive regenerative treatment after myocardial regeneration. It improves ventricular function, reduces infarct size, enhances myocardial perfusion, and supports favorable ventricular remodeling. But still, there are many limitations that are still exist. That is, there was moderate heterogeneity among the included studies due to difference in stem cell type. As I already explained, different delivery methods, dosages, and follow-up durations. Therefore, large multiple randomized control trials with standardized treatment protocols and long-term follow-up are still required before stem cell therapy becomes part of routine clinical practices. In future, advances in tissue engineering, biometrics, and gene editing technologies may further improve the effectiveness of regenerative therapy. Thank you very much for the attention. I would be happy to answer any question now.
Okay, thank you. I would like to request Dr. Maxine and Dr. Avi to ask any questions if they have.
Okay, thank you very much, Dr. Durga. I'm sorry if I'm pronouncing your name. Durga. Thank you very much. It's a very interesting area. Unfortunately, we did not have the benefit of seeing all your slides. We only saw the first one. So we didn't see the outputs in terms of the different graphs, but that's fine. I think for me, my concern was the fact that you were using studies that had different measures of cardiac function. And I wondered how that may have impacted your conclusion. I mean, I see where you did mention about the variances in terms of dosing, types of stem cells, but
Yes, ma'am.
in terms of your conclusion, your definition of improved cardiac function seemed to have been very different.
Yes, ma'am. Actually, there is a mesenchymal stem cell. That's what you are talking about, right?
No, I was talking about how did you define improved cardiac function? I heard
Ejection
left
fraction.
ventricular
Yes.
fraction, but then you had other ways of measuring it. So you're putting studies together that had different measures of your outcome, and I was a little concerned about using, those different measures.
Ma'am, basically we use different studies, and the basic result I found that there is a much reduction in the LVEF, that is 2.55% as compared with the conventional therapy, and also there is a 7.8% reduction in FARC scar size also. So we choose basically mesenchymal cells because it you can say that have stronger immunomodulatory and paracrine signaling effect on that, promoting angiogenesis, reducing fibrosis, and supporting the tissue repair more effectively.
All right, thank you very much. I'll hand over to Dr. Singh.
Okay, so for the next one, we have Ayla Bajwa from FMH College of Medicine and Dentistry, Lahore, Pakistan. We have a pre-recorded video which will be playing.
Ayla Bajwa, a third-year medical student at FMH College of Medicine and Dentistry in Lahore, Pakistan. Today, I will be presenting our systematic review and meta-analysis comparing the efficacy of palinositron monotherapy versus ondansetron dexamethasone combination of prevention of post-operative nausea and vomiting. To begin with some background, post and distressing complications following surgery. It affects up to 80% of high-risk patients and its consequences extend well beyond discomfort. It delays recovery, prolongs hospital stays, and significantly increases healthcare costs. For years, the standard prophylactic approach has combined two drugs, ondansetron and dexamethasone. Ondansetron blocks the serotonin receptors responsible for triggering the nausea signal, while dexamethasone, a corticosteroid, targets nausea through an entirely different pathway. This multimodal approach covering two mechanisms became the established standard of care. However, palinositron, a second-generation serotonin receptor antagonist, operates quite differently. Its plasma half-life is approximately 40 hours compared to ondansetron's 4 hours. It binds to receptors far more powerfully through a mechanism called allosteric binding and uniquely triggers receptor internalization, essentially pulling receptors inside the cell so serotonin has no surface target to attach to. Given these pharmacological advantages, the central question our study addressed was, is palinositron as a single agent usually superior to this well-established two-drug combination? That is precisely what this systematic review and meta-analysis set out to determine. Moving on to our methodology. This study is a systematic review and meta-analysis, meaning rather than collecting our own patient data, we systematically identified and pooled results from all existing studies comparing these two treatments directly. The study was conducted in full accordance with PRISMA 2020 guidelines, the internationally recognized standard for reporting systematic reviews. Prior to commencing data collection, the study was prospectively registered on Prospero, the International Registry for Systematic Reviews, under registration number the following. This pre-registration ensures complete transparency and prevents selective reporting of outcomes. Our comprehensive search covered three major electronic databases: PubMed, Scopus, and Cochrane Central Register. From inception through June 2025, as illustrated in the Prisma flow diagram, the search initially identified 95 records. Following removal of 59 duplicates, 36 unique articles remained for screening. After full text review of 20 articles and application of our eligibility criteria, which required randomized controlled trials in adult patients aged 18 or older, directly comparing these two treatments, 4 studies were ultimately included. These were Fonseca 2020 from Brazil, examining laparoscopic cholecystectomy; Day 2021 from India, examining laparoscopic gynecological surgery; Krishnan 2024 from India, examining laparoscopic surgery; and Singh 2024 from India, examining caesarean sections under spinal anesthesia, comprising 304 patients in total. Turning to the risk of bias assessment, all 4 included studies were double-blind randomized controlled trials rated as low to some concerns risk overall, confirming the methodological quality of the included evidence is high. Now to our findings. Before going through the results, it is worth briefly explaining how to read a forest plot for context. Each square represents an individual study's result. The horizontal line through each square is at its confidence interval. The diamond at the bottom represents the pooled combined result across all studies. When the diamond sits to the left of the central line, that indicates palinositron outperformed the combination, starting with our primary outcome PONV incidence within 24 hours, as seen in figure 5. Every individual study square sits to the left of the center line, and pooled diamond sits clearly to the left as well. The odds ratio was 0.22 with a 95% confidence interval of 0.11 to 0.45 and a p-value of less than 0.0001. In practical terms, palinositron patients had 78% lower odds of experiencing PONV, translating to a PONV rate of just 8% versus 28% in the combination group. Notably, the I-squared value was 0%, reflecting perfect consistency across all 4 studies regardless of surgical setting or country. Turning to figure 7. Rescue antiemetic requirements within 24 hours. The diamond again sits clearly to the left. Odds ratio 0.11, confidence interval 0.03 to 0.39, p-value 0.0006. Palinositron patients were 89% likely to require rescue medication, only 4% versus 29% in the combination group. This is clinically remarkable difference. Regarding the 12-hour outcome, the confidence interval just crosses the center line with a p-value of 0.05, falling just short of statistical significance, this is likely attributable to only 2 studies reporting this time point, limiting statistical power. Finally, for 24 to 48-hour outcome, the diamond sits directly on the center line with an odds ratio of 1.01 and p-value of 0.99, indicating no meaningful difference between treatments at this time point. By 24 to 48 hours post-surgery, the primary emetogenic stimulus from anesthesia has substantially diminished, explaining the absence of effect. To summarize and contextualize these findings, polyneuropathy as a single agent demonstrated clear superiority over two-drug ondansetron-dexamethasone combination in preventing PONV within 24 hours and in reducing rescue antiemetic requirements. These were not marginal findings. The results were statistically high, significant, and clinically very meaningful. The pharmacological rationale is well established. Polyneuropathy's allosteric binding and mechanism receptor internalization provide a more and complete and sustained serotonin receptor blockade than ondansetron's competitive inhibition. Even when ondansetron is paired with dexamethasone, its 40-hour half-life further sustains this protection through critical early operative period. From a clinical perspective, these findings carry important implications. A single-agent approach reduces medication burden, minimizes drug interaction risks, and eliminates corticosteroid-related adverse effects, particularly relevant in diabetic patients where dexamethasone-induced hyperglycemia is a concern. Acknowledged limitations include the small number of eligible trials, variation in dexamethasone dosing across studies ranging from 4 to 8 milligrams, and then inability to formally assess publications bias, given fewer than 10 included studies. In conclusion, polyneuropathy represents a superior, well-tolerated, and clinical practical first-line prophylactic option for PONV, particularly in high-risk patients undergoing laparoscopic or obstetric procedures. Larger randomized trials with standardized protocols and formal cost-effectiveness analyses are warranted to consolidate these findings. Thank you for your attention.
Okay, I would like to ask our judges, Dr. Maxine and Dr. Abhinay, to share any views on this study or any
Thank you very
questions.
much. Okay, thank you very much for the presentation. It was great. I commend you for doing this kind of study, looking at how to mitigate, the adversity associated with cortisol, the adverse effect and all that. Very fine. My concern is that number one, when you were recruiting your studies, it's like you omitted Web of Science. You did not recruit studies, through Web of Science. I saw PubMed, I saw Scopus. I'm not sure I saw anything like Web of Science. So I want to ask why. Why didn't you opt studies from the Web of Science? That's my question.
Okay, I've noted it down, and I'll be conveying it to the presenter as the presenter is not here at the moment.
Oh, I didn't realize that the presenter left.
No, it was
Okay, I'm
pre-recorded.
sorry. My question.
It was a bad network. Maybe network was not strong.
Oh, I see.
Yes.
Okay. All right. Oh, I'm so sad. It's in an area that I teach, and I would have been loved to have had the opportunity to engage with her. But so my question to her, well, we would expect the newer generation drug to have some advantage over the older one, and yes, the half-life is longer, so yes, the duration of the drug is better. I think for me, what I would have wanted to ask her, it's about the dexamethasone. There is a rationale for using the dexamethasone along with ondansetron. And in this case, she mentioned adverse effects. Now, patients are only getting this over a short term, so I would have liked her to kind of articulate the adverse effects, since she's highlighting that it's really because of dexamethasone why she would want to recommend this management. And I suspect that this newer drug is going to be more expensive, and coming from a low-income country, you're actually increasing the financial bill. So my question to her really relates to how significant are these adverse effects that are, or potential adverse effects of dexamethasone are for her to want to move to this new agent. Thank you.
Okay, thank you so much for your questions. Okay, we'll be displaying the QR code now. Please scan it and vote for your favorite presentation. And we hope to have you by the end of till the end of tomorrow's day, so as to tell the names of the award winners. Okay, moving ahead, we have Norman El-Badri Ibrahim from University of Khartoum, Sudan. And the topic is reproductive health literacy among married women of reproductive age, a cross-sectional study in rural White Nile State, Sudan.
I'm Nermi El-Badri Ibrahim. I'm a PhD medical student at University of Khartoum. On behalf of my co-authors, I would like to thank you for the opportunity to present our study titled Reproductive Health Literacy Among Married Women of Reproductive Age, a cross-sectional study in rural White Nile State, Sudan. To start with some background, reproductive health literacy is a crucial determinant of women's ability to make informed decisions regarding reproductive health. In rural Sudan, limited access to reliable health information may contribute to low levels of reproductive health literacy, yet evidence from this context remains limited and insufficient. This gap motivated us to conduct our study, which aimed to assess reproductive health literacy among married women of reproductive age and to determine the factors associated with a good level of reproductive health literacy. So, to address this aim, we conducted an analytical cross-sectional study among 310 married women aged 15 to 49 years old in rural White Nile State in March 2026. Participants were recruited by using convenient sampling. Data were collected using a structured pre-tested interviewer-administered questionnaire with two domain sections. The first captures socio-demographics characteristics including age, education, employment, income, and number of births, and the source of reproductive health information. The second assesses menstrual health knowledge, general reproductive health practices, including antenatal care and postpartum danger signs and cervical cancer awareness. Responses were scored as 1 for the correct answer and 0 for the incorrect or I don't know, giving a total score ranging from 0 to 18. Participants were then categorized into poor, moderate, and good literacy levels based on Bloom's taxonomy cutoffs. For the analysis, we used SPSS version 21 descriptive statistics, summarize the sample by varied analysis, including Pearson correlations for age, independent t-test for parity, and one-way ANOVA for education, income, and employment. Finally, multiple linear regression was performed to identify the independent predictors for reproductive health literacy while controlling for confounders. Moving now to our results as shown in Figure 1. Reproductive health literacy was predominantly moderate, accounting for 41.9% of participants. Only 31.6% of participants had a good literacy, while 26.5% had low literacy or poor literacy. Then going to Figure 2, show domain-specific scores in Figure 2. Participants achieved highest score in menstrual health with median 4 out of 4, followed by general reproductive health practice with median 7 out of 8. In contrast, cervical cancer was the lowest with a median of only 1 out of 6, is highlighting an important knowledge gap. Finally, moving to Figure 3, which shows the significant predictors of reproductive health literacy: high income, moderate income, employment, consulting doctor or nurse, using of social media as a source of as the primary source of health information, were all independently associated with a better reproductive health literacy score. In contrast, reliance on midwife was negatively associated with the literacy score. Then going to discussion, literacy was predominantly moderate, with cervical cancer awareness being the weakest domain. Socioeconomic factors such as income, employment, age, alongside health information source were independent predictors. Midwife reliance was linked to lower scores, reflecting gaps in community level health communication. Then, to conclusion, we need targeted interventions, expanding access to qualified healthcare professionals, and reliable information channels, particularly for low income and unemployed women. Thank you for your attention.
Hello, Norman. Thank you for your presentation. So we'll be having our judges, Dr. Maxine and Dr. Adinei, for asking any questions if they have.
Thank you very much
Thank you for
for
your
the presentation.
presentation. My question to you is related to your definition of reproductive health literacy. I didn't see that on the slide, so if you could just tell me what's the definition you are using for that. I'm not hearing anything.
Norman, we cannot hear you.
Maybe we have lost her. Probably type it in the chat too.
Okay. Norman, if
Are
you
you
can
hearing me,
hear.
Miss Ayali?
Yes, I can hear you. Okay, Norman is gone. Okay, I'll just note down the questions.
It's gone now.
Yeah, yes, I wanted to ask why the focus on the cervical cancer awareness. Why not breast cancer? Why not ovarian cancer? Why her choice for cervical cancer? That's what I wanted to ask before. Thank you.
Hello. I have some technical issues. I can't hear you. Can you repeat your questions?
Okay, yeah, I said that. Why did you limit yourself to why the choice of cervical cancer awareness? Why not
In the
ovarian cancer? Why
chat.
not breast cancer awareness? Do you understand?
Yeah, yes. You asked why I chose cervical cancer awareness.
Yeah.
Yeah. Cervical cancer awareness I noticed in some rural population, Sudanese rural population, um, cervical cancer programs and human papillomavirus vaccinations and also screening services was limited, and also the informations, the accessibility of accurate information for the rural population also was limited and not accurate. Yes, you understand me? So I want to measure to assess the level of awareness, and as our result found that is was a very low, indicating an important knowledge gap.
Okay, Norman, there is one more question in the chat box. What is the definition of reproductive health literacy? Were you able to hear me?
What?
Okay, I think there is a serious network issue. So we can move ahead. Let us display the QR code. Please scan the QR code and vote for your favorite presentation. And I would also like to remind our judges to fill the form that was given to you previously. The results will be announced tomorrow in the award ceremony, so we hope to have you all till then. Okay, next up we have Kanashka Verma from Sri Guru Ramdas Institute of Medical Sciences and Research, Punjab, India. The topic is mind wandering and attentional control as behavioral markers of frontoparietal network inefficiency, a questionnaire-based study among medical trainees. Kanashka, you can go ahead.
Hi, greetings everybody. My name is Kanashka Verma. I'm currently a second year MBBS student at Sri Guru Ramdas Institute of Medical Sciences and Research, Punjab, India. The title of my study is Mind Wandering and Attention Control as Behavioral Markers of Frontoparietal Network Inefficiency, a questionnaire-based study among medical trainees. So let me just give you a brief background about it. Our brain has two main networks. Number one, DMN, the default mode network, and number two, FPN, frontoparietal attention control network. The DMN is responsible for internally directed thoughts like mind wandering. However, the FPN is responsible for attention regulation and goal-directed behavior. The disruption of balance between these two leads to cognitive errors and reduced task performance. Our study focuses around a special cohort of population, that is medical trainees, who are more susceptible to cognitive failures. Now the question arises, why? Why? Because of extensive multitasking, high cognitive load, and a continuous demand to keep on learning. So our study focuses to determine the association between mind wandering and cognitive failures, to determine the relationship between mind wandering, attention control, and cognitive failure, and to assess attention control as a mediator between mind wandering and cognitive failures. We also wanted to study all these three parameters with reference to gender and years of medical training. So for that purpose, a cross-sectional questionnaire-based study was designed, keeping a sample size of 200. We made sure that we take 50 participants from all the 4 profs so that the proportion and the ratio remains the same. 3 questionnaires were used, as you can see on your screens: mind wandering questionnaire, attention control scale, and cognitive failure questionnaires. These questionnaires were distributed amongst the participants and the responses were collected. Now, as we move towards the analysis, you can see on your screen the first figure, the comparison of mind wandering, attention control, and cognitive failures on the basis of gender. When we found out that mind wandering was higher in females, attention control was higher in males, but cognitive failure was higher in males. All these 3 values are statistically significant as the p-value is less than 0.05. Now, when we compared all these 3 values in reference to the years of medical training, you can see that mind wandering and attention control increased as the years of training progressed. Now, if you can look towards the right side on the scatter plot, mind wandering was taken on the x-axis, attention control on the y-axis. A linear regression is seen with a negative slope. Now, each of that circle represents an entity, and the size reaching a maximum limit of 60, the size of the circle and the intensity of the color, both is directly proportional to cognitive failures. So if we can focus on the area of the higher density, and if we draw the mean, we would find out that high values of mind wandering correspond to low values of attention control that further corresponds to high values of cognitive failure. So with this scatter plot, we have justified one of our objectives, which was to determine the relationship between these 3 parameters. Now, when I talk about the mediation analysis, that was done using Barron's and Kenny's approach. If you can look at this figure, taking mind wandering on x-axis and attention control on y-axis, a 1 unit increase in mind wandering corresponded to 0.68 unit decrease in attention control, negative slope. Taking attention control on x-axis and cognitive failures on y-axis, a unit increase in attention control decreased cognitive failure by 0.38 units. Taking mind-wandering on x-axis and cognitive failures on y-axis, a unit increase in mind-wandering led to 0.92 unit increase in cognitive failure. But when we mediated this pathway via the attention control, a unit increase in mind-wandering corresponded to 0.66 unit increase in cognitive failure. So via this, we prove that yes, attention control mediates mind-wandering and cognitive failure, but it is just a partial mediation. So in conclusion, I would like to say that mind-wandering increased significantly across the years of the study and was higher in females, while attention control showed a declining trend, and cognitive failure increased with academic progression. Furthermore, attention control partially mediated the relationship between mind-wandering and cognitive failures, indicating that reduced attention control may be a key mechanism through which mind-wandering contributes to cognitive failures. Thank you.
Thank you so much, Kanishka. I would request Dr. Nazir and Dr. Adinay to ask any questions that they have.
Okay, thank you very much, Dr. Verma. This is very interesting. And I'll just say that, we're training these people to be medical doctors. And you're telling me that the more they're into the training is the less cognitive strength they have. That sounds like a very flawed study. So I just want your opinion. It sounds like your data is very flawed. If a year 4 student has cognitive decline.
Yes,
your
doctor.
opinion. I'm saying that I think your data is flawed. It just doesn't sound right. I mean, the students will be weeded out from their GPA. And I have a medical student, year 4, that I'm putting out there soon, and they are in a worse state of concentrating on what they have to do than a year 1 student.
So yes, this was actually a surprising result for us as well. We anticipated that, okay, these values would be higher in the first years or the second years because, you're coming on from high school, you think that it's going to be chill, med school is not that tough. But surprisingly, to our surprise as well, these values were higher as the years progressed. So that is what brings me to the thing that we propose via the study is that something that lacks in our medical education today is we focus on the academics part, but the clinical skills is something that are not being taken care properly. So via the study, we propose that mindful sessions should be taking place. There should be sessions that focus the students to work on their clinical skills. The pressure should be decreased, and as you rightly mentioned, as the year progresses, as the cognitive load increases, the exam pressure increases, and all those factors contribute to that. But becoming to our role into that is something that we should make sure that there are some activities put forth in front of them that can put them aside from the academics and that can really help them focus on their focusing skills and attention span and how they can cognitively be present at a situation rather than just being physically there. So yeah, that's my take on it.
Thank you.
Thank you.
Okay. Can you hear me? Yeah. Thank you very much for the presentation.
Doctor, I cannot hear
Very
you properly. You're not audible.
Can you hear me now? Can you hear me now? Hello?
Should I rejoin?
I said, yeah. Can you hear me?
Just give me a second, I'll rejoin.
Okay.
Hello.
Yeah, Vama, yeah, welcome back. Can you hear me now?
Yes, I can hear you now.
Very good. Oh, thank you very much for that presentation. It was awesome.
Thank you,
But I
doctor.
don't know where you were doing your study. Did you put into consideration time of the day? Because mind wandering, cognitive failure, you know, attention control, all these parameters of they decrease across the daytime. They are related to fatigue. So my question is, did you put it into consideration time of the day when you were collecting this parameter using questionnaire? Did you put into consideration time of the day? Did you collect all of them at the same time in the day?
Yes, doctor. We
You get my
used.
question?
Yeah, I got your question. You're asking me if all those
Yeah,
three questionnaires were collected at the same time,
yeah, yeah,
right?
yeah.
Yeah, we
Yes.
did collect that at the same time. The standardized questionnaires, one after
Okay.
another, they were put in front of the candidates, the participants, and they were recovered from them once they submitted them.
So that's fine. Then again, we just advise that in your future study, you can think of doing objective, studies, maybe like EEG or review, to have more objective, measurement. Thank you very much.
Yes, doctor. The thing was that we did this study so that it serves as a groundwork. There are
Yeah,
parameters like stress, rumination, exhaustion, and fMRI, like you mentioned. So
yeah,
we really
yeah.
want that study. This should serve as a ground force, and studies should be conducted so that we can put forth some conclusive data out of this, so that it
Thank
serves
you.
a fruitful purpose. Thank you.
Yeah, thank you.
Okay, thank you so much, judges. Thank you so much, Kanashkar. It was wonderful. So we'll be having the QR code displayed on the screen. Please scan it and vote for your favorite presentation. Your votes will help determine the awards which will be announced at the award ceremony tomorrow. Hello everyone, welcome back. So we'll be resuming with our next presentation. We have Aditi Balan from ACS Medical College and Hospital, Chennai, India. And the topic is Precision Medicine Approaches in Alzheimer's Disease, Clinical Perspective on ALZ-801. We have a pre-recorded video.
Good day, respected judges, faculty members, and fellow delegates. I am Aditi Balan from ACS Medical College and Hospital, Chennai, and today I will be presenting our systematic review and meta-analysis titled Precision Medicine Approaches in Alzheimer's Disease with ALZ-801. Alzheimer's disease currently affects around 55 million people worldwide, with nearly 10 million new cases every year, making it one of the leading causes of disability among older adults. One of the strongest genetic risk factors is the APOE epsilon 4 allele, which not only increases the likelihood of developing Alzheimer's disease, but it also accelerates disease progression. Although monoclonal antibodies such as lenatumab and donanemab have shown their promise, their use is limited by adverse effects like amyloid-related imaging abnormalities, particularly in cerebral edema and especially in APOE3/4 carriers. This has created a need for safer, more targeted therapies. ALZ-801, an oral amyloid beta oligomer inhibitor, represents a precision medicine approach by targeting the toxic soluble oligomers responsible for neuronal injury while avoiding many of the complications associated with antibody therapies. Our review evaluates the efficacy and safety of this emerging treatment. To better understand the role of ALZ-801, we conducted a PRISMA-guided systematic review of randomized controlled trials available in PubMed from database until March 2026. Our objective was to evaluate cognitive outcomes, functional performance, neuroimaging findings, biomarker changes, and overall safety, with particular emphasis on patients carrying the APO34 genotype. We specifically included randomized clinical trials involving patients with mild cognitive impairment or early Alzheimer's disease who received ALZ-801. Primary outcomes included changes in ADAS-Cog13, clinical dementia rating, sum of boxes, disability assessment for dementia, hippocampal volume, plasma biomarkers such as PETA-181, and the occurrences of ARIA. Studies involving animal models,
Duplicate publications and non-clinical data were excluded. Risk of bias was assessed during the Cochrane ROB2 tool, while findings were synthesized qualitatively with particular focus on the phase 2 and phase 3 APOLLOE4 trials, which currently provide the strongest clinical evidence for ALZ-801. Our review demonstrated several clinically meaningful findings. First, ALC-801 produced an approximately a 31% reduction in plasma beta-181, a biomarker which is strongly associated with Alzheimer's disease progression. Secondly, patients receiving ALZ-801 experienced around 28% less hippocampal atrophy compared with matched external controls, suggesting slower neurodegeneration. Perhaps the most striking observation was its safety profile. Across the included studies, no cases of ARIA-E or amyloid-related cerebral edema were reported. This is particularly significant because currently approved monoclonal antibodies have reported ARIA-E rates of approximately 21 to 36% of APOE34 homozygous patients. When cognitive outcomes were examined, the greatest clinical benefit was observed in patients with mild cognitive impairment, where slower decline in CDR-SB scores suggested that earlier intervention may preserve neurological function more effectively than treatment initiated after dementia has developed. Taken together, these findings indicate that ALZ-801 may not simply improve symptoms, but may also modify underlying disease biology while maintaining a considerably safety profile. Our findings support three important conclusions. First, sustained reductions in plasma beta-181 together with the preservation of hippocampal volume suggest that ALZ-801 may have genuine disease-modifying potential rather than merely symptomatic effects. Second, its safety profile distinguishes it from currently available anti-amyloid antibodies. Third, treatment response appears to be both genotype dependent and stage dependent. So in the second one, the complete absence of ARIA-E in the reviewed trials is particularly relevant for APO34 carriers who are considered the highest risk group for treatment-related complications. Although the overall phase 3 trial did not reach statistical significance for its primary endpoint, the pre-specified subgroup of patients with mild cognitive impairment demonstrated meaningful cognitive, functional, and neuroimaging benefits. This suggests that earlier intervention before irreversible neuronal loss may be the optimal therapeutic window. In conclusion, ALZ-801 represents one of the first truly precision medicine approaches in Alzheimer's disease. By combining genotype-guided patient selection with an oral therapy targeting toxic amyloid beta oligomers, it offers the possibility of effective disease modification while avoiding the safety limitations associated with intravenous antibody therapies. Future studies should therefore focus on enriching phase 3 trials with patients in the mild cognitive impairment stage, integrating routine APO34 genotyping into clinical practice, and exploring biomarker guided treatment strategies. Thank you for your attention.
Okay, thank you. So we have our judges, Dr. Tanya and Dr. Hiba. Would you share your views so that I will note it down and share it with the presenter, as this was a pre-recorded video?
Hi. Well, I find your work very interesting in terms of the safety of the use of this molecule. In fact, one of the things that has made very difficult the treatment for Alzheimer has been the use of monoclonal antibodies, which is like very important to address, first of all, the side effects. But now, as I know, you're going to give the student my questions. Yes? I understood that part? Okay. So, sorry, my internet connection is kind of weak. So, well, the first one is, which I usually have encountered personally and in my scientific field, is to find out or to detect those patients that are like at the beginning of the disease, like early and mild cognitive, let's say, this dysfunction. So I think that the main target will be those that are like in this stage, as you said, but the challenge will be finding them. No, because usually we find out that our patient or our relative, mother or father, or I don't know, an uncle or some part of our family have Alzheimer, or they are developing Alzheimer because they have this late diagnosis. So you should be aware that maybe to use them in this type of patients that are like at the beginning of the disease is like the challenge to find them and then um, to design a clinical trial for them, especially in this stage. That's what I think it is going to be the challenge for this molecule, as you have already said in your presentation. Thank you very much.
Thank you so much, Dr. Tanya. Dr. Hiba, do you have any question?
Hello. So, first of all, the presentation looks very interesting, and the topic is really interesting, especially now that we have so much of papers ongoing with the precision medicine and Alzheimer's disease and so on. So, the most important thing in this paper is it is very important that we can detect Alzheimer's disease even before, like the actual symptoms start to happen. And I would like to know, I would like to ask about the limitations that actually can encounter such a study, or mainly in these patients, because to collect this kind of data is really hard, especially for the patients who are not very well developing the symptoms at the beginning. So I would like to know the actual limitations that they encounter in this kind of studies, like what were they, and how they can overpass, like in the future, what they can do in order to like what kind other of monoclonal antibodies, for example, they can detect other than this one in the patient with symptomatic Alzheimer's disease or pre-stage of Alzheimer.
Okay, I've noted it down. I will convey this to the presenter. Thank you so much for your question.
All
And
right.
we'll move ahead to the next presenter. Before that, we can have the QR code displayed. Please vote for your favorite presentation. And we hope to have you all with us till the end of tomorrow. Okay, so moving on, the next presenter we have Anushka Bansal, also from ACS Medical College, Chennai, India. The topic is efficacy of gefitinib combined with methotrexate in the medical management of ectopic pregnancy. This is a pre-recorded video as well.
Greetings, respected judges, moderators, and fellow delegates. I'm Anushka Bansal, and today I'm presenting a systematic review and meta-analysis entitled Efficacy of Gefitinib combined with methotrexate in the medical management of ectopic pregnancy. This work was conducted by Anushka and myself from ACS Medical College and Hospital, Chennai, India. Ectopic pregnancy remains one of the leading causes of first trimester maternal morbidity. While methotrexate is the standard medical treatment, treatment failure and the subsequent need for surgery continue to be significant challenges. This prompted us to evaluate whether adding gefitinib could improve treatment outcomes or not. The objective of our review was to systematically evaluate the efficacy and safety of combining gefitinib with methotrexate in the medical management of ectopic pregnancy. We conducted a PRISMA-guided systematic review of PubMed indexed literature from database inception until March 2026. 16 studies met our inclusion criteria for qualitative synthesis and 11 contained sufficient data for quantitative meta-analysis. The primary outcome included treatment success, decline in beta-HCG levels, time to clinical resolution, fertility preservation, and adverse events. Mechanistically, methotrexate inhibits DNA synthesis leading to trophoblastic destruction. Gefitinib, an epidermal growth factor receptor inhibitor, enhances trophoblastic apoptosis. Together, these complementary mechanisms promote a faster decline in beta HCG and improve medical resolution of ectopic pregnancy. Our analysis demonstrated several clinically meaningful benefits of combination therapy. First, the pooled treatment success rate was 78.6%, indicating successful resolution without surgery in most stable tuber ectopic pregnancies. Patients receiving gefitinib also showed a significantly faster decline in beta HCG levels, reflecting more rapid trophoblastic regression. In addition, the median time to resolution was reduced from 28 days with methotrexate alone to 18 days with combination therapy, representing a reduction of approximately 10 days. Another important finding was the reduced need for surgery. Surgical interventions decreased from 28.7% with methotrexate alone to 11.4% with gefitinib was added. Regarding safety, the most frequently reported adverse effects were acneiform rash and diarrhea. These events were generally mild and transient, while serious events were uncommon, occurring in only about 1.2% of patients. Overall, these findings suggest that gefitinib may enhance treatment efficacy while maintaining an acceptable safety profile. Our findings indicate that gefitinib represents a promising adjunct to methotrexate for the medical management of ectopic pregnancy. Across the included studies, combination therapy consistently demonstrated higher treatment success, fast beta HCG decline, short time to resolution, and a reduced need for surgical intervention. Favorable fertility preservation outcomes were also reported in selected non-tubal ectopic pregnancies. However, it is important to note that the current evidence remains limited by relatively small study populations and the availability of only a few high quality randomized controlled trials. Therefore, although the results are encouraging, larger prospective multi-center studies are needed before this approach can be routinely incorporated into clinical guidelines. In conclusion, gefitinib combined with methotrexate has the potential to improve medical management of ectopic pregnancy by increasing treatment success, accelerating recovery, and reducing surgical intervention while maintaining an acceptable safety profile.
Okay, thank you. So we have our judges, Dr. Hiba and Dr. Tanya. If you have any comments or any questions on this study, you can let me know.
Well, thank you very much for the video. I think this is a very good alternative for the treatment of this gynecological process. But I just have one question, which will be like the 1% that had serious side effects. Which were those side effects? Like death, for example, which is really serious, or like something neurological, or which I would like to know which were the serious effects, even though it is a very small chance to have them. If they are serious, they place like a safety use of this combined treatment. So maybe, as you already have said, larger studies with larger follow-up periods of time may be useful to address some of the side effects that may be encountered in the future after this type of treatment. Thank you very much.
Thank you so much, Dr. Tanya, for the question. Dr. Heba, do you have any question or any comments?
Well, hello. Basically, I do not have a question. I just want to give my opinion regarding the video as well, regarding the topic. The topic is really important and really serious, especially that I've treated as well one of the cases that was ectopic pregnancy, and it is a severe situation. So knowing that we have an combined therapy that actually can be very effective, especially in preserving next with the next pregnancy and preserving fertility, because when we have ectopic pregnancy once, we can have repetitively as well, it can affect the fertility. So knowing this is really important, and is really important for the woman health in the future. It gives a really big, how to say it, hope for the woman who had already this kind of situation before. And yes, the topic was fascinating and the video was really amazing. Thank you.
Thank you so much. So we'll be displaying the QR code, and I request all of you to vote for your favorite presentation. I would also like to remind our judges to fill the form which was given previously. Okay, next up we have Dr. Nuha Khalifa, who is a medical doctor graduated from University of Medical Sciences and Technology. The topic is epidemiological profile of patients with gynecological cancers in Rwanda Military Teaching Hospital.
Hello everyone, I'm Dr. Nuha Khalifa, presenting research conducted with Dr. Bertin Sitini at Rwanda Military Teaching Hospital on epidemiological profile of patients with gynecological cancers in Rwanda. So as a background, gynecological cancer account for 15.7% of female cancer-related death worldwide, with Eastern Africa faces the highest prevalence. Also, Eastern Africa faces a projected 172% increase in mortality by 2050. In Rwanda, cervical cancer is known to be prevalent, but the full comprehensive data on the full spectrum of gynecological cancers remain limited, which limit the policy making and treatment in the country. For our study aim, we aim to determine the disease frequency, staging, and operational treatment delay. Also, we did a multivariable study to see what can predict our advanced stage presentation. So regarding our study, we did a retrospective census study. We did a descriptive and analytical analysis in which we reviewed all patients with confirmed gynecological cancer in Rwanda Military Teaching Hospital or referred to the hospital with confirmed diagnosis, in which we found a total of 504 patients. We did this study between January 2023 and December 2024. Our hospital is Rwanda Military Teaching Hospital, is a specialized 400-bed facility in Kigali. It is the only hospital providing radiotherapy in Rwanda and one of the 3 hospitals providing chemotherapy. And one of the studies found that 78% of patients with cervical cancer were treated in Rwanda Military Teaching Hospital. We did a descriptive analysis, and we did a multivariable linguistic regression to find the independent predictor of advanced staging. We did the P of less than 0.05. So we found 4 key results. First, the distribution by location. We found that 80% of patients were presented with cervical cancer. Also, we found that 43% of tested patients have HIV co-infection, which is 15 times more than the national prevalence of Rwanda, peaking especially at 69% in vulval cancer. Also, regarding the staging, we found that 68% of patients presented in advanced stage, which is Vigo stage 3 and 4. Also, regarding the treatment delay, we found that patient experienced median delay of 134 days in referral to treatment. In this analysis, we only used patients who were referred with confirmed diagnosis. to avoid any diagnostic delay. We also found that there is a significant delay, especially in Western province, in comparison to Kigali city. Also, in the predictors of advanced staging, we found that the only predictor was the residence of the patient. We found that Eastern province has an odd ratio of 3.98 of presenting in late stage, which is in comparison to age, HIV, and parity. So a discussion, there is a near universal advanced stage presentation which highlight the structural gap in early screening and treatment availability. Also, the disproportionate 43% HIV co-infection demand the routine integration of screening and treatment of patient who is receiving antiretroviral therapy. Also, there is a regional timeline disparities, and profound. We found that 80% of patients were lost to follow-up, which exposed critical operational system failure requiring localized patient navigation network. As a conclusion, geographic context present, especially Eastern province, serves as the primary structural determinant of diagnosis, of late diagnosis, provoking actionable evidence to steer Rwanda 90-70-90 elimination target of cervical cancer, especially through decentralizing care networks. That's all. Thank you.
Thank you so much, Dr. Noha, to ask any questions if they have.
Hi, Nuha. Thank you very much for your presentation. It was great. I think this, even though these gynecological cancers are worldwide spread, they are still a health problem and an issue in every part of the world, especially in those developing countries, which is like very important to address. And I think your research is really important, at least for, knowing like the distribution of some determinants that may be important to address and to correct. No, so I think this is very, very good for you to let us know. I have a question, which is like, how about the HPV vaccination program? Do you have any?
Yes, in Rwanda, they started HPV vaccination program, which now is, I think, they achieved their goal, almost achieved their goal of vaccinating 90% of teenage girls, which is part of the 90-70-90 vision of Rwanda. But it started, so it's not covering the already patient that we have already. That's why.
Yes, of course, that's what I thought. I mean, maybe these patients obviously are older, they have not been vaccinated, and maybe these numbers will change in a few years. Hopefully, they do, no? Hopefully. And what you said about HIV infection, and regarding this Eastern province that you have already mentioned, do you know if this province has a very high or the distribution of HIV infection in this province? Is this something that may be related to the gynecological cancers that you have already seen?
I actually don't have the data on HIV infection in each province, but I think that's maybe a factor in these results.
Obviously, I think that's what I thought. Maybe this is a confounding, variable that may be influencing what you have already seen in your results. And it has been seen that also this location is one of the ones that has the highest prevalence. And is it because it is really far away from health services?
Unfortunately, no. It's near Kigali, but maybe because other province, maybe they have other hospitals, they can tertiary hospitals they can go to, like Butaro. I think it's in the northern province, I believe. But yeah, I think also the eastern province is the largest province, approximately, in Rwanda. Maybe that's it, but yes, that's all.
No, that's okay. It is because I just wondered that part. Thank you very much, Noah.
Thank you.
Dr. Khalifa, really a very enlightening presentation. I'm from Jamaica, and I'm a little concerned, and I was just wondering. I mean, one of the things that has happened in our country is an active campaign, and some of these services are actually free in our health clinic in terms of the screening. Our problem is usually with the men. They don't like to do the prostate, and there's a big campaign. So how is this being managed in your country? Or, is there any plan to share the data and ensure that something is actively done?
Yes, as I mentioned, the 90-70-90 vision for cervical cancer. Their vision is 90% of teenage girls will be vaccinated, 70% will undergo screening, I think, and 90% will undergo early treatment and diagnosis.
Okay, and how is drugs applied in terms of HIV? Is that offered free?
HIV, they have a high coverage HIV antiretroviral therapy clinics. I'm not sure if it's free, but they have a good insurance system. But I'm not sure if it covers the HIV treatment.
Thank you very much. I enjoyed your presentation.
Thank you.
Thank you, Dr. Nuhan. Thank you, judges, for the questions. So moving ahead, we'll be displaying the QR code on the screen. Please scan it and vote for your favorite presentation. Your votes will determine the awards which will be announced at the end of tomorrow's session. I would also like to remind our judges to fill the form given to you previously. Moving on, we have our next presenter, Jeevan Darage Vishwabhashini Vimalasena from Professor Dr. Paraskev Stoyanov, Medical University, Bulgaria. The topic is antimicrobial resistance patterns of Staphylococcus aureus in bloodstream and wound infections. You can go ahead.
Yes. So good afternoon. My name is Jiwandarike Vishwabhashini Vimalasena, and along with my co-author, Savitha Subramaniam, we are both third-year medical students at the Medical University of Varna in Varna, Bulgaria. Today, I'm pleased to present our study titled Antimicrobial Resistance Patterns of Staphylococcus aureus in Bloodstream and Wound Infections, which was conducted at the University Hospital St. Marina. To dive into a bit of background first about our study, Staphylococcus aureus is a leading cause of both bloodstream and wound infections. So rising antimicrobial resistance, particularly methicillin-resistant Staphylococcus aureus, otherwise known as MRSA, is limiting treatment options and worsening patient outcomes worldwide, because resistance can vary not only between hospitals, but also between infection sites within the same hospital. Continuous local surveillance is essential to guide empirical therapy, meaning treatment is started before the exact organism is confirmed. Our aim was therefore to compare resistance patterns of Staphylococcus aureus from bloodstream versus wound infections at the University Hospital St. Marina during 2025. To investigate this, I'll first explain the methodology we used. We conducted a retrospective cross-sectional study at the Laboratory of Microbiology at the University Hospital St. Marina. We included 235 non-duplicate Staphylococcus aureus isolates collected throughout 2025. These comprised of 75 blood culture isolates and 160 wound isolates. Antimicrobial susceptibility was determined using the disk diffusion method to UCAS guidelines. Each isolate was tested against 12 antibiotics representing multiple antimicrobial classes. These included beta-lactams, aminoglycosides, macrolides, lincosamides, fluoroquinolones, glycopeptides, oxazolidinones, and others such as tigecycline and trimethylprimsulfamethoxazole. Finally, resistance rates were calculated and compared descriptively between the two groups. Having described our methods, let's now look at the results. Penicillin resistance was by far the highest of any antibiotic tested, 68% among bloodstream isolates and 76% among wound isolates. For MRSA, identified via cefoxitin resistance, wound isolates showed a notably higher prevalence of nearly 14%, compared with just over 9% in bloodstream isolates. Interestingly, gentamicin resistance showed the opposite pattern, with 16% resistance in bloodstream isolates versus approximately 11% in wound isolates. Erythromycin and clindamycin resistance were both substantially higher among wound isolates, 40% and 38%, compared with the 28% for each antibiotic among bloodstream isolates. Ciprofloxacin and tetracycline resistance remained relatively low and broadly similar between the two groups, ranging from around 4 to 11%. Finally, all isolates from both infection sites remained fully susceptible to tigecycline, while resistance to vancomycin, teicoplanin, and linezolid remained rare, at or below 1.2%. As summarized here, these findings have several important clinical implications, which I'll discuss in the next slide. These findings carry several important messages. First, penicillin resistance is so prevalent in both infection types that this class should generally be avoided for empirical treatment. Second, the high and lincosamide resistance among wound isolates may reflect greater cumulative antibiotic exposure in that patient population. Although MRSA rates were relatively modest, they remain clinically significant because they influence directly first-line treatment decisions. Finally, the preserved susceptibility to tigecycline, vancomycin, teicoplanin, and linezolid is reassuring for the management of more difficult infections. Clinically, these findings support evidence-based empirical antibiotic selection, reinforce the importance of continuous local antimicrobial resistance surveillance, and contribute to antimicrobial stewardship strategies aimed at reducing resistance. In conclusion, bloodstream and wound isolates of Staphylococcus aureus display distinct resistant profiles, particularly for MRSA and macrolide lincosamide resistance, suggesting that empirical therapy may benefit from being tailored to the infection site rather than using a one-size-fits-all approach. Overall, these findings reinforce the importance of continuous local antimicrobial resistance surveillance to guide treatment decisions and preserve antibiotic effectiveness. Thank you very much for your attention. I'd be happy to answer any questions.
Presentation. I would request Dr. Maxine and Dr. Heba to ask questions if they have any.
Okay, thank you very much. It was a very interesting presentation and one that is really important. We know that antimicrobial resistance is a major threat. I'm sorry, I might have missed it. I'm assuming that these samples were just taken from the microbiology lab pool?
Yeah, it was a retrospective study.
Right, so was comparison done in terms of the patient demographics?
So we had 235 non-duplicate samples. So based on that, we conducted the study and saw resistance patterns in the past year of 2025.
Right, thus I'm trying to rationalize why you would have chosen blood against wound in that, and I'm not a medical doctor, but my understanding is that most of these blood infections would have started as a wound infection that was not managed and progressed.
So,
right? And then the sepsis patients, I think would have probably been patients who were more severe. Yeah, I just was trying to rationalize why you would have expected the blood to be different from the wound, and that some comparison of the demographics of your patients would have been important. The blood infections may have been your elderly patients who have been on multiple antibiotics or multiple types of infections, diabetic, etc. So it would have been good to have some discussion on demographics of the patients rather than just looking at the samples.
So we chose the bloodstream and wound isolates because These are the two most common and clinically significant infections caused by Staphylococcus aureus. And since antibiotic exposure and resistance patterns can differ depending on the site of infection, we wanted to determine whether these differences could influence empirical antibiotic treatment later on. So it was a basis of just comparing that. Okay.
Okay, so let's have the QR code displayed. I would request our audience to vote for the favorite presentation. Okay, for our final presentation for today, we have Tanushka Muralidharan from ACS Medical College and Hospital, Chennai, India. The topic is residual inflammatory risk in atherosclerotic cardiovascular disease. And we have a pre-recorded video which we'll be playing.
Greetings everyone, I'm Tanishka Muralidharan and today I'll be presenting our systematic review and meta-analysis titled Residual Inflammatory Risk in Atherosclerotic Cardiovascular Disease. Is anti-inflammatory therapy the next frontier beyond LDL reduction? Despite major advances in LDL cholesterol lowering, ASCVD remains responsible for nearly 18 million deaths annually, and many patients continue to experience recurrent cardiovascular events even after reaching guideline LDL targets. This persistent risk is driven by residual inflammation, reflected by elevated hsCRP despite optimal lipid control. Therefore, our objective was to evaluate whether anti-inflammatory therapy improves cardiovascular outcomes in patients with established ASCVD. Moving on to our methodology. We performed a systematic review and meta-analysis following the PRISMA guidelines. PubMed was searched for studies published between 2016 and 2026, evaluating anti-inflammatory therapies, primarily canakinumab and low-dose colchicine in adults with ASCVD. The main outcome was major adverse cardiovascular events, while the secondary outcomes included myocardial infarction, stroke, coronary revascularization, cardiovascular mortality, and hsCRP reduction. After screening over 1,246 records, 28 studies were included in the qualitative review, with 12 studies eligible for the meta-analysis. Our evidence base included the landmark CANTOS, COLCOT, and LODOCO-2 trials. Our findings consistently showed that reducing inflammation lowers cardiovascular risk beyond LDL reduction. In the CANTOS trial, canakinumab reduced hsCRP by 41% and recurrent cardiovascular events by 15%. Similarly, COLCOT demonstrated a 23% reduction in major adverse cardiovascular events, while LODOCO-2 reported a 31% reduction. Across all included studies, pooled analysis showed a 25% reduction in MACE with a risk ratio of 0.75. Significant reductions were also observed for myocardial infarction and coronary revascularization. Although stroke and cardiovascular mortality showed favorable trends, they were not consistently statistically significant. Importantly, heterogeneity was low, supporting the reliability of these findings. Overall, our analysis reinforces inflammation as an independent therapeutic target in ASCVD. These findings suggest that treating residual inflammatory risk should be complement rather than replace standard lipid-lowering therapy. Patients with elevated inflammatory markers such as hsCRP may derive the greatest benefit. Regarding safety, colchicine was mainly associated with mild gastrointestinal side effects, while canakinumab showed a modest increase in infections Overall, the benefit-risk profile remained favorable in appropriately selected patients. Future research should focus on improving patient selection, incorporating HSCRP into routine risk assessment, and optimizing treatment strategies. In conclusion, anti-inflammatory therapy significantly reduces recurrent cardiovascular events beyond LDL lowering, supporting inflammation as a promising therapeutic target in ASCVD. Thank you for your attention.
Okay, thank you. So I'll be requesting Dr. Tanya and Dr. Maxine to comment on this presentation.
Sorry, I'm going to just ask Dr. Tanya to lead the questions because my internet is now kind of unstable.
Yes, of course. No
Okay.
problem. Thank you very much. Well, this is very interesting. No, you know that LDL and cardiovascular diseases around the world are like the main problem related to stroke and disabilities that you may have in the population. In my country, is like very common. And this is just the way we live and the way we eat and the way we have our day-to-day life lifestyle. But I just have one question, and maybe in these studies it was mentioned if they have already addressed the presence of some variables that may be present in these patients. For example, in women with menopause, no, related to age, we know that usually with menopause, our LDL levels increase, and we are, because of the lack of estrogen, at risk, adding up this part of some cardiovascular problems. So if the age was something that was mentioned, if menopause was part of one of the variables that were studied, if hormonal replacement therapy was related to this, because usually this reduces inflammation. Exercise is really important. If those that were involved in these studies had some exercise, and which type of exercise, for example, just like walking or something with a higher energy input, and other variables like, for example, I don't know, maybe as these are very large studies, if microbiota has been related to this part of reducing inflammation in these patients. So there are a lot of questions still left, but definitely reducing inflammation reduces the risk of a lot of things, but obviously in this part of cardiovascular diseases is like a very, very important thing that we have to add to the pharmacological treatment, obviously. No, so these are my comments and questions. Thank you very much.
Okay, thank you very much for that. We'll be displaying the QR code for this now. Please vote for your most preferred presentation, and please stay with us till the end of tomorrow's session to have the winners of the award ceremony. Okay, so that concludes all of our today's presentations. Thank you so much to all our judges for joining us today and all our presenters for sharing their outstanding research work. It has truly been amazing to witness all of the medical students from around the world come together, share their research, their ideas, and your dedication is truly valued. We invite you to join us again tomorrow at 7:30 a.m. Eastern Time as we continue with another round of oral and poster presentations, followed by our award ceremony. As for the award ceremony, please join us at approximately 2:30 p.m. Eastern Time when we will be announcing the award recipients selected from both today's and tomorrow's presentations. With that, we successfully conclude the first day of WCMSR 2026, and thank you once again for making this a very memorable first day. We really appreciate the participation of everyone and have a wonderful day ahead. Good day. Thank you. Bye bye.